All right. Good morning. Good morning, everybody. We're going to learn some more pulmonary. Since I get all set up here, I got to wipe my glasses off. I'm seeing fog. And I know it's not foggy in the room. That means it's my glasses. Okay. Let me get myself situated here and then I'll clean my glasses off and then we will get started. All right. There we go. All right. Let us begin. We'll do an extra long day on Monday to make up for the morning questions this morning so that nobody loses out on anything. But anyway, what I'm going to do is train somebody here who can set up this stuff so that because we used to have another guy who used to do it. Pratik, who used to sit here. Yeah, he knew how to set everything up. That or otherwise, because Dr. Davis might stand in if something happens. That's the first time in 2 years I didn't hear any alarm at all. I don't know if I heard it or I turned it off or it didn't go off at all, but I didn't hear a thing. Anyway, I just woke up and there's light outside. I said, that's a bad sign. It's never light outside when I wake up. I said, oh, Lord. Anyway, so that's why I had to call Rit and tell everybody, okay, it's canceled because I didn't have anybody here who knew how to set up. Otherwise, Dr. Davis could have done the session. But anyway, so we got it all set up so that if that happens ever again, that's the first time in 2 years, she'll take over. And that way I can just come in and finish it. All right, let's do this, folks. Pulmonary. Yeah. Next week is off week. So we're going to do an extra long morning session. So rather than just 5-step 2, we're going to do 10-step 2. And rather than 10-step 1s, we're going to do 15-step 1s. So we're just going to make it up. Huh? Friday is the last day. Monday's the off week. It just means that you'll have access for that day. That's it. So yeah. If there's anybody who doesn't have access, we'll give them access for that day. Yeah, that's it. Just so everybody knows, nobody says, "Oh, give me back my $1.75," or whatever it is it works up to. I mean, good Lord. Yes. Oh, you mean the off week? Yeah, we'll still be doing morning sessions. Yeah, because I enjoy morning sessions. I mean, it doesn't feel like work to me, so I like doing it. I like making sure students are learning how to take a test. Yeah, so that's why I said we'll just make up for today by doing an extra long one on Monday. Yeah. All right, so let's do this. When there was no surfactant, let's take it from where we left off. Since we went through this on Friday, but I want to go through it again. So please follow along. All right, so this is when there's no surfactant. And there's a million reasons for that. Alveoli will collapse. Let me make sure. Yeah, okay. So alveoli will collapse, which leads to poor compliance, increase the work of breathing. That means the baby's going to be weak and short of breath. Well, that should sound real familiar. Oxygen, therefore, has to be given. But when you give oxygen, Mitchell, the alveoli still collapsed. Oxygen still cannot get across. That means you now have a diffusion problem. Everybody follow me so far? Diffusion problem says oxygen on the arterial side will be low, so PO2 drops. What does the baby do? Breathe faster, and therefore PCO2 drops. And if PCO2 drops, pH goes up. Everybody understand the blood gas? I don't want you to just memorize it and then tomorrow you can't tell me how we got there. You got to know how to get there again yourself. Talk it out. Don't memorize it. Talk it out. That way you know you're getting it right when they ask you. Okay? And then from low PO2, I created low energy state. There it is. Everything you want to know. But from there, I said, well, what's going to happen to pulmonary vessels? Constrict. That means pulmonary pressure and resistance rise. That means blood flow will drop. That means capital wedge pressure will drop. S2 splitting will narrow. You now create a resistance problem in the lungs. Everybody still following me? All right. Resistance problem in the lungs means it's going to affect pulmonary. That means it's going to affect S2. That means S2 is going to become louder. If you got a resistance problem, hypertrophy. Hypertrophy means thick walls, increased contractility, which then leads to diastolic dysfunction. All this is old stuff, folks. There's nothing new I'm saying here. I want to make sure you guys just know how to recreate information with the patterns you've been given. Don't always think every disease is new. Apply what you already know. All right, so hypertrophy, thick walls, diastolic dysfunction, S4, that gets louder when you inhale because we're on the right side. That means blood is going to back up, so CVP is going to rise. So you see, folks, no matter what they ask you, you can figure it out. And then if you have low flow again to the left side, that means it creates a low volume state. There it is. That means low sodium, low chloride, low potassium, low calcium, metabolic alkalosis, increased risk of calcification, increased risk of stones. That means just about whatever they ask you, you now know how to figure it out. Why they get calcification underneath their skin is not a strange question to you anymore. But now you know how they all do it. And I said, this is not just about RDS. Sounds like RDS, but it's really about ARDS. I said, no, it's not really about ARDS. Hell, it's every restricted lung disease known to man. If you can find one where I'm wrong, I'll shake your hand. Because I've checked, they're all the same. You just didn't know they were all the same because they taught it to you as details. And so you thought every disease was different. I said, nope, I see the same thing in all of them. And I was right. Answering the questions became easy because I'm not trying to rethink the disease. I just, restricted lung disease, click. Even if I don't know what the disease is, as long as I know restrictive or obstructive, I already know the answer. Folks, in pulmonary, there are only two patterns. Two I can do. Thousands of diseases I cannot do. And you can't do it either. Restrictive and obstructive, that's all you got to do. Figure out which one it is. That's why we're going through all these words so that all I need is one word. And I know what pattern they want. One. It's in the vignette, folks. Pulmonary questions are that simple. Okay? Just when somebody comes in wheezing, I say, oh, hell, that's airway. That's obstructive. I just go down and answer the question. So you guys want to read the rest of the story and all that. I don't. They ask me a question. I already know the answer. Once I figure out if it's restrictive or obstructive, I'm out. Okay? Only if they say, what disease is it? Okay, fine. Then I got to keep reading to figure out what disease it is. But if they're asking me some physiology of the disease, folks, you don't need the whole vignette for that. All I got to just figure out, is this restrictive or obstructive? Get out, click answer, and you keep moving. You already got the point. Okay? All right. So anyway, oxygen has difficult time diffusing across. Oxygen will build up, causing free radical formation. When you have all these free radicals building up, what organ are you worried about, Lillian? The brain. It's always about the brain. Don't ever forget that, folks. It sounds like it's a new answer. No, it's still about the brain. All right. In the brain, the most fragile vessels are the vessels right along the medial wall of the two lateral ventricles. Anybody remember what that was called? Avi? No, lenticule striatum is an internal capsule. All right. The germinal matrix, the number one cause of intracerebral hemorrhage in premature babies. Just so you see, it's all connected. That germinal matrix has real fragile vessels. So as soon as free radicals start flying, pierce right through the vessels, and you start bleeding. And because you're bleeding right along the midline, which fibers are right along the midline? Armando. Yeah, legs. Remember spastic diplegia. Why is that the most common cerebral palsy in America? Because the leg fibers are taken out. Everybody understand that? All right. This way you keep connecting things together is not something new because now you know how to connect things together. All right. So that's one. Number two, it damages the retina. The retinal arteries are real tiny too. So you get retinopathy of prematurity, or ROP. Retinopathy of prematurity, free radical damage. So how can you decrease the incidence of these things? By just giving them a certain vitamin, Zena. She forgot, Hannah. Vitamin E is therefore given to all premature babies in America now. That's a protocol. All right. So again, I don't want you to just memorize the protocol because you saw it in the book in the protocol, but you actually know why they started that. If you can absorb a lot of these free radicals, guess what? Decrease distance, decrease the blindness incidence too. Light must hit the retina by what age, or else you're blind for life, Zena? How long do you have to hit that retina? So up to 3 months of life. That's it. After that, the brain just shuts down the retina. No more information coming in. Doesn't matter what you do after that, they won't get vision. This is actually what took Stevie Wonder's eyes, because back then they didn't know what to do. All right. So restricted lung disease, known to man. I'm just summarizing it for you, so follow along again. This is the third or fourth time. I expect each one of you to be able to go through this if I ever ask. Okay? They have poor compliance. Now you know why. Alveoli collapse. They have trouble breathing in because you need to breathe in to pop the alveoli open. They have poor diffusion because alveoli collapse. They have increased AA gradient. The big A is alveolar, small a is arterial. So that's oxygen in alveolus minus oxygen in arterial. Well, the big A has the most of the oxygen, is hardly getting to the other side. So that's why they say large AA gradient. So anybody with a diffusion problem has a large AA gradient automatically. You should be able to visualize that now. And then there's the blood gas we just derived. PO2 is low because it's having a hard time diffusing something. The baby or anybody else starts breathing faster. So PCO2 goes low and therefore pH goes up. That's what I'm saying, folks. Talk it out so you don't just memorize these numbers and then after a while you forgot how we even got here. All right, because then you get confused on the data exam and now you can't remember, what was that blood gas again? See, that's memorization. All you gotta do is talk it out. You'll come up with the answer again. They develop a secondary perfusion problem because hypoxia constricts the pulmonary vessels. Now you know why. Low energy state from hypoxia, low volume state from pulmonary hypertension. Okay, and they all die from heart disease, right? But it's called cor pulmonale because cor pulmonale, Ida, lets me know is right side of heart failure. Because remember, 90% of heart failure is left-sided. So that's why they came up with a new term. But notice the concept is still the same. You still die of heart failure. That's what I mean by concepts and patterns don't change. They keep changing the words around, but the pattern is what you ought to try to make sure you understand, not words, because they'll change the words. Okay, so if they say heart failure, they're talking about left side of heart failure. If they say cor pulmonale, then they're talking about right side of heart failure. Okay, and if you have right side of heart failure, Michael, what's the only treatment we have for that person? Let me see if Justin can remember. He remembers that after I say Justin. Michael says what? Fluids is the only treatment for right side heart failure. So you see, because we had a lecture on heart failure, you already know how to treat all of them. I don't have to give you a new lecture about how to treat it. You already know how to treat it. Okay? So all the restricted lung diseases have right side heart failure. You already know how to treat all of them. As far as heart failure, only one thing works, fluids. Drugs don't work. Because 85% of drug keeps going to the left side because that's where 85% of blood flow goes. There's no way to force it to go to right ventricle. Any questions on restricted lung disease? Cool. Highly membrane disease. Yes, Anders. Why is it fluids for the right side of heart failure? Anybody know how to explain that? Nobody learned it. All right, Michael. No, both sides have volume problems. Yeah, feet are swollen, liver swollen, everything's swollen, but it's not that. All right, Jess? Well, let me make it easier for you. It's because when you got right side of heart failure, I cannot drown you with fluid. Left side of heart failure, any fluid I give you will drown you. Left side of heart failure, any fluid I give you piles up in the lungs. You will drown. Right side of heart failure, any fluid, excess fluid I give you just goes to your legs. No harm done. All you're doing is maximizing Frank Stalling forces, Jess. Frank Stalling forces says if you have more EDV, you have more cardiac output. Because if that blood goes in the lungs, the left side is fine. He'll take it and pump it forward. So fluids. And for the step 2, 3 people, they say take wedge pressure all the way up to 18. That's when they start getting short of breath. But beneath that number, there's no pulmonary edema, and they're doing just fine. They're getting more cardiac output because you're pumping more blood through the lungs. So fluids cannot kill you if you have right side of heart failure. Fluids can kill you if you have left side of heart failure. You understand, Rachel? You understand, Miguel? Everybody else understand? Okay, just so you understand, why is it just fluids? There it is. Keep it simple, easy to remember. Yes, sir.
So the problem was because you had the right side extended, you never got enough blood to the left side.
Yeah, you never got enough blood to the left side. So get more blood to the left side, guess what? More output. Yeah. Okay. All right, but that can only go for so long because the right side will eventually finish failing and then the person dies. But at least you make them feel better during that time. All right, complications of highly memory disease or any restricted lung disease are as follows. As compliance drops, Karina, you follow me for this. As compliance drops, the need for pressure support rises. This is how to remember that if you put somebody on a ventilator with restricted lung disease, you have to add pressure support. See? That way we don't have to read about any of them because now I know why we're always doing that. Well, there's 3 types of pressure supports, Karina. One is called continuous positive airway pressure, CPAP. That means it's blowing air through your nose into your lungs. That's continuous. What happens when you inflate a balloon that doesn't want to inflate and you keep it continuously inflated? You see a problem with that, Karina? What? It says continuous. It's going to keep it inflated. It's going to pop. Highest incidence of pneumothorax. I remember when I was a resident man, almost every room in the ICU that had a pneumothorax that had a tube in their chest. And I didn't know we were the ones causing it, but this was all we had at that time. Back in the 80s, this was the only thing that was available, and it was just popping lungs everywhere. So then somebody came up with a different one. It was called PEEP, positive and expiratory pressure. PEEP is the same thing as grunting. We all grunt. What you're doing is, rather than letting all the air come out, you blow some of it back real forcefully and alveoli open up. That means for the next breath, it comes easy now. All right, that's PEEP. But what is the problem you see if you keep forcing a balloon open that doesn't want to open? It's gonna pop. Pneumothorax, just not as high as CPAP. Okay, just so you understand. Why do we keep coming up with new techniques for this? Now we use BiPAP. BiPAP is bi-level positive airway pressure, Ashley. That means you can decide when you want pressure to be applied. For restricted lung disease, do you want pressure applied during inspiration or expiration? Only during inspiration. Everybody clear about that? So this way you take the pressure off during expiration. And now the balloon is not constantly open. Lowest incidence of pneumothorax. I mean, I'm telling you, back in the 80s, every room had a chest tube. Now, again, I noticed patterns, but back then I sure didn't understand it. So why does everybody got a chest tube in? Everybody's got pneumothorax. I didn't understand that CPAP was just inflating balloons and keeping them constantly open. And the balloon is already stiff. It doesn't want to be open. It's going to pop eventually. Any questions? All right, now they say before you put somebody on a ventilator, because we know if you put on a ventilator, you're going to have to use one of these. They say try doing non-invasive. So it's called non-invasive positive pressure ventilation. NIPPV is now the standard, folks. There's a lot of questions now I'm seeing on UWorld testing. Make sure you know that. So when somebody requires ventilation, we used to just put them on the tube and put them on the ventilator. Now they say, no, try this first, because you put it with a mask. The benefit of that, not only that you can still give BiPAP through it, but you avoid ventilator-associated pneumonia. Remember, germs live in there. Yeah, especially like Legionella, water is going through there. Well, guess what? We transmit infections too, okay? So you cut down the number of pulmonary infections due to pneumonia. They call them VAP, ventilator-associated pneumonia, if you use non-invasive. So watch out now. I've seen a lot of questions. I was about to pick ventilator. I said, ooh, and okay, that's right. And I switched, and that was the right answer. Had I picked a ventilator, I would have gotten wrong. Just so you guys know, it's switching, but it's a good switch based on what I'm seeing. The literature says that is the best way to keep, ventilate somebody who doesn't need to be on ventilator long term, Because somebody who collapses, you don't know, maybe they need a ventilator 1 or 2 days. Well, you don't want to put them on a ventilator and then run into other problems. Now they get pneumonia by the second day. Okay, now they got to stay on a ventilator for another 7 days. All right, so you see, folks, over time, we was chasing our own tails, and we didn't know. All right, as diffusion decreases, the need for oxygen increases, right? Because you got this fibrosis or membrane in front of you. Diffusion decreases, you got to give more oxygen. More oxygen means more free radicals. More free radicals means more damage. More damage means more membrane. More membrane means less diffusion. Everybody see the vicious cycle? And that's why 60% of these babies used to die on a ventilator. Die because their lungs were so heavy with this membrane. It was so thick that even a ventilator could not push their lungs up. So if the ventilator can't move for you, you can see the baby's not going to move it either. And that's why they would just die on a ventilator. 6 out of 10. And prematurity still remains the #1 cause of death in the first month of life. Neonatal mortality rate, still based on prematurity. Well, somebody came up with a jet ventilator. They said, what if we strap a jet engine to a ventilator? What difference would that make? Well, let's see. If you walk into a room, someone at a jet ventilator, all you it's going so fast. Also, I hear the whole time. Before you could hear, not in here. With a jet ventilator, all you is breathing for you 250 breaths per minute. It's breathing at a rate that you and I can never establish. 250 breaths per minute. So what are you really doing? Here's the net result. I'm really just pushing in 10 molecules of oxygen. I'm just giving you a number. 10 molecules in there. In a fraction of a second, suck 9 of them right back out. 10 in, 9 out. 10 in, 9 out. 10 in, 9 out. So what am I really doing? Single file of oxygen molecules just walking in there like this. That's it. What are you doing? Avoiding free radical formation. So without free radical damage, less membrane, less diffusion, and mortality dropped 30%. It went from 60 to 40. So when you see that mortality rate in the literature, it sounds, oh my God, that's high. Well, it is high, but it used to be 60. At least we got it down to 40% now. Okay, but they'll ask you how jet ventilator works. The books always say decreases barotrauma. That's what they're talking about, free radical damage against the membrane. And that means less of highly membrane production. Somebody decide, hey, you know, if jet ventilator works for RDS, why don't we use it for ARDS? That's the same disease in adults. So let's talk about that. ARDS is just the adult form. However, the problem here on them is that you've got increase in permeability of the pulmonary vessels, allowing fluid and proteins to leak out and wash away your surfactant. See, now you're back to the same place as RDS, no surfactant. But they love to ask, what is the underlying problem? It's not no surfactant. Surfactant was there, but it got washed away. So it's increase in leaking or increased permeability, however they want to say it. That's what caused no surfactant. Everybody understand the difference? Permeability is not the same thing as lack of surfactant. Lack of surfactant is RDS. That's why there's collapse. But at ARDS, there's collapse is secondary. That means you have leaky vessel, fluid and proteins leak out, wash away the surfactant, and then they collapse. I know. Sepsis is the #1 cause of ARDS, and trauma is #2. Any questions on that? So somebody came up with the idea of using jet ventilator for ARDS. What I found amazing was who actually came up with the idea. It was not the pulmonologist who did the first study on RDS. You know who came up with the idea? The respiratory tech, who's not a pulmonologist. He made the connection. And then they did the study, and he was right. It should work on them too. So guess what? Then he realized it should work on any, you can use on any severe restricted lung disease. See, that's connections. Versus you got to wait till people have a bunch of other diseases to see if it works on them too. No, you can make the connection for yourself and be way ahead of the curve. Okay, so the tech saved more lives than the pulmonologist who's supposed to know all this stuff. Okay, all right, so remember that, ARDS. Jet ventilator works for them just like it works for any restricted lung disease. So anytime somebody has restricted lung disease, you want to use, again, this positive pressure. We know they're all going to need it, but BiPAP is the safest. Everybody follow me? And if you think they're only going to be on ventilator for a couple of days, NIPPV is better. Also avoids pneumonia on top of the problem. Okay? And then if the disease becomes real severe, severe sarcoid, severe histo, whatever it is, then use jet ventilator. Any questions on that? Another thing you can use is that the lungs are so badly damaged and you want to give the lungs a break. Let them heal up and not have to work for you for a while. Then we use something called ECMO. Extracorporeal membrane oxygenation. What that means on them is that rather than let your lungs oxygenate for you, we have a tub over here that'll oxygenate for you. I mean, but that means we got to hook up a tube to your aorta and a tube to your inferior vena cava. That means the blood is not going through your lungs anymore. It's going through this tub over here. It allows your lungs to rest up. So in ECMO, there's two types. VA, that means a vein is attached to an artery, or VV, a vein is attached to a vein. When do you need either? Well, for your lungs, I want to attach an artery to a vein. I want to attach an aorta to the vein so it bypasses the lung. So VA is when I want to rest your lungs completely. VV says I want to bypass an entire tissue or organ. So I attach one vein to another vein, so it never went through the tissue at all. It just comes right back up to that machine, okay, and bypasses that tissue. So if you got like liver failure and we want to rest your liver, or GI failure and we want to rest your GI, you can. So VA is the most commonly used because you can attach an artery to a vein, and that way you bypass the tissue altogether. All right. That's just extra information for you guys because I didn't used to talk about that till this time. All right, so anyway, complications of doing what we just said we're about to do, Angie. More pressure support can lead to pneumothorax. Now you know how and why and which one has the highest incidence. This is where you're not guessing, okay? So what happens when you get a pneumothorax? You got air outside the lungs compressing your lungs. If I compress your lungs, Cesar, it then compresses your heart. It's the same physiology as a tamponade. And that's why, remember tamponade? Kussmaul sign, no surprise. Tamponade, remember? Pulsus paradoxicus. So you got to remember what they were, though, because they'll describe it. They're not going to just say the word. Kussmaul sign, increased JVD on inspiration. Pulsus paradoxicus, exaggerated drop in pulse or blood pressure with inspiration. It means there's hardly any blood coming in on the right side. That's all it means, physiology. Loss of pulse and blood pressure, then you become cyanotic because no blood has moved through your lungs in a while. And then Hammond sign is when the pneumothorax is so large, I can actually feel bubbles underneath your skin. I press on your skin, I feel crunch, 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 crunch. They'll call it subcutaneous, they'll say crepitus, air bubbles, Hammond sign, evidence of a large pneumothorax. Let's look at pneumothoraces. There's two types, spontaneous and traumatic. Why are spontaneous pneumothoraces so common in women, Josh? Most relaxation due to what, Josh? Thank you. Let's just say estrogen connection. Come on, baby. That's how it's done. See? So look at my hand. Muscles are relaxing. What are they doing? Yeah, I feel like opening up for no reason, and one day they pop. Spontaneous pneumothorax is so common in women that whenever they get chest pain, sudden chest pain, PE is number one. Spontaneous pneumothorax is number two. MI is way down the list. It's not MI. They pop blebs all the time. What about the tall, thin male? Who the heck is that guy, Gloria? Who? Yeah, Klinefelter, who has an extra X, so he has extra estrogen. See that? Same physiology. So you're not just memorizing. Don't memorize, folks. Connect it to something you already understand. And therefore, if they come up with some strange disease, as long as you see the same thing happening, you say, yeah, why not? Instead of thinking you got to be sure of everything. Okay? All right, some hands up here. Oh, my videos.
Excuse me, I can't see you. Okay.
You want to see me, Mabel?
Yes.
Oh,
I can
okay,
see you
no
now.
problem. No problem. It just goes out from time to time. All right, Abdullah Khan, you have a question?
Yeah, a little while ago when you were talking about the jet ventilator when it's used in ARDS, can it also be used for antitrypsin deficiency?
It can be used for anything with restricted lung disease physiology, sir, including alpha-1 antitrypsin deficiency.
And the other thing I wanted to ask was the ECMO, the venous one. Can that be used for like compartment syndrome? to save the limb?
Let me see. Yeah, from one vein to another vein. Let me see. If you go from a vein to a vein, what you're doing is stopping from even going up to the heart. Yeah, you can use that for compartment syndrome. So, or we use it primarily for when there's heart disease and you want to rest the heart for a while. Then let the machine do all the pumping and the oxygenating.
Okay, thank you.
Follow? Yeah, but at least now you're starting to see it. All right, so spontaneous pneumothorax, again, women, and is this all estrogen connection, folks? Tall, thin male is Marfan's and Klinefelters, but they have weak alveoli too, so they're overinflated. Trauma is number one, stab wound, rib fracture, gunshot wound. Kind of explains itself, so that's easy. If you get stabbed on the left side of your chest, that's a bad day because your heart is on that side. Number one cause of death is tamponade, followed by pneumothorax, then hemothorax, in that order. So that means when they say, what's the next step of your management, is based on tamponade is going to kill them first. You better take care of that. Remember, what's going to kill your patient first is what they expect you to be managing when they say, what's the next step of your management? All right? You get stabbed on the right side of your chest, lucky day, relatively, that is. So now your heart's protected on the left side. It's just pneumothorax followed by hemothorax. At least tamponade is off the list. If you have an asymptomatic pneumothorax, that's usually a female who popped a bleb. And when it's when it's less than 25% occupation, this is a number that they want you to know. So less than 25% of the pleural cavity is occupied by that air bubble. The answer is do nothing. So we see it lots of times when you do an x-ray on a female for something else, and the radiologist says, oh, she's got a spontaneous pneumothorax of 17%, which means 17% of the pleural cavity is occupied. Then you know, under 25, do nothing, because she didn't even come in for that. But if the person is symptomatic at any level, or is more than 25% occupation, you have to put in a chest tube. Just know you know criteria. But what about this needle thoracostomy? If it's more than 25% occupation and you now have what we call tension pneumothorax, you have to put a needle in there first. Needle thoracostomy is for the patient I just described, the one who has all this stuff. No pulse, no blood pressure, he's cyanotic, he can see Kussmaul, pulse period. It means blood is not moving. Why? Because you have positive pressure in the thoracic cavity. Remember you learned last week. If you don't have negative pressure in this thorax, blood and air cannot move in there. Well, a pneumothorax puts positive pressure in there. That's it. Blood and air start moving. That's why the person temporarily dies. Then you do something. Okay? So when they have a tension pneumothorax, what do? Put a needle in their chest. It's called needle thoracostomy. Where do you put the needle? It's usually an anatomy question. They're going to ask you that. But they expect every doctor to know how to do these. That's why I'm going to explain it to you. Needle thoracostomy. Put a needle in the second intercostal space, mid-clavicular line. How do I remember that? Because air rises straight to the top. Your lung, the apex is right there in the mid-clavicular line. So there'll be a pocket of air sitting right at the top. As soon as you put the needle in there, you hear the air escapes. All of a sudden, pulse comes right back. That's because you've taken the pressure off the lung and the heart. Question, Cynthia. Question about pneumothorax is? No, you get Kussmaul sign with, so she's asking, do I get Kussmaul sign with a pneumothorax on the left side only? No, either one. But obviously it occurs faster with one on the left side than one on the right side. No, the other way, sorry. One on the right side, because you're pressing on IVC and superior vena cava. That means blood cannot enter the heart. Yep. Yeah, but either side can do it. So needle thoracostomy, again, anatomically, second intercostal space, mid-clavicular line. You'll hear the air escape, pulse and blood pressure come back, and then you do the chest tube. What do I put in the chest tube? Fourth or fifth intercostal space, but now it's mid-axillary line. These questions are usually anatomical. They want to make sure you know how to do it, because every doctor is supposed to know how to save a patient's life with a pneumothorax. Fourth or fifth intercostal space, and then you angle the tube upward, because remember, the air is still up in the second intercostal space. How do we get all the way down to fourth or fifth? Because when they start out the first or second, you got an intern who's got to do learn how to do the procedure, he's got a scalpel in his knife. That's dangerous. What happened? Axillary artery and axillary nerve right up there. They got sliced. People died. So we stopped doing that. Then we went to third or fourth, and you still angle upward to the first or second spot. That's what we've been doing for the last 20 years. Well, somebody did a retrospective, said, okay, we still killed too many people when you got an intern who still doesn't know what he's doing yet, and still killed a few people. So we said, okay, let's go down to fourth or fifth. That's where we are now. But just so you know, we worked our way down over time. Okay, it's based on physician error. All right, so fourth or fifth for pneumo, for hemo, blood settles. So you put it down one more, fifth or sixth, and then face it downward. Josh. What is the acceptable level of patient death? Yeah, what you do is, there's no acceptable level. What you do is compare it to another group of patients who are hospitalized, but who didn't have this, and see what their death rate were. Whatever that number is, if you got a number way lower than that, then that means their procedure is what's killing them. Yeah, so you always got to have a control group to compare it to. All right, so chest tube placement, fourth or fifth intercostal space, angle upward. I'm going to talk it through for you. Just visualize this with me. Don't try to write down every word because you're not going to catch every word I say. We say, let's say Mr. Johnson. I say, Mr. Johnson, I say, put your arms over this table. Why am I doing that? Because I want to maximally open up his lungs. And the best way to do it is have your arms out like this. That way it opens up the sides, okay? Now, I pick my spot, I clean it, I numb it with some lidocaine, I'm ready. I say, okay, Mr. Johnson, take some deep breaths. I let him take some deep breaths. Why? I want him to be hyperventilated to decrease his respiratory drive because I'm about to have him hold his breath for about a good 60 seconds. And you can't have somebody who have a strong drive and you're trying to let them hold their breath for 6 seconds. It ain't gonna happen, okay? So you wait till they take maybe 6, 7, 8 breaths. You say, okay, hold it. This is on inspiration. If you say hold it, guess what? I'm gonna need this. The lung and chest wall are together. When you say hold it, they're like this, okay? That means you tell me inhale, hold it. They're right next to each other because I wanna know where the lung is my left hand, the chest wall is my right hand. I wanna know that they're right together. Then I'm gonna say, okay, exhale, but only for half a second. Exhale, hold it. See what I've done? Only the lung has moved. Chest wall is still standing still. That way now I know this lung is far away because I'm about to come in here with a knife. You don't want the lung sitting right next there. You just slice his lung open. There he's got a bigger pneumothorax. So for half a second, you say exhale, and then the lung moves away before the chest wall even moves. You hold it right there. Now you take your scalpel, cut that space. So let's say here's a space. I've just cut it. See that? I put in my chest tube like this and angle upward like that because I want to get up there to that second space where the air is. And you just see air start escaping. The other side, you put it into a bottle of water. That's called a water seal. Why? Because air can get into water, but air cannot come through water back through that tube. So you created a one-way valve, which is nice. Because as soon as you put it into the bubble, that's just bubbles coming out. That's air escaping. Now you have a visual on whether the air is coming out or not. I like that one. The other one is wall suction. You put it into a tube in a wall, and you hear this. See, that thing is sucking air out of their chest. Okay, but you don't really know if it's getting anything or not getting anything. I like water. That way, as soon as I walk in the room, I see bubbles. That means the air's still coming out. And I walk in there a few hours later, oh, no more bubbles. I said, okay, maybe it's all gone now. Any questions on how to put in a tube? Now, after you put in that tube, remember, I've got the tube in here like this, but I still got a hole right here. So what you do is take gauze, put a bunch of Vaseline on it. Air cannot get through Vaseline. Right here like that, see that? And then you sew that gauze to his skin and take the suture around the tube. So now both things are permanently right there on the chest. And then he can breathe all he wants on him. Is there an increase in waterborne infection because of the tube? I mean, nah. Because the bottle is so far away from his chest, we don't see it. Okay, now, how do I get this tube out of his chest? So let's say I walk in later on that evening and I see no bubbling. All right? And I say, hey, I wonder if all the air is gone. So when you have somebody on chest tube, we usually check on them right before lunch, right after lunch, and then at the end of the day. Because if you want to get the tube out, here's how we do it. You walk in there, you don't see any bubbling. First thing you do, put a clamp across the chest tube. I want to see if no more air will collect. I put the clamp and then wait 2 hours. Come back. If you unclamp it and you see bubbling, that means that pneumothorax is not finished sealing up yet. Everybody understand that so far? If I come back 2 hours later, unclamp it, nothing comes out, the hole is sealed. You can pull it out. And the way you pull it out is the same way we put it in. Take a deep breath, sir. Hold it. See? Now, this is a chest tube here, and it's sealed between my two hands. See that? And then I'm going to say, inhale, hold it. That way he's got to smash like this. And then pull it out like that. See that? Because he's done breathing in. So no more air can go in. And that's why you just pull it out and then, sew up the skin after he exhales. Any questions on that? All right. That's first scenario, if everything goes well. After you put in a chest tube, we always do a chest x-ray to make sure that tube is in the right spot. Okay? Now, what if things don't go right? Scenario number 2. I walk in that room hours later. It doesn't take long for air to escape, folks. Remember, air goes high pressure to low pressure immediately. So let's say I put it in at 7 a.m. I come back at 11 a.m. and I still see bubbling as if I just put the tube in. Anytime you see bubbling hours later, as if you just put the tube in, that person has a hole in his cartilage. And cartilage is avascular. It does not seal up on its own. They need surgery. So that's, let me see, what's the word? Oh, bronchial tear or bronchial rupture, like stab wounds, gunshot wounds. It went right through the cartilage. It's not going to heal up. That's why every breath he takes, air just comes out with every breath. And that's why it's still bubbling like you just put that tube in. He needs surgery. Any questions on that? All right. So that's pneumothorax. They expect everybody to know how to take care of somebody, save their life for this. As free radicals traumatize the airway, Bailey, we're going to phase 2. The airway starts to produce mucus to protect itself. By producing mucus, Bailey, airway will thicken. Goblet cells will undergo hyperplasia. What does that mean? They multiply in numbers. That's because now your lungs say, I need more mucus. Okay, well, here's more goblet cells then. That means the airway will lumen because it's full of mucus. And that way you have increased read index. Let's look at what that is. So here's the airway, like this. Here's the wall of your airway. I'm just putting a dashed line. The space occupied by goblet cells divided by the total wall thickness equals read index. So as what fraction of the wall is occupied by goblet cells? It's usually somewhere between 0.2 and 0.3. But all of a sudden it goes up to 0.4, 0.5, 0.6, 0.7. That means almost the whole wall has been occupied by goblet cells. That's too many. That's how you know you got an airway problem now. So read index is either increased or normal. There's no decreased read index because you always have a baseline number of goblet cells. But what you're developing now is an airway disease that we call bronchopulmonary dysplasia. This is the first obstructive lung disease. However, Bailey, it turns out that every obstructive lung disease has the exact same profile. Oh, I love this, folks. Look at this. Obstructive lung disease, have trouble breathing out. Restricted, have trouble breathing in. All you gotta do is look at your patient. You can tell what kind of disease they have. All right, problem with ventilation. Rather than restricted, which has diffusion and perfusion. I never said those two words. I never said ventilation when I was talking about restricted. Okay? That means if they mention, this is what I mean by all you need is one word and you already know the profile. You should get the answer right. You don't even have to know what disease they're talking about, but you can still get it right. Okay? Look at the blood gas. If you're not ventilating, the PO2 can be normal or low, depends on when you catch them. When they have severe bronchospasm, that's it, PO2 is low. But most of the time, spasm will then break, PO2 is back to normal. That's why they say normal or low. But definitely your clue is PCO2 is high. If you're not ventilating, the CO2 is not leaving. And CO2 is an acid, so pH is low. Look at that, totally opposite blood gas than what I gave you for restrictive. Again, it's only if you understand it, folks, then you actually pay attention when they give you the blood gas. One word gives you the answer. The blood gas gives you the answer. But that's only if you understand the physiology behind it. Because as you know, you've seen these questions many times. But because you wanted to know exactly what disease it was, then you missed the question. Now realize you don't need to know what disease it is. You just need to know restrictive or obstructive to answer the majority of pulmonary questions. Just letting you know in a secret. That's why it gives you the clue almost every time. Every time I look at it, I see it. It's there. Obviously, before Dr. Shah, I didn't see a thing, man. I just saw somebody wheezing. I wonder why they're wheezing. And I was off just like every other student trying to figure out what disease they're talking about. All right, so anyway, too much airway mucus, like I just said. Airway thickening, like I just said. Gallus hyperplasia, like I just said. Increased read index, like I just said. And the most common cause of death now is called bronchiectasis, which means digestion of your alveoli, Anders. You can't breathe without alveoli. You understand, Anders? You understand, Saba? You understand, Naif? You understand, Gloria? How about you now? You understand? You understand, Saba? All right. You understand, Maria? I think so. Well, you didn't say yeah, so that means I got to sweeten up the deal then. All right, so let me put something else on top of this. Here it is. Folks, it turns out, Maria, that bacteria love your airway. Why? Because they feed off of food. You and I aspirate food into our airway all the time. Everybody understand that? So bacteria, if they like your airways, that can be restrictive or obstructive. Obstructive, trouble breathing in or out. Trouble breathing, no, stop that. Trouble breathing out. Trouble ventilation or diffusion? Ventilation is going to be increased or decreased? Decreased. You're not blowing it off. That's decreased ventilation. And therefore the PCO2 will be high. pH will be low. Read index will be high. Tell me one thing I'll see when I look in the airway for a bacteria. Thick airway, increased mucus, increased read index, all the same thing you just heard. What's the most common cause of death for bacterial pneumonia? Bronchiectasis. What about if it's Staph aureus pneumonia? Staph aureus pneumonia, most common cause of death is what? Bronchiectasis. Klebsiella pneumonia. Bronchial E. coli pneumonia. Bronchial aspiration pneumonia. Bronchial actinomyces pneumonia. You can open up any book you want. Check if I'm wrong. It'll blow you away. It's always been the same thing. You guys just didn't pick it up because it was never taught to you. It was never taught to you. This is what I mean, folks. Pulmonary, I rack up a ton of points. I don't even know what the hell disease they're even talking about. I just see one word, obstructive. I answer the question. I don't have to care what bacteria they're talking about. It's always the same answer. I mean, one rare one I'll miss. Let it go. See, you start worrying about this one rare pneumonia that does something different. I'm telling you, there's always an exception. That's what I'm saying. Stop worrying about the exceptions. When they're less than 10%, I'm not worried. I'll take a 90 plus on anybody's exam. Okay, that way you've done well on the exam. Versus you keep worrying about these exceptions and then you can't even hit 62%. That's because you're worried too much about the exception. That's what costs you the exam. Anna. If you got bacterial pneumonia, the most common cause of death is still going to be the key. The key is pneumonia. That means in the lungs. Sepsis is going to be different. Yeah, sepsis is different. So every bacterial pneumonia, bronchiectasis. End of story. That answer's never been wrong. Okay? But everything else is non-bacterial. Justin. Everything else is non-bacterial. They like to live in interstitium. Why? That's where the oxygen is. They need that oxygen for replication. So for anything non-bacterial, you're going to put it interstitium or airway. Interstitium. Is that restrictive or obstructive then? No. Again, make sure you're paying attention to this profile. Okay? Airway is obstructive. She just did obstructive. Anybody else in interstitium is restrictive. Everybody understand? All you need is one word clue. The minute I say interstitium, I just made it restrictive. That means you should know the rest of the profile after that. Everybody else understand that? All they need to give you is one word, folks, but you got to study these words because it's worth 1,000 points. You got to know it cold. Because I don't know which word they're going to give you, but I see it when I look at a question, and you can see it too. That's only if you know it well. All right? So what I'm saying here, Justin, is that anything non-bacterial, I'm going to say restrictive. Everybody follow me? That means that I don't care if it's virus, fungus, protozoa, cardiovascular disease, cancer, I could care less. I'm picking the same answer all the time. See? So that means if you got pneumocystis jirovecii infection in an AIDS patient, CD4 count of 127. Is that going to be interstitial or airway? Gustavo. Interstitial, restrictive or obstructive? Restrictive, trouble breathing in or out? Trouble breathing in. So the PO2 will be what? Low respiratory rate? High, PCO2. Low, pH. High. So if the PO2 is low, pulmonary vessels are going to constrict or dilate. No, oxygen dilates pulmonary vessels. Hypoxia constricts it. So pulmonary pressure will do what in pneumocystis? Increase pulmonary resistance will do what? Increase pulmonary blood flow will do what? Decrease pulmonary capillary wedge pressure will do what? Decrease. Is this going to create a resistance or volume problem? Resistance is going to affect S1 or S2? No, there's no S1 in pulmonary. All right, now everybody, hope you guys are studying these profiles. Okay, don't ever mix them up. You're not going to get any points. You may get 1 point out of 100. I'm not interested in 1%. I want to pick up over 90%, just thinking the same thing all the time. But notice that way for pneumocystis, what do? I say all the same stuff. That means that most common cause of death, cor pulmonale. I'm not changing my mind for anybody. It's the same answer. That way I don't have to look up a virus, adenovirus, RSV. Otherwise, when you don't know that, you think you got to go read 10 more chapters to get ready for an exam. And I'm saying, no, just know your profiles. That covers a ton of ground, and you never have to look it up. Why? Because you're right over 90% of the time. Nothing's right 100% of the time. So please don't expect that. But if I can get over 90% without worrying about it, I'll take it. Okay? All right, so that's obstructive lung disease profile. I always like to start with RDS. Why? Because RDS starts off restrictive and then morphs into an obstructive lung disease. That way I cover both profiles with one disease. Now you know the profile, or hopefully you will study these profiles and know it well. Steve, question.
So both restricted and obstructed have increased respiratory rate?
Both restricted and obstructed have increased respiratory rate, right? Because they're both tachypneic and dyspneic. They both have weakness, shortness of breath. Nothing changes.
But then how come increased respiratory rate of obstructive gives you hypercapnia?
Why is it only the obstructive gives you hypercapnia? It means increased PCO2. Karina will explain to you. Wait a minute, I think you said it backwards. Yeah, obstructive has poor ventilation. So even though they're breathing fast, CO2 is not getting out. That's why their CO2 is up. Because they have an airway problem. There's mucus in their way, can't get the carbon dioxide out. Restrictive don't have an airway problem. So with every breath, CO2 is leaving. That's why they have respiratory alkalosis. Okay. Obstructive. Any questions? You understand it, Karen?
Yeah. Yeah. So you said that both have increased respiratory rate.
They both have increased respiratory rate because everything in the lung makes you breathe faster. Right? Doesn't matter if you have an airway problem, interstitial problem, you're going to breathe faster. Because if your PCO2 is up, your brain says breathe faster, you can blow up the CO2, even though you can't. If your PO2 is low, your brain says, hey, could you breathe faster? We need more oxygen. Either way, you're getting the same signals. You understand, Ryan?
Yes, yes.
You understand, Acid? All right, we move on. Every lung disease presents with the same signs and symptoms, folks. There it is. Every lung disease. You hear what I just said? That's what I'm saying. You don't have to look this stuff up anymore. They're all tachypneic dyspneic. They're all weak and short of breath. That's why is when you get the blood gas, then you know which one it is. Why do you think as soon as they come to emergency, we get a blood gas? See, that's management. Rather than just memorizing, that's what we do. You now know why we do it. Because only the blood gas can start to separate it from airway or interstitial for you. Okay? Can it really be this easy? Yeah. All right, so amylin food production. You've heard this 3 times now, I think. One more time. Since the lung is involved, I thought, let's just do it again. Please listen, because you got to be able to tell this story and come up with the information again. The mom supplies 90% of the amniotic fluid. However, the baby swallows away 10%. His brain has to tell him to do so. His autonomics got to work. His esophagus got to be open, and the muscles got to work as well. And the upper GI has to be open. So that means if the baby cannot swallow, are you going to have too much or too little, Gloria? Too much. And that word is polyhydramnios. Polyhydramnios is when you got more than 24. Remember, we use 8 to 24 now. More than 2,400 cc's per quadrant. If you have polyhydramnios, you have 2 big complications. Adnan, give me one. Sandeep, give me one. Potters is oligo. I'm on a poly. Nave, give me one. Uterine rupture is the worst, but that's a distant number 2. What was number 1, Jess? Yeah, preterm labor, because you're distending the uterus with fluid. It's not baby, but the uterine wall doesn't know that. Once you get to a certain stretch, boom, labor begins. Preterm labor happens 90% of the time. Uterine rupture is very rare, but it's so devastating when it happens. And I explained it to you. Sudden gush of blood everywhere. Her vitals crash. And when you examine her uterus, you can feel the head popped out. They usually hint at it by telling you the station just changed. The baby was -2, all of a sudden, boom, +1. That means he popped back up. Okay? Anna. No, that's not the turtle. Turtle sign has to do with the delivery process. We'll talk about that tomorrow. All right, so that's 80%. To subtract, I just gave you the 5 things that you have to do to subtract. 20, the baby takes his 10%, adds another 10%, and then pees into the sac. In order to add, he has to be able to urinate. So if you cannot urinate, you're not able to add. Is that going to give you too much or too little, Miguel? If the baby cannot pee, you cannot add. Is it going to give you too much or too little? What? Too little. What's the word for that? Oligohydramnios. So amniotic fluid less than 800 cc's per quadrant. All right, role of amniotic fluid. Remember, shock absorption was number 1. Number 2 was to absorb atmospheric pressure away from the baby. For what reason? To allow the alveoli to inflate. You cannot inflate a balloon into positive pressure. If there's negative pressure, then it'll inflate. So polyhydramnios, your differential. Again, you've seen this before. Just reminding you how to put it together, and you'll see there's only one answer on the list. That's what I see. But I always go through the 5 areas and look on the list, only 1. That's how you know test writers is congratulating the students organized. The students not organized just memorize a long list of stuff with no rhyme or reason or understanding of how they came up with that list. That means you can't duplicate it day to day. All right, so neurological defect. They can go down to be a vitamin. I say, what vitamin are they looking for? No, not E. B. B9, folate, brain. Then make sure you connect. All right, autonomic dysfunction, remember Raleigh Day. Neuromuscular disease, Wording Hoffman. All right, upper GI atresia, esophageal atresia, and duodenal atresia. What's the clue for esophageal atresia? Gloria. Esophageal atresia, Anders. Drooling since he was born. He can't swallow his own spit. All right, and remember when you put on a nasogastric tube, curls and comes right back up at you. That means there's a tube there. You do your water-thin contrast, gastrographin, and you see a pocket. How come that pocket is there, Karis? What failed to happen? Apoptosis didn't happen. What gene controls that? P53. What protein helps out? Big D. And what's his label? Phosphatidylserine and the Hitman. Caspase. Everybody should know this should be an old song, okay? Again, repetitions to help you. Don't be writing stuff down again. All right, do it in the atresia. Give me a clue, Steve. Yeah, double bubble sign on X-ray. Bilious vomiting. Remember, bile gets dumped to the second part of duodenum. So bilious vomiting 30 to 40 minutes after the first feeding because food can't even get past the membrane. And again, apoptosis didn't happen. And then hypothyroidism is because without thyroid, nothing works out, right? All right, oligohydramnios, something's wrong with the kidney system. Number 1, the renal agenesis, you don't have it. And that's metanephros, right? Metanephros. Then develop, or the uretary bud failed to make contact with it. Still won't get any kidneys. Or there's an obstruction in the bladder, posterior urethral valves. Or they'll call it a persistence of urogenital membrane. That's what actually causes the valve to be back there. But it's in the back of the urethra, so that's why it's posterior urethral. So that means when urine tries to go out, it hits this membrane and won't go out. For that reason, the most common cause of abdominal mass in a newborn is what, Ashley? Not neuroblastoma, Halima. All right, Josh. Most common cause of abdominal mass in a newborn is what? Now let me ask Leslie.
Enlarged bladder.
An enlarged bladder. That's how common posterior urethral valve is. enlarged bladder. It's after the newborn period, actually, then it's neuroblastoma. So watch out for this one, okay? So oligohydramnios, what's the main complication for that, Angie? Potter sequence. So without enough amniotic fluid, your lungs will not inflate. If they will not inflate, the baby comes out and he dies shortly thereafter. So what do we do? If I see oligohydramnios, now anytime after 24 weeks, what are you supposed to do on them? Oligohydramnios, after 24 weeks, what are you supposed to do? No, not Salumetrol. Karina will help you on this one. Immediate C-section. Remember I told you that baby's being smashed by a rock. There's no need to hold off till tomorrow. We do it immediately. And remember, after 24, you got a 50-50 chance based on today's technology of saving that baby's life. Whereas before, 100% died. 100%. There was no way to save any of them. Okay, just so you know, why are we saying immediate? Because at least you have a chance to save half of them. All right, so that's oligo. Potter syndrome or Potter sequence. So when oligohydramnios leads to pressure effect on the fetus, everything is flattened. His face, his chest, his lungs, everything. Okay? Prune belly syndrome. You see, nice picture there. The baby's belly looks like a prune. Is lack of smooth muscle in the abdominal wall. Has mesenchyme, mesoderm, connective tissue. So the mesoderm did not crawl into the abdominal wall, so there's no muscle there, so he can bear down and pee. So if you cannot bear down and pee, guess what? You got the exact same problem. You're going to end up with a Potters because you cannot pee. That means you cannot unload. So that baby's going to have a big bladder when he's born. Same problem. Well, this happens if you have a neurogenic problem. That means the nerve to your bladder doesn't work. What's the most common cause of peripheral neuropathy, period, in America? Leslie.
Diabetes.
Diabetes. So diabetes is number one cause of neurogenic bladder. So the nerve doesn't work. They're pushing, hardly anything comes out. So what do we do for prune belly or the person with neurogenic bladder? We teach them how to put a catheter in there. So for mom, we teach her how to cath this baby every 4 hours. Most people urinate every 4 hours. And if you're sticking a foreign body into somebody's urethra every day, Halima, what's the most common cause of death now? What's that? All right, Jess? Infection, UTIs. What's the top bacteria, Jess? E. coli followed by? Proteus followed by? Klebsiella, they say nitrite negative. Enterococcus postcoital. Saprophyticus, they want virus. Adenovirus. All right. For neurogenic bladder, for diabetic, remember I told you if it's early, you can use a medication to help them out. What's the medication that we talked about for early neurogenic bladder? Maria, do you remember the name of the drug? Early neurogenic bladder. There's a drug you use to treat them. Let me ask Abdullah Khan. Abdullah, do you know them? Was that?
I'm not sure. I think it was like.
All right, Jolita, do you know the name of the drug?
Can't remember.
All right, Akuna?
Is it Bethalacan?
Close enough, girl.
Okay.
I'm happy to hear something that sounds like what I want. So, Bethanacol and carbachol were the two I gave you. Early neurogenic bladder. So, to avoid catheter, give them treatment for like 1 or 2 years. I mean, hey, if you push off UTIs for 2 years, who wouldn't want that? Okay, but then after the nerve dies, nothing you can do about it. You got a cath. All right, very good. All right, any questions on prune belly or Potters? Next one then. How long do they live? Oh no, they live probably their teens maybe. Yeah, well, some of them will die early though, because you know when mom's got to put the catheter in, if you got a mother gets frustrated, she does it the wrong way and puts germs in there. Yeah, not much you can do, but they can live into their teens. It's important to have negative pressure in the thoracic cavity. Hopefully I've impressed you with that, because if you don't have negative vacuum in your chest, air and blood can't move in there. You understand that, Solange? You understand that, Meha? You understand that, Hannah? You got to have a vacuum in your chest. Air and blood cannot move into positive pressure. So diaphragmatic hernia is another problem to worry about. The diaphragm forms in everybody from ventral or dorsal. That means from the front, spins around to the back, dorsal. Okay? It turns out the left side is weaker than the right side. So for that reason, 90% of diaphragmatic hernias are on the left side. How do you recognize it? Well, if you got a really good ultrasonographer in utero, we can see it. But most of the time, we find out after they're born. After they're born, all of a sudden you hear bowel sounds in the chest. That's not supposed to be there. Bach to leg defect, B for back. Because remember, you spin from the front to the back. The hole is going to be in the back if you pull out a baby prematurely. So it makes sense. And I already said 90% are going to be on the left because the left is weaker. Morgagni, M for midline, means after you already formed it, it then ripped. And that would be rare. Bowel sounds in the chest is how we detect most of them. You must repair surgically right after birth. Why? You're hoping, Josh, that this happened late in development so that only part of the lung got collapsed by the intestines. Because if it happened early and the lung is completely collapsed, that baby's going to die after you deliver him. But you're hoping to save a few by getting the intestines off that lung and letting it reinflate. We use a little positive pressure to inflate it. Because that's the only chance that baby has. If not, they die. Josh. If I hear bowel sounds in the chest of an elderly individual, still a diaphragmatic hernia. It happens as late in trauma. Like if they were in a car accident, they say, I'm okay. About 2 days later, all of a sudden now they get severe chest pain and they can barely breathe. There's usually delayed rupture of the diaphragm after severe trauma. Yeah. Car accidents, I've seen several of those. All right, so diaphragmatic hernia is nice picture. Remember, we saw that in one of the morning questions. You see all of a sudden that right side there is all popped up to the middle now. Anatomy of the lungs. All right, this is just for you to look at, just so you get a visual. All the way to alveoli, where oxygen exchange will actually occur. All right, let's talk about them. There's extrathoracic airway. Extrathoracic means outside of the thorax. That means not protected by the rib cage. Extrathoracic airway, from the lips to your glottis, is extrathoracic, okay? It narrows when you inhale. That's why you hear noise, because it's collapsing when you inhale. It expands when you exhale. That's why you don't hear any noises. So you got to know the movement with each breathing cycle. Extrathoracic narrows when you inhale, expands when you exhale. This is why when somebody's breathing too fast, you know, a child who's really scared about something to happen, and they breathing fast, you can hear that. That's called stridor. That means you're collapsing your own extrathoracic airway. You're making it even harder for yourself to breathe. And so that's why we say, okay, slow, deep breaths, slow, deep breaths. You're trying to slow them down because they don't realize the faster and harder you breathe, actually the less you're ventilating yourself. Okay? So that's extrathoracic airway. And an intrathoracic airway from the glottis to the alveoli. So the glottis is a dividing line. From the glottis down to alveolus, expands when you inhale, narrows when you exhale. So the opposite. For that reason, it means when a person makes a noise when they inhale on them, where's it likely coming from? Intro or extrathoracic airway? Which one? Yeah, extrathoracic. If you make a noise when you inhale, extrathoracic airway. Make a noise when you exhale, intrathoracic airway. A noise when you inhale, we call it stridor. A noise when you exhale, we call it wheezing. And they both mean the same thing, narrowing of the airway. Just where is that narrowing? Your intrathoracic airway has a vacuum around it. And that's why when you inhale, it opens up wide. Even if there's a narrowing, I wouldn't hear it. So wheezing on exhalation is expected. Does everybody understand that? Okay. But there was a big article back in the 80s. The title was, All That Wheezes Is Not Asthma. Why? Because every pediatrician, every kid that wheezes, they were calling it asthma. There's a million reasons for wheezing. And so they were just going through the physiology. Wheezing just means intrathoracic airway is narrow, not that you have asthma. Okay? like foreign body. Children inhale foreign bodies all the time. Doctors were missing it because they were saying, oh, asthma. So the foreign body just stayed there for weeks. Yes. Stridor is extrathoracic airway noise. Yeah, slow, deep breaths. And then the airway will. No, wheezing, you have to treat him because that's intrathoracic airway. You got to give him a beta agonist or figure out if there's a foreign body down there. All right, that's intra and extrathoracic airway. Now, another way to divide this is dead space and alveolar space. Dead space is from your lip to the terminal bronchioles. Dead space. Why do we call it dead? Because no oxygen exchange can occur. From your lip to the terminal bronchioles, dead space. No oxygen exchange can occur in those areas. Zero. And then the rest of it is called alveolar space. Now, that's why I gave you the picture. I mean, if you can study it for yourself, but the areas that can exchange oxygen, one is called a respiratory bronchial. That means the bronchial that goes into the alveolus. Respiratory bronchial. Then the piece that goes into the alveolus itself is called the alveolar duct. Just renaming that little piece. And then alveolus itself. That's called alveolar space. One more time. Alveolar space. That means exchange of oxygen can only occur in these three areas. Respiratory bronchial. Alveolar duct. And the alveolus itself. That's the only three places that can exchange oxygen. One cell layer of thickness. That's it. Remember, oxygen is diffusion dependent. You put anything in his way, he can't get across. So those three areas have just one thin layer of cells. That's it. There's no cartilage, okay, in the way. That's how to know there's no cartilage down there, because that cartilage would be in the way. You'd have a diffusion problem. So dead space ventilation plus alveolar ventilation equals total ventilation. Does that make sense to you, Cynthia? Cynthia says, okay. You got to go through the dead space to get to alveolar space. Everybody understand that? So that's why they say dead space ventilation plus alveolar ventilation equals total ventilation. But the one that affects your oxygenation is alveolar ventilation. Dead space does not. Everybody understand that? You understand that, Cynthia? So the reason why I wanted you to understand that is because there's a difference between breathing and ventilating. The ventilation we're interested in is alveolar ventilation. You can breathe through your dead space and you're still not ventilating. And that's a huge difference. I remember one of my senior residents, his name was Gino. He was trained by Dr. Shah too. The guy was sharp. I remember we were on call together in Peds and he said, Francis, don't ever call the attending for asthma, a child with asthma or an adult with COPD until you get a blood gas back. So why is that? He said, because the first thing the attendant's going to ask you is the patient ventilating well or not? And if you don't know the difference, it's so easy to say, yeah, he's breathing fine. You're fired tomorrow because you don't know the difference. You can be breathing fine and die right in front of me. That means I don't know the difference because the person can be ventilating, but it's all dead space, but they're not ventilating. How do I know that? The blood gas. That's how you know. That's why I said, don't call him until you get the blood gas. Because if you say, he says, how's the patient ventilating? I said, well, his blood gas was nearly 65 when he came in. Now it's 32. Everybody understand that? That means he's blowing off CO2. That means alveolar space is working. Okay. What if I take a shallow breath, Mitchell? Are you sacrificing dead space ventilation or sacrificing alveolar ventilation? Alveolar. Because if you need a column this big, take a shallow breath. Do you see where it's going? You're pulling it out of the alveolar space. See, you're still breathing here, but you're not ventilating here. So nobody get the two mixed up. Just like in obstructive lung disease. They're tachypnic, but the question you asked me, see that? But they're not ventilating. That's why their PCO2 is high, even though they're breathing real fast. Question, sir?
When you talk about blood gases,
Yeah, blood gas always means arterial blood gas. Yeah, always. Yep. All right, so now, trachea. The trachea is in the midline. Let's go through the whole airway now. Your trachea has 16 to 20 C-shaped cartilage rings with the opening to the C facing posteriorly. All right, let me show you what that means. Here's the letter C. Let's zoom in a little bit. Okay, here's the letter C, letter C. What you're gonna do is face it backwards like this. So that means it's facing backwards. That's because right behind it is your esophagus. That way, when you swallow, you collapse your own trachea. See that? That's what prevents aspiration. Otherwise, we'd all aspirate everything that we eat. But even with this working perfectly, we still aspirate small amounts. But in case you're asked why the opening to the C always faces posteriorly, because the esophagus back there, when you swallow a bolus, will collapse your trachea for you to keep you from aspirating. Any questions on that? All right. You have 3 anatomical narrowings in your esophagus, sorry, your trachea. It's very important to know, Amy. One is the glottis. The glottis is the most narrow. Then the midway, and it's caused by the aortic arch going across the anterior surface. So it might make that an anatomy question. And then the carina is where one big trachea bifurcates into 2 mainstem bronchi. Why do you want to know about these 3 places? That's where foreign bodies get stuck. Where's the biggest foreign body going to get stuck, Karis? No, not the carina. Ashley? The glottis is the most narrow space. It's going to have to cross there first. So most narrow is where most things get stuck. Everybody understand? I remember we had that one morning question, the kid who swallowed aspirated a coin. Where was it? Right up here? Right to the carina. All right? So when you got a foreign body, you do an x-ray, you got to know, look right up there in the midline, go, look at those 3 places, you'll see your foreign body. Okay? So the glottis is where most things get stuck. So that means if your glottis is closed off, Michael, if your glottis is closed off, that means air cannot move into your airway and also can't move outside your airway. You understand that, Halima? So the quickest way to assess whether somebody's glottis is open or whether somebody's trachea is open, that's what they'll ask you. What is the best way to assess patency of your trachea? You know, when somebody's down on the ground, I want to know, is his airway working? Okay, because if his airway working, then great. I don't have to do anything. But if his airway is not open, I got to do something. Everybody follow me? The best way to assess it is to have him make a noise. That's why we say, sir, are you okay? Are you okay? All they do, even a grunt tells me his airway is open. You can't make a noise if your trachea is closed off. Okay? So the quickest way to assess patency of the trachea is usually the question, is to have the person make a noise. Sir, ma'am, are you okay? If they don't say anything, we do one more thing. You take the knuckle of your middle finger, rub the sternum. That hurts like crazy. There it is. Trachea is open. That's all I want to know. It means I don't have to worry about your airway. Your airway is open. Because as long as the trachea is open, you can use one of the lungs. The other lung can be collapsed for all I care. You can breathe through the other one. That means you're going to be fine till the paramedics get here. Yes, sir. Yeah, that's what the sternal rub is for. It's trying to get them to make any kind of noise. Any kind of noise says your trachea is open. Well, yeah. I mean, if they're making a noise, they're not coming with those because it means the signal went up to the cortex and they responded. Yeah, that means they're not coming with those. All right. So, any questions on checking patency of the trachea? All right. Aspiration. That's when things don't go right. We can aspirate easily. Well, we all aspirate small amounts as it is. But if things don't go right, then you're going to aspirate even more. So the question they like to give you is a stroke patient. Well, you got to know the brain's not working. Then you can't protect your airway very well. All right. If the patient is unable to speak, then the object is lodged in the trachea. Large objects tend to lodge at the glottis 90% of the time. So we always check that first. You perform the Heimlich maneuver. So Heimlich maneuver is for objects, large objects that's lodged in your trachea. Anybody ever seen Dr. Heimlich before? Dr. Heimlich, man, this is a real geeky looking guy, man. But he is, genius what he came up with. I have incredible respect for this man. So here's how he came up with it. All right. Let me see, zoom out a little bit here. All right. Here was his whole premise. He said, when you breathe in, okay, your diaphragm sits like this. When you breathe in, your diaphragm comes down and then comes around to the back like that. Everybody watch that? When you breathe out, it comes back to the middle and then cups up like that. That means even after you breathe out, folks, there's 2 pockets of air sitting up here at the top. See that? My hand is holding 2 pockets of air at the top of your lungs, full of air. What if I could push that air through your trachea for you? That means if there's something up here in the glottis, there's a propulsive force coming around it, boom, push it right out. Amazing, simple, but incredible thinking to me. That all you gotta do is just push, and whatever it is, flies right out. Heimlich maneuver. Everybody's supposed to know how to do it. Take the thumb of your offhand. I'm right-handed, so I take my left hand. Put that thumb right at the xiphoid process. That means you're under the 2 pockets. Then you take your other hand and grab the other 4 fingers, wrap around the person's chest like that, and push straight up. When you push straight up like that, all the air goes right through the trachea, and a piece of meat comes flying out. Any questions? And you can find a xiphoid process on anybody. Now, that's easy landmark to find, okay? But let's say you call me a couple of years from now, Dr. Francis, I don't know about this Heimlich you taught us. This guy is 450 pounds. I can't get my hands around him. All right, then don't get your hands around him. What you do is ask for help. You ask somebody to help you. You lift the guy up. You take a chair, usually one with a straight back. And when you go to restaurants, it's usually straight back, right? Yeah, you just have him, you lift him and just put his chest right, xiphoid, right where the back of the chair. And all you guys got to do is push on his back, and you get the exact same thing. And piece of meat goes flying out. He said, doggone it, Dr. Francis, I don't know, I got a 2-year-old. If I put my hands around him, I'm going to kill him. I said, well, don't put your hands around him then. All right? No, we don't do that. 2 years and above, 2 years and below, we don't do Heimlich. What you do is called a back thrust. You lay that baby head down on your thigh. His chest will wrap around your thigh exactly the way we want. And all you got to do is take the heel of your hand and hit the middle of his chest, and you get the exact same propulsive force. Head down means piece of meat will come flying out. That's how you save a life one day.
When do you have to stabilize?
The stabilize in the hand is for newborns. Yeah, for newborns, because they're so tiny, you can't even put them on your thigh. You just hold them on your hand like this, and you do the same thing on the back with 2 fingers. All right? Any questions on that? If you're alone and choking, use the back of a chair. Yeah, before you pass out, because you're going to pass out. All right? So, yeah, she brings up a good point. If you're by yourself, nobody around, you're going to die if you don't do something for yourself, right? You get to a chair as quickly as you can and use the back of that chair. Just go down like that. And then hope that piece of meat comes flying out before you pass out, because that only a certain amount of time you will pass out. Okay? All right, so now let me teach you about the Good Samaritan Act. Good Samaritan law was passed many years ago to take all liability away from physicians for helping other people. Because they knew that doctors would be afraid to help people because they thought you'd get sued if you did something wrong. So they took all liability away. The law says if you perform a procedure that you've been trained to perform in the process of helping saving somebody's life, even if the outcome is adverse, you cannot be held liable. Why? The patient would have died if you did nothing. Everybody follow me? And that was very wise of them, because otherwise the person would have died. So let the doctor take a chance and try to do something to save the person's life. But if I got to worry about getting sued, then I'm going to be, oh, I don't know if I want to do that. And then boom, take off. And the person will just die right there. Yes. No, if you've been trained, you can do it. You don't need an ambulance driver's permission. No, if you say I've been trained, they trust your word. If they want to, they can call your residency and say, do your residents get trained in this procedure? But that's rare. I've never seen them or heard of them calling any residency to verify. Yeah, that's why I like doing the chest tube. I had to teach you. Pericardiocentesis, I taught you because I expect every doctor to know how to do this to save a life in an emergency. Okay. So if you perform a procedure you've been trained to do, even if the outcome is adverse, you cannot be held liable. But part two says, you only do procedures that you've been trained to do. If you've never been trained to do it, don't try it. Everybody understand? You can't say, because I stayed at Holiday Inn Express last night and watched some video on craniotomies, you know what, I'm going to do a craniotomy today. No, you were never trained to do craniotomies. You ain't about to do it today either. Everybody understand? Okay? Number three, if you're not in your right mind, don't attempt it. Meaning if you're drunk, if you're at a bar and somebody starts dying because of some reason and You've already had a few drinks. Don't do it. Because now they can turn around and sue you and say it's because you were drunk. That's why they died. The family will sue you, not him. Okay, but don't do it. All right. Next, you cannot accept any form of remuneration, which is the word they use, but that just means payment. You cannot accept any payment for what you just done. Everybody understand that? From the person or anybody related to him. That's what the law says. But I always tell students, just don't take any form of payment at all. You don't know who's related to who. All right? Because there's been times a doctor helps somebody at a restaurant. What the managers always do, can I pay for your meal for you? That's payment. And then you find out he's related to the guy that just went to the hospital. You're in trouble. You're in trouble because you accepted payment. Next, if you accept any form of payment, folks, you just sign a contract to be that patient's doctor. You have to follow the ambulance to the hospital where they're taking them to fulfill your duty as his doctor. That's what the law says, okay? Which means if the doctor accepts payment by getting free dinner, and then he didn't follow the ambulance to the hospital, see, that's one of these surprise lawsuits. You know, lawyers, I remember they used to call lawyers ambulance chasers because they would see how doctors didn't know this law very well. And so it was easy lawsuit. You're going to lose. Because if they find out you accepted payment and then you didn't go, that's called abandonment. You abandon your own patient. You can be sued now. Okay? Everybody understand that? Yes, sir. What if their mama invites you to dinner? Oh, the mama was out with them? No. You're always allowed to accept food and cards, cookies, cakes. Yeah, that's not considered payment. Yeah, it's got to be something of monetary value. Airlines, yes. Frequent flyer miles. Yes. You're not supposed to accept. You're not supposed. You don't accept upgrade either. That's payment. That's payment. The key is I always tell students just say no because I don't want to have to try to figure out who's related to who and then and get blindsided by a lawsuit. And then you find out they were related somehow, and now there's no way for you to erase it because you're in trouble. Okay. Last part of the law says this: if you do not try to help somebody in a time of trouble like that, then you can be sued for that. Yes. That's part of Hippocratic oath. You put your arms up and you say, hey, I am willing to put other people's lives before mine. The lawyers remind you signed a contract that says you're going to try to help other people in times of trouble, and yet you drove right by. Did you know if you pass a crash and you're a doctor and the crash just happened, you're supposed to stop and see if you can help somebody? This happened to me one time. I was heading to Chicago. I got on 57. I had that accelerator mash the ground while I was blowing dust flying around. I mean, I was like, yeah, should be in an hour and a half. No problem. I got this. And just when I got barely to Market Street, all of a sudden I saw a little Toyota behind me. They hit something that was trying to run across the street. And all of a sudden they, boom, 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 they rolled over 3 times. I'm like, oh, damn. Okay. You know, so I hit my brakes and back it up. Luckily, there were 3 ladies in there. Yeah, 2 in the front, 1 in the back. And I looked at them and said, ladies, is everybody okay? Oh, good. I ain't got to do nothing. I heard 3 That's all I want to hear. That means everybody's airway is just fine. And remember, you don't want to move anybody. So it's best just leave them right there in the car. I could hear the siren. Paramedics were already on their way. You know, 2 hospitals 5 minutes away. So they were already on their way. As a doctor, I'm supposed to stay there till paramedics get there. Once I get on the phone with the ER physician, that ER physician has now accepted responsibility. I can now drive off. That's the law. Because I remember when I was a resident, I remember one attendant gave me terrible advice. He said, if you're on vacation with your wife, he said, make sure you don't tell the hotel you're a doctor, because if somebody starts choking, all that, they'll come get you to come save a life. I'm like, man, obviously he didn't read the last part of the law. If you don't try to help somebody, they can go back and sue you for it. Because you had a chance to save a life and you just ducked out of the hotel, you're in trouble now. Okay, so that's what I'm saying, folks. Better know the rules yourself so you don't have some attending influence you to do the wrong thing because he's been doing the wrong thing. You don't want to be the one that gets caught for it. Okay. So anyway, that's how you do it. Yes. 2 questions. Does this apply to medical students? Yes. Only if you've been trained to do it. Now, I learned this when I was a medical student about this Good Samaritan law. When I did that, when I learned it, I said, oh man, I remember, I think it was Gino or another person saying, run to every code. You know why he said run to every code? Because when you get there, as the first one to get the code, you get to do all the procedures. That means even if you screw up, you cannot be sued. See that? Most residents don't get that information. Gino, I think, is the one that passed on to me. He said, man, go to every code. That way you can do every procedure. Even if you screw up, they can't sue you for it. Because the guy would have died if you didn't try something. Because it's an unwritten rule. Whoever gets there first, you get to intubate them, put in a chest tube, put in an art line, do whatever needs to be done. You get first dibs on it. So, man, I was running to every code I could, boy, so I cut somebody. I'm telling you, man. In an emergency situation, I call it the hero moment. Oh, but don't tell me to cut somebody in a normal, sane moment. I can't do it. I told you, no, nurse, please. Turn on the fan. Turn up the fan, man. It's hot in here. I can't do it. But hero moment, bang, get out of my way. Hey, I'll tend to the patient. Call 911. And then you go right there and just start doing whatever you got to do. Because that way I know I cannot be sued even if I mess everything up. Patient would have died anyway. Okay? But that's how you get all the practice you need. I mean, there were times they wake me up out of REM, man. I'm like, ooh, I got to get there fast. And because I sleep like this with my pillow, my arm underneath the pillow. This arm was asleep. I'm like, come on, man, you got to wake up. We got to go. I mean, this arm was behind me, flapping in the wind. I'm trying, come on, man, you better wake up. Because I can't even do CPR because this arm is asleep. I'm like, come on, wake up. We got to get there fast. I'm trying to get there so I can be the first one to get all the procedures done. I loved it. And then I did 2 weeks in trauma surgery. That's another one. You get to do every procedure right in the ER. I loved it. Those are the moments where I love it every moment of it. And then when I went up to NICU, you get to do every procedure on the babies too. Now, if you can do procedures on the babies like 1,500 grams, 20, man, come on. You can hit any adult with your eyes closed. I mean, NICU was the best place because by that time I'd done most procedures. But when I get to NICU and I had to do on babies this tiny, oh man, if you can hit a little tiny vessel on a baby, the vein of an adult is like a big tunnel. I'm serious. It's relative. You don't realize your eye. You can see the vein. Really? Oh, yeah. Nothing to it at all. Anyway, that's just to encourage you guys. Don't run away from codes. Run to as many codes as you can because you get there first, you get to do a bunch of stuff and you get to learn how to do it. Okay, that way, one day when you actually have to put a chest tube in somebody's ICU and the attending says, who's going to put a chest? And you say, I can do it. I've done 3 of them already. So he's impressed that you already know how to do it. All right, put in an art line, put in an IV line, all that. All right, so that's for large objects. Back to us already talked about. If still unable to dislodge the object, let's say the guy slumps over. Remember I told you only have a certain amount of time before you pass out. If the person passes out, then you do an emergent cricothyroidotomy. That means you find the Adam's apple. Obviously, it's harder on a female to find a larynx, but you can find it. And then slide right down. There's the wings of, I don't know what the name of that bone is. Anybody know what that is? The one with the wings? Hyoid? That's called hyoid? Yeah. You can feel the wings on it. There's an empty spot right here. There's number cartilage. There's 2 vessels at the far ends, the middle avascular. That's why you feel these come right here with your needle, right in here. You're in the middle. You didn't touch any vessels at all, but now you have an airway. Okay? Cricothyroidotomy. You get in there and they say use a straw that's wrapped in paper or in plastic. That's as sterile as you're going to get. This is how you establish an airway in a restaurant if you happen to be the doctor there. Okay? And put it right in there. You now have an airway till the paramedics get there. Person's life is saved. All right? It's a beautiful moment, folks, when you can save somebody else's life. I've had students in an airplane, like you were talking about. When the airplane is going down, you need a steak knife because it has a sharp point. Because what you're going to do is use wine as anesthesia. Remember, that's what we used to use in the past. We looking all strange. And they put a little wine on there. That's anesthetic. And then you apply even pressure right in that middle. See here till you feel a give. You're now in the trachea. Then you put the straw in there. If you happen to be at 35,000 feet, the plane cannot land in 20 minutes. The patient's going to be brain dead. So what do? You do the same thing. Get a bottle of wine, right? They sell them on the plane, $4, and they do appreciate exact change. So if you don't have exact change, yeah, I'm a quarter short. Anybody got a quarter? Anybody got a quarter? I need a quarter. Nobody got a quarter in this damn? Hey, first class. Anybody got a quarter over there? I mean, I was just playing. But anyway, you buy the wine. That's anesthesia again. Put it on their neck. Take a knife. Oh, wait a minute. We're not allowed to carry knives on the planes no more. No. That's steward, what do they call them now? Not steward or stewardess. Airline, what do they call it? Airline attendants. One of them's packing. All right, one of them's got a knife. I'm telling you right now, they're packing. Okay, so you say, I need a knife. And you take the wine, pour it on the tip, that's anesthesia again, and poke it right through. And then you hit the top of the ceiling. Remember, there's plastic tubing up there for the mask. That's sterile. So the tube will fall down. You now have sterile tubing, put it right in that hole. You save their life till the plane can land. I had one of my students do that shortly after she was here for a program, and then she told me she was flying or whatever, and then all of a sudden that happened to somebody, and she was the reason the guy was still alive. Okay, but they offered her all kinds of frequent flyer miles. She remembered, turn it down, because you don't know who's related to this guy. Yeah, but it saved the person's life. All right, that's aspiration. Small objects tend to lodge in the right lower lobe. Small objects will fall straight down and go to the right lower lobe. Why the right lower lobe? Cynthia wants to know. That's because it's a larger, and it's straighter. So gravity will pull things straight down there. If you remember, the left goes off on a 90-degree angle. I mean, how's gravity going to do that? So the right mainstem bronchus is wider and straighter than the left. So small objects tend to lodge in the right lower lobe. So anybody who has recurrent right lower lobe pneumonia, they always tell you, you got a foreign body to deal with. You got to go down there and take a look. And you need bronchoscopy. You go down there, take a look, and pull it out with the same procedure. There's the 3 most common objects that get lodged. Peanuts. This happens a lot in ballparks, as you can tell. Popcorn. Ballparks again. But you know what it is, mom and dad could be eating popcorn at home. A kernel of popcorn falls to the carpet. They don't bend over and pick it up. But then you got a 6 to 9 month old who's crawling around. He's going to pick that sucker up, put it right in his throat. He has no teeth. He's just going to aspirate it right down. Okay, that's how he became number 2. And then pieces of hot dogs. A lot of parents have a habit of giving those little Vienna sausages to their babies for teething. That's when you're poor, you find a way around it, right? A teething ring may be $3 or $4, but if you're poor in the hood, $3 or $4 is a lot of money. So what they do, little Vienna sausages. It was like a nickel when I was growing up, a nickel. And it had like 6 little sausages in there. You put them in the freezer. When your child's drooling all over the place, he's teething. You put it in his hand. They would do that. That would numb the gum. Teething, taken care of. That's when you cannot afford Ambisol and all the other things that are those are even more expensive. All right, but anyway, that's how hot dogs became number 3. Because one day they actually gum a little piece off of there, and they don't have teeth in yet, and they will just aspirate it. Okay. And then finally, dust particles. Dust particles are the tiniest particles, but what they do is divide them into 3 levels: large, medium, and small. Greater than 20 micrometers, large. They get trapped in the mucus in your upper airway, which makes sense because every time you open up your mouth, the wind blows a whole lot of particles into your lungs, but it never make it down to the bottom. Why? Because the mucus traps them. And that's why every now and then, Nolan, what do? You do that. You know what that is? When we do that, all you're doing is popping up the mucus with the debris into your esophagus. That's because when you pull it down to your stomach, stomach acid kills everything. Okay? So, larger objects, mucus. Between 2 and 20 micrometers, cleared by ciliary action. That means it fell down even further to the airway. The cilia would then push it upward, and then the mucus would take it up the rest of the way. And then if it's less than 2 micrometers, the tiniest particles, that's in just about macrophages. And when macrophages ingest this stuff, then they go into the interstitium. This is why anytime you have dust particles, it becomes an interstitial disease. By dust particles, I'm talking about the pneumoconioses, like silicosis, anthracosis. Those are all tiny particles. That's why they all cause interstitial disease, because the macrophages, when they engulf this stuff, they go into the interstitium. Now they're creating a diffusional problem for oxygen. What if they ask you, what's the most beneficial protection for your airway? Cilia. You have cilia all the way down to the terminal bronchioles, so that if anything goes all the way down, yeah, cilia will just bring it back up for you. So if they just say most common or most important, cilia is the answer. But if they tell you what size the dust particle is, now you know how to figure it out. Any questions so far? Evaluation for aspiration. It's called inspiratory expiratory film. We ask you, Halima, take a deep breath in. All the lobes are inflating. Then I say, well, okay, take a deep breath out. I take another x-ray, and I'll notice one lobe never collapsed. That's where your peanut is stuck. Everybody understand? Just only takes a few minutes. And you can diagnose which lobe it is, and then you bronch them and go down and pull that peanut out of there. Now, when something's right along the midline on them, you use what we call rigid bronchoscopy. When it's out to the periphery, you're gonna have to turn some corners, flexible bronchoscopy. Now, only on step 2 and 3 do they want you to know the difference. Step 1 just needs no bronchoscopy. Yes. No, most piece cases is still here in the trachea, but you can see that on the x-ray. Yeah. Yeah, I had one little girl, she aspirated a penny and it got stuck in her glottis. She was still able to talk. That means the penny was just kind of flapping up like that. And so she can still talk, but we had to get it out of there. When you do the x-ray, you can see exactly where it was. So we bronched her, pulled the penny out, and I gave it to Mom. I said, Mom, this is the most expensive penny you'll ever own. I said, because we had to bronch them. That's, anesthesia, pulmonologist, ER visit. That's almost $10,000 for that penny. So it's amazing. Airway anatomical divisions. I gave you a preview already. Dead space goes from your lip to your terminal bronchioles. It cannot exchange oxygen, so we call it dead space. Then the respiratory unit were those other 3 places, which was the respiratory bronchiole, the alveolar duct, the piece that goes into the alveolus, and then alveolus itself. So respiratory unit or alveolar unit is made up of 3 pieces. Right? That's just an anatomy question. Well, you have dead space ventilation that precedes alveolar ventilation because you have to go through the dead space to get to the alveolar space. You understand that, Anders? You understand, Saba? All right. If you take a shallow breath, you're sacrificing alveolar ventilation, always. All right. And in total ventilation, they made an equation out of it. VD plus VL. It just means that's when you add them together, that's total ventilation. All right. So total ventilation again. Now we're going to put some numbers on it. Dead space plus alveolar ventilation. And then you can see, well, how much air do you move in 1 minute? That's called minute ventilation. That means your total tidal volume, that means the column that you need, times respiratory rate. So, Maria, minute ventilation, your tidal volume, let's say it's 400 cc's, and you're breathing 20 breaths per minute. What's your minute ventilation? What is that? It's 8,000. That's the same thing as 8 liters of air moved per minute. Everybody understand? They'll give you the tidal volume, give you respiratory rate, you figure out the minute ventilation for anybody. But what they'll do is further tell you how much is in the dead space, and you figure out what the alveolar ventilation is. You just subtract. So Saba, I got somebody who's tidal volume 500 cc's, and dead space ventilation is 40%. You follow me? Respiratory rate is 10. What's the alveolar ventilation? %40 of 5,000 is what? What's the 40% of 5,000? What's the number? 2,000. Then the remainder is the alveolar ventilation. That means 3,000 is alveolar ventilation. Yeah, so they'll give you all the information you need to figure it out. But either they'll ask you for total, or they'll give you enough information for the total, but tell you what percentage goes to one space and ask you how much goes to the other space. Okay? They're easy if you know the equations. And so I'm giving it to you now so that you understand. This is one equation you got to know. Tidal volume for anybody is calculated now at 6 to 8 cc's per kilogram. They want you to calculate it. Don't put in just some number you got in your training as a resident. That's what, as a resident, they told me put in 500 for everybody. And I saw they do that in so many residencies, just 400 for everybody, 600 for everybody. I say, well, why is everybody the same number? That didn't make any sense to me, but I couldn't get a resident who could explain it to me. He said, we always put in 500. The problem is, what if the person needs 600? Anna, what problem do you see? You're underventilating them. How's that going to affect their PO2? O2 without getting the oxygen to the alveolus. Now, you said it right the first time, but you guessed for the second one. No, I said O2. You got it right the first question. That means you understood it. So now apply the same thing for the second one. I said oh hell, I forgot what I said. All right, so 60, yeah. If somebody needs 600, you only give them 500. That means you're shy of 100. But that's alveolar ventilation. Remember, the end of the tidal volume is the alveolar ventilation. We just went through that a minute ago. Anytime you give somebody a shallow breath, you're sacrificing alveolar ventilation, folks. There should be no guessing. It's always the same answer. You're sacrificing alveolar ventilation. Okay, so that means whatever you didn't give them, you're not blowing up the balloons. That means you're doing the same thing. You're breathing for them, but they're not ventilating. So that's why now there's so many questions where you have to calculate it. Because they want to make sure you become a resident who knows how to calculate. Don't just put in 500, because they know that's what residents are going to tell you when you get up there. Yeah, just put in 500. No, don't just put in 500. Calculate it. However, if you got restricted lung disease, as you see here, we go on the lower end, like the jet ventilator. We now know if you got restricted lung disease, the best way to ventilate you need pressure support. BiPAP is the best one. You need a high rate, high oxygen, and now you know tidal volume should be low, but a very high rate, like the jet ventilator. That's what decreased their mortality by 30%. High rate, low volume does better to ventilate somebody with restricted lung disease with minimal trauma. Any questions on that? All right. So there's anatomy of the lungs again. Just remind you, please study this picture so you can visualize all these things. All right, but that's just anatomy. Histology. Let's do histology before we take our break here. We got pneumocytes. There's type 1s and type 2s. Type 1s make up 95% of your pneumocytes, and type 2s are 5%. That's of pneumocytes. Type 1s are mostly macrophages, phagocytes. They're found throughout the airway, but the majority are found in the terminal bronchial. How do I remember that? If you look at the anatomy of your lung, particles will float all the way down and then drop at the terminal bronchial. That's how to remember why smallest particles, i.e. cigarette smoke. Why do you think lung cancer starts there? See, I saw that connection. So, oh, that's why they're always saying that. I never knew until I studied and put the name with the physiology. Now I can see it. All right. So terminal bronchial is where the smallest particles will fall. Okay. That's why it makes sense to have the macrophages there to gobble it up, clean out the airway. The only role that type 1s have in the alveolus, because alveolus dominated by type 2s. The only role type 1s play in the alveolus is to help oxygen get across. Remember, he's diffusion dependent, so it makes sense he needs somebody's help. And that's type 1 pneumocytes. Will carry oxygen across. Type 2s don't do that. Type 2s, most of them are in the alveolus. Makes sense because they produce surfactant. And that's where you need the surfactants, the alveolus. Makes sense, Amy? All right. Remember, type 2s can revert back to being type 1s if you need to clean out the alveolus in any way, or if you need to regenerate the alveolus in any way. So how do I summarize it for students? If there's a question about the alveolus, if it's about oxygen across, I pick type 1s. Anything else, I'm picking type 2s. Make it simple so you don't have to overthink it. Okay? This is a question, and I see alveolus in that vignette. I already know. If it's about oxygen across, I pick type 1s. If it's anything else, just pick type 2s all the time. Okay? But if it's the airway, pick type 1s all the time. When it comes to pneumocytes, that's how I organize it. Again, over 95% accurate, I'll take it. I'll just be wrong a few times. Eric Bouchard, you have a question?
Is it important, Dr. Francis, to know the mechanism that type 1 uses for allowing O2 across, or is that just diffusion?
Yeah, it's just mostly diffusion. Yeah, I've never seen him ask any new mechanism. Yeah, good question. Anna. Is this why macrophages carry the most amount of what? Ferritin? Yeah, just not here in the lungs, unless you got heart failure and blood is just in there. then the macrophages are carrying ferritin. But throughout the body too, macrophages carry ferritin because they're the ones destroying the red blood cells in the spleen. So they're carrying the ferritin around with them, and they take it back to the bone marrow. Will carrying a ferritin help diffusion? Not that I know of. I mean, ferritin is just iron itself. It's just a storage form. They'll have hemoglobin and the ferritin in the macrophages only if you have heart failure. That means blood is sitting still. Then they have to digest those RBCs for you. Yeah. That's why they call them heart failure cells. Just full of iron. Goblet cells produce mucus to trap debris. And as it turns out, Nolan, mucus will move 1 inch per cough. So that means by listening to how you cough, I can tell you where your problem's at. Because again, how you train your senses as a physician, you don't always have to even touch the patient. So when somebody comes in, here's what I watch. I watch how they breathe. If they're spending more time breathing in, where's the problem? Miguel. I don't think he caught it. Edmundo, if you're spending more time breathing in, is that restrictive or obstructive? Restrictive. All you guys do is hear in. That's it. Okay. This person's spending more time breathing in. And here's what you hear. Watch how I breathe. The person will do this. See how long it's spent breathing in and done with breathing out. That's restrictive. Okay. Prolonged breathing out. Remember, if you read the books, they say prolonged expiratory phase, pursed lips. What is that? That's obstructive. Because now you hear this. See, by pursing your lips, you slow down how fast air leaves. That means you're spending more time in exhalation. That's obstructive. Watch how the person breathes. You can tell. What about when they cough? All right, so when somebody does that, that's they're just clearing their throat. That's sinus drainage. Sinus drainage, gravity's already bringing it down. All you're doing is popping it into your esophagus so you can swallow it down. That's what men do. We just swallow everything that comes down. Women like, yeah, how you do that? Ew. They Kleenex. Ew. Swallow the damn thing, would you? All right, your stomach acid kill everything that comes down anyway. It's just simple germs. All right, so that's when you clear your throat. But when somebody, you quickly count it, about 6 coughs. That's about 6 inches. Oh, bronchi. He has bronchitis. I haven't even talked to him. I haven't touched him yet. Just listen how he coughs. Every time he coughs, you hear about 5, 6, 7 coughs. Yeah, that's 6, 7 inches. It's still bronchus. That's bronchitis. Versus this one. They've changed all kinds of colors already. That's how you know the mucus is way down at the alveolus. You got 30, 40 coughs before you're finally satisfied. Think about a child who has bronchiolitis, because that's the bronchioles way out in the periphery. Or how about somebody with whooping cough? Because the mucus is way out there in the bronchioles. That's why you got to cough 30, 40 times before you get the mucus up. So imagine, therefore, with children with whooping cough, why so many of them used to die. Before the vaccine, folks, 40% of children used to die every year from whooping cough because a baby cannot cough 40 times in a row. It ain't going to happen. It's just in the middle of their coughing. Mucus is coming up. The brain says, hey, you need to inhale. So the baby just forcibly inhales. And that means air comes down like this and meets that pocket of mucus, explodes it like this. And that's why you whoop. And that's how I got his name, whooping cough. Boy, the telepertussis. See? So it's so easy in pediatric floor, I could tell somebody who had it because you hear this. I said, whoop, there it is. You know how to take that one, man. That's an old song from way back, boy. Okay, but anyway, that's easy to diagnose. On the test, they'll tell you the person coughs till they vomit. That's because you're trying to breathe while coughing. They vomit. Or they cough and their eyes start tearing. That's because they're trying to keep that pressure coming. And it squeezes tears out of their tear glands. Yeah. Anyway, we'll talk about it under micro again. All right, so smooth muscle is located throughout the entire airway. Most smooth muscle is found in a medium-sized airway. Just like in the blood vessels. Which blood vessels have the most smooth muscle? Cesar. Who? No, aorta has the thickest layer, but that's not what I asked. I asked who has the most. Justin. Who? How do you know it's the arterioles? Because they do the most to regulate your blood pressure. How are you going to regulate blood pressure without smooth muscle? So that's how I remember. Arterioles are medium-sized blood vessels, medium-sized airways. Correlation. Medium-sized airways have the most smooth muscle. What does that tell me? Who regulates airflow the most? See that? Medium-sized airways. Where are you going to find the most bronchoconstriction? Medium-sized. Most bronchodilation? Medium-sized. Where do you find most of your beta-2 receptors? Medium-sized. Where does a child get most of his wheezing from? Medium-sized. See that? But that's their favorite one. Why? Because if you read the book, you look at the book says asthma is reversible small airway disease. You don't really know that small airways in your brain, but it tells you how to know small airways in your brain because that's what you read. But then he'll ask you, well, where's most of the wheezing coming from? You don't realize your brain's gonna be attracted to small airways when it looks down, unless you thought about it and say, oh, no, I gotta pick medium-sized airways because that's where most smooth muscle is found. And small airways play a role, but that's not where most wheezing is coming from. All right, Clara cells are specialized macrophages. All they do is eat dust. So there's macrophages, phagocytose, dust only. And then cartilage. So we already said you got 16 to 20 C-shaped cartilage rings in the trachea, right down the midline. Once the mainstem bronchus dives into the lung parenchyma, you now have the weight of your lungs on the trachea. I mean, not the trachea, but the mainstem bronchus, you need to have fully encircling cartilage. Otherwise, the weight of the lung would collapse the whole airway. You can't breathe. Now, that's how I remember it, so I don't just memorize it, all right? Once the mainstem bronchus dives into the lung parenchyma, that means into the lung tissue, the weight of the lung is now sitting on all these bronchioles. You got to have cartilage all the way around so to hold it open. If you don't have enough cartilage to hold it open in a newborn baby, that's called laryngotracheomalacia. That means soft cartilage. They'll have severe stridor for about 18 months. You just got to wait till the cartilage calcifies. So this baby does a lot of stridor whenever you lay him down on his back, because then the airway just collapses because he doesn't have the cartilage to keep it open anymore. But they're real noisy breathers. All right. Epithelium. The upper 1/3 of your trachea has squamous cells. Remember why squamous cell carcinoma is the most common intrathoracic cancer? Right here. Middle 1/3 of trachea is a combination of squamous and columnar. Then after that is all columnar. Pseudostratified because it comes down, narrows at the waist, and then goes back out to normal. So it looks like it's two cells stacked on top of each other, but it's not. That's what pseudostratified means. So tall columnar, pseudostratified, and ciliated epithelium is the respiratory epithelium. Sounds like a long title till you visualize it, then it's easy to remember. The more you smoke, the longer the zone of squamous cells, because smoke is an irritant, Halima. And if you irritate cells, they're going to mutate into another adult cell type that can handle that stress. What do we call that? What's the term we use for that? Yeah, metaplasia. And that's why all of a sudden now you have more trachea with squamous cells, and therefore you get squamous cell carcinoma. And what's the hormone that squamous cell carcinoma produces when you get in your lungs? Melissa. That's right. Ashley, you know this one? What's the hormone associated with squamous cell carcinoma of the lung? PTH. Remember, hypercalcemia is your clue. She said what? Why'd you say it so softly? I can't even hear. Oh, just in case you're wrong. I don't know why you guys are so scared. Okay, as soon as you guys find out you're right, then I hear you guys loud and clear. Man, come on, I keep telling you guys, say it loud and clear. That way, if you're right, you get a lot of points in the mind of the attending. If you whisper and then you find out you're right, he doesn't give you any points for it because he knows that's why students whisper, because you're afraid to be wrong. That's how he knows he thinks you're guessing. Don't do that. Don't take points away from yourself. All right, so anyway, that's the respiratory epithelium. And then how do you help somebody stop smoking? Well, if I can help you stop smoking, it turns out after 5 years, your lung parenchyma will go back to normal, but cancer risk stays the same. After 10 years of not smoking, cancer risk is cut in half. And after 15 years, cancer risk is back down to 1 to 3%. So you can erase all the damage done by smoking. That's why we try to get people to stop smoking. The other reason is because smoking is the #1 risk factor for all diseases in America. The one modifiable risk factor for disease in America is to smoke. And you go connect to over 60% of cancers, heart disease, lung disease, I mean, renal disease, stroke, my goodness, it's everywhere. So that's why we try to help you stop smoking. The best one is nicotine patch. Nicotine patch is the best one. For test questions, nicotine patch is the best one. Why? Because it comes with a support group. If you like Alcoholics Anonymous, why they're so successful? Support group. Remember, empathy is so powerful. People who've gone through the same thing you've gone through. When somebody can say that to you, it's powerful. And then because they're calling you every day, giving you, sending you nice positive text messages, all that, that helps a person feel that they're being encouraged. And so they're more likely to succeed. So nicotine patch is #1. Bupropion, #2. What's the bad side effect with bupropion, Miguel? And Ida. And Angie. Seizures, remember seizure risk. So anybody with a history of seizures or any risk of seizures, so electrolyte disorders, if they're on diuretics, bulimia, anorexia, we don't give it because they're gonna have a seizure one day. And then varenicline is #3. Chantix. Varenicline. Varenicline is a nicotinic receptor agonist. So it's giving you the same buzz as the nicotine that you get a buzz from. And then you slowly wean it down. Varenicline. Chantix now has a support group because they were trying to compete with nicotine patch. Yes, sir. How did this get bumped down to #3? It got bumped down to #3 because the initial studies, retrospective studies they did showed an increased incidence of homicide and suicide. Nicotine, pushing a sympathetic tone, makes you angry. So they were committing suicide or homicide. Now, when they went back and reviewed it, after they got more data, it showed that the risk of suicide or homicide was the same with all the drugs. So they took the black box warning off of that. So the problem is once you get that reputation, it's hard to scrub it off yet. Yeah, I'm not using that. Any doctor use it, hey, that's up to you. If you're brave enough to go ahead. Because if your patient is the one who's unfortunately commit suicide or go out and kill somebody, a good lawyer is going to try to get you for it. And say it's because of that drug and cite all the old studies, and it'd be hard to fight that in court. Yes.
With like the increase in vaping.
With increase in vaping?
I know it's very new thing right now.
Yeah.
But what we expect to see questions on it. It's so new.
Yeah, the only thing you want to know about vaping is a good question. Is it EVALI, e-cigarettes and vaping acute lung injury. Yeah, so it's a severe lung disease, restricted lung disease seen with e-cigarette users and vaping. And it has to do with the chemicals they use. They don't expect you to know what the chemicals are and all that, but they do expect you to know that disease. Okay, all you can do is just like ARDS, put them on steroids and hope for the best. Has a high death rate just like ARDS. All right, anyway, that's stop smoking. And then final one here, we'll do cilia and take our break here. Cilia line the entire airway all the way down to the respiratory bronchial. They beat in one direction towards your mouth. We use that word orad, means towards your mouth, oral. It has a 9+2 configuration. That means 9 microtubules surrounded by 2 actin proteins. Do you know of a microtubule inhibitor that we've learned about, Nate? Been who? Been blasting, Edna, colchicine, Gloria. Been Christine. All right, so we've learned a few of them. All right, so anyway, any of those microtubule inhibitors obviously are going to mess up your ciliary action. So people who are on those drugs have more pulmonary infections, obviously. Okay, but then cilia need a dining arm, remember D for derriere, to move backwards. Because what they do is, if you watch my arm, the cilia beat in one direction towards your mouth that way. They beat that way. Then they come down out of the mucus, slide underneath the mucus. See, they're going backwards. That's why dyning. Go backwards and go back up in the mucus. That way mucus only moves in one direction. Otherwise, if you accidentally pick the answer that says cilia beat back and forth, then that means mucus is not moving. So be careful. It moves orad. It does not beat backwards. It's passive movement going backwards. When dyning is broken, what disease is that? Ida? Huh? Cartaginers. Cartaginers, see that? Obstructive lung disease, look at that, bronchiectasis. Now you don't even have to memorize that. That's what all obstructions die from. Because you got mucus that won't move, that's airway problem, obstructive lung disease. Everything we already learned about obstructive applies. Saves you a ton of reading. But there's your triad. Bronchiectasis, infertility, because of cilia in the fallopian tube, cilia in the epididymis for a male. In fact, for men, remember cystic fibrosis? They actually obliterate their entire vas deferens. And so almost 100% sterility for men. Not quite as bad here, but they're a high infertility rate. And in sinus inversus, remember, which part of the GI tract must undergo this counterclockwise spin coming into the abdominal cavity? Cynthia. It's not the midgut, is that? You asking me a question or you answering my question? Okay, she doesn't remember. Angie, what are you saying? So kind of, you're asking me a question again? I asked you first. Why do you guys always ask me a question? I don't want a question. I asked you a question. Give me an answer. Nolan. It's the midgut. Thank you, Nolan. That's right, Miss Cynthia. I don't know why you guys punish yourself so much. Keep telling you guys, just answer the question. Because when you're asking the question back, it means you don't know that's the answer. I told you that technique's not going to give you credit if you're right. It's still because you sound like you're guessing. So he's not going to give you any credit. So that's why I'm trying to help you form these habits now before you leave here. Because when you go on rotations, folks, you got to know the perception of the attending based on what you said. To get maximum points, just answer with confidence. Why? Because you know you're going to be right the majority of the times. Not because anybody's right all the time. But if you're going to write the majority of the time, just say it with strength and confidence. They love that. Okay? All right. Sinus inversus. Only the midgut develops out in the yolk sac. And then it's got to go that 270-degree counterclockwise turn coming on in. Okay? And I think that, yeah, that's a good place to stop. And then we're going through lung sounds after the break. So start back at 2:35, 2:35, sorry, 10:35. Dang. Folks start packing their bags, leaving. I'm like, what are you guys doing? Well, you said 2:35, Dr. Francis. All right, let's continue where we left off. Cartigenous. Now we're going to do lung sounds. Because again, that way, when they give you the physical exam for the patient, the sound that they give you, folks, tells me a lot about what's going on. That means you got to understand the physiology of these sounds. Stridor is that noise. When you breathe in too hard, your exothoracic airway narrows. Okay, that's what stridor is. Remember, wheezing is narrowing of the intrathoracic airway. And of course, there's a long differential for each one. All you got to do is just say it, though, Melissa. Just talk it out. So when somebody has stridor, you say, I need something narrows the exothoracic airway. And then you'll see it. Like if you have a small jaw, like Treacher Collins or Pierre Robin syndromes, micrognathia, big tonsils, big adenoids, retropharyngeal abscess, peritonsil. I mean, you just come up with a differential. It's a long list. But the key thing is only between here, the lip and the glottis. That's what I mean. You got to be able to talk it out. Don't try to remember some list you read somewhere. I need something in the exothoracic airway to narrow it. And then you see there's only one answer on that list. That's what I mean. The test writer, congratulates any student who's organized. And then realize it's not about knowing every detail there is in a book. Is your mind organized? Because a doctor's mind has got to be organized if you want to save the most lives. All right, so wheezing is intrathoracic airways. That means something's in your airway. Now, if you got wheezing when you exhale, that's normal. So if somebody's breathing in like this, you hear. So you wheeze only when they exhale. Just. All right, now, whenever anybody wheezes on inhalation, that's never a good sign. Because on inhalation, your intrathoracic airway is supposed to open wide like this. And yet I'm hearing wheezing. That means there's something big in the way. Everybody follow? Or the airway is completely narrow like that, like severe bronchospasm. So anytime you hear wheezing on inhalation, that person's in bad shape, whether you knew it or not. So here's a question I remember seeing on my boys years ago. It says you're called, you're the physician on call. Yeah, physician on call in the ICU. You get a call, you're a physician on call in the ER. You get a call from the ICU and it says we're down to our last bed. Okay, I'm sure that came up with COVID, right? We're down to our last bed. And then 2 patients walk in the ER right after that call. It says one person has real loud wheezing on exhalation and the other one has real soft wheezing on inhalation. Who gets the ICU bed? Justin. All right, Cesar. The one who's wheezing on inhalation, period. Notice how they made it soft, as if it doesn't mean anything, versus real loud on exhalation, as if that means something. Is the phase that you hear it in that means the most, not how loud or soft it is. Okay? All right. Bronchi, air moving over mucus. Who has mucus in their airway on them? Restricted or obstructive?
Hey, excuse me, sir.
Wait a minute, Mabel. All right, go ahead, Anna. Who has mucus? It says mucus over in the airway. So all obstructive have bronchi. All right, Mabel, you have a question?
Yeah, please. I didn't understand what you explained on somebody is on call on ER and got a call, maybe a call from ICU. I didn't understand the example you gave.
All right, I said you get a call from the ICU that you're down to your last bed. That means only one person can come in the ICU. Do you understand that?
Yes, sir.
Okay, 2 people walk in the ER with shortness of breath. One has real loud wheezing on exhalation. One has real soft wheezing on inhalation. Who gets the ICU bed, Mabel?
I don't know.
No, figure it out, Mabel. You don't have to know. Figure it out right now. Which one bothers you more? Somebody who's wheezing when they inhale or wheezing when they exhale? All right, Gloria, help her out. Any wheezing when you inhale, Mabel, is a bad thing. I just said, either you got an airway that's wide open, but there's a big mass in the way. That's not good. Or you got an airway that's not open at all. You got severe bronchospasm. Okay? Any wheezing when you inhale, no matter how soft or loud, is a bad sign. That person needs to be in the ICU. Okay? And that was the point they were trying to make with that question. Okay? You understand that, Mabel?
Yes, sir. Thank you.
All right. So rhonchi, air moving over mucus in your airway. So all obstructives have rhonchi. Crackles, we've talked about this several times. Crackles means airway that was collapsed or popping open. Who has airways that are collapsed most of the time, Mabel? Restrictive or obstructive?
Sir?
Who has alveoli that are collapsed most of the time? Restrictive or obstructive?
Obstructive.
No. Obstructive has airway that's open all the time because it's got carbon dioxide stuck in there. Nicholas, brush it.
Yeah, restrictive
Why restrictive, sir?
because of the fibrotic destruction.
Yeah, because they have fibrosis. You understand that, Mabel? I always got to tie it to something physiological to remember these things. All right? Crackles are much more common than restrictive. They all have it. From day one, they have it. Why? Because the interstitial disease causes fibrosis. And alveoli collapse. Obstructives get it late in their disease. When mucus clogs up the whole airway, then that airway will collapse. Or they got pneumonia or something. Something's got to be there for them to get it. Not that they don't have it, but all the restrictions have it from day one. Yes, sir. Yeah, flush pulmonary edema will cause crackles, yes. Because the fluid will wash away the surfactant in the interstitium and cause alveoli to collapse. Yeah. Yeah, it has to be. Crackles always means you got collapse of the alveoli, always. All right, that's lung sound. Other lung sound, decreased breath sounds, or dullness of percussion. Says there's something between the lung and the chest wall. And that something, Miguel, is absorbing the noise. What it is, you don't know, but you know where it is. That's the key. So when I look at the answer list, I say, I need something between the lung and chest wall. Oh, hemothorax. Okay, blood. Soon, I'll take it. Oh, fluid effusion. Oh, okay, fluid. Okay, fine, I'll take it. He's got mesothelioma. Oh, that's a mass in it. My point is, you better pick an answer that between the lung and chest wall. And stop trying to memorize lists. Understand the physiology of these lists so you don't have to remember them. But you can say it again to yourself, look at the list of answers, you'll see there's only one answer where you want it. All right. Next one, increased firmness. Means you have consolidation on the same side or atelectasis on the opposite side. Or you can make the same conclusion when you have bronchophony, egophony, or E to A changes. I say the letter E and it sounds like the letter A. It means, again, consolidation on the same side and atelectasis on the opposite side. So let's say you got increased firmness in the left lower lobe. What are your two choices, Edna? Increased firmness, left lower lobe. What are your two choices? No, not obstructive. I never use obstructive here. No, I didn't say restrictive either. Okay. Gloria, what did I say? Yeah, that's what I'm saying. Look up at the screen right there. There's no obstructive on there. It says consolidation. Where, Gloria? On the same side. So consolidation in the left lower lobe or atelectasis in the right lower lobe. That's what I mean. Same side or atelectasis on the other side. Because if you got atelectasis on the other side, that means the airways collapse. That means you're not really hearing anything here. That's why it looks like there's more firmness on the normal side. Melissa. Yeah, if you have, yeah, so she was saying it was a question that she did, and they said decreased firmness. That means something's absorbing the noise. That's the same thing as saying dullness of percussion. Yeah, and that was fluid. Yeah. Again, remember, a test writer can say things in a different way, but he's still saying the same thing. Yeah. So that's all it was. They just changed the word. It's a word game, folks. It's always been a word game. All right, tracheal deviation. So Jess, your trachea deviates away from pressure, pneumothorax, on the opposite side, or towards atelectasis. Because when you collapse part of the airway, you create a vacuum on that side. So if your trachea deviates to the right, Jess, what are my two choices? Right atelectasis or left pneumothorax. Then they'll give you a second finding to know which one they want. So trachea deviates to the right with decreased breath sounds on the right. And Jess says the diagnosis is what? Atelectasis on the right. Right. Remember, trachea deviates to the right. So they gave you a finding that goes with the finding on the right. Pneumothorax is on the left. They didn't say anything about the left. That's what I mean. You got to have two findings to narrow it down to one choice. And that's what they give you on the exam, folks. Because they figure you should know the two, and then here give you evidence for one. There it is. You should know the answer. You should never be guessing. They will give you all the findings. Okay, or put only one of them on the list. But you got to know how to think it through with these lung sounds. Very valuable. They always give you the pulmonary exam, folks. They don't hide it from you. All right, but the finding on the exam will tell you exactly what's going on in the lung. Yes, Lauren. Pneumothorax and hemothorax, yes, can also give you deviations to opposite side because both will apply pressure. So now finally, hyperresonance. Hyperresonance says there's extra air in that thoracic cavity, i.e. pneumothorax is the worst it can be. Okay, so when you have hyperresonance on one side, think pneumothorax on the same side. But what if you have hyperresonance on both sides? Think hyperinflation, because now you have extra air on both sides. Like asthmatics, COPD, when they come in, they're overinflated on both sides. So hyperresonance on both sides, I think hyperinflation. Hyperresonance on one side, I think pneumothorax. So trachea deviates to the left. Zena, what are my two choices? Right? Pneumothorax where? Pneumothorax where? Give me location now. All right, Steve. Pneumothorax on the right because I'm pushing it towards the left. Pressure pushes to the opposite side. All right, so everybody is listening because you got to be able to take a look at that lung exam. You should know what it is already. All right, notice almost every pulmonary question we've had in the morning, we got them right. That's because I just focus on these sounds that they tell me. The sound tells me what's going on. But if you know what these sounds mean, you're gonna have a hard time figuring out what it is. Okay? So trachea deviates to one side. That means pressure on the opposite side or atelectasis on the same side. That's the way you should interpret. And then they give you a finding to tell you which side something is on. So hyperresonance. All right, Ryan, you have a question?
Yeah, so can you go back to the previous slide?
And your question is?
When you have when your trachea, so in the case of the trachea deviation, it'll be if it deviates to the right, you have a pneumothorax on the left, atelectasis on the right. You have increased tactile vocal fremitus on the right as well.
Trachea is deviating to what side again? To the right, right? If you get deviates to the right, that means you have atelectasis. You're gonna have decreased fremitus on that side because the lung is just not there. It's collapsed. Remember, that's what atelectasis means. So if you want to use fremitus, then you have to say it that way. They usually will say decreased breath sounds on that side because if you got a collapsed lung, there's no air moving through it.
Okay.
Yeah. All right. Lung infections now. And there's clues. Listen carefully. Croup is subglottic edema. It means you're going to have narrowing of the airway right by the glottis. That's still considered extrathoracic airway. So what do you hear? Stridor. Stridor and barking cough. Bark, bark, bark. Sounds like a dog barking. So when a kid comes in with croup, I say, hey, did the dog next door start barking at you this morning? Yeah, how'd you know that? The dog heard a bark. That says a new dog. So then, Jeremy said, oh, there's a key next door. So Chihuahua shows up with a rose in their paw. He said, what's up? Anyway, stridor and barking cough equals croup. What do you see on the neck film? It's called a steeple sign. That means the narrowing collapses your trachea like this. So you just see a little column of black air moving through the middle. Steeple sign. Looks like a steeple on x-ray. You understand, Melissa? So that's croup. Bronchiolitis is, we call it infectious asthma. That means asthma-like symptoms caused by an infection. Okay? So it has all the signs and symptoms of asthma, but it's an infection. And that's typically what we assume if you're under the age of 2. Bronchiolitis has all the signs of asthma, but asthma persists after age 2. Bronchiolitis does not. I found out the lung is normal adult size at age 2. Then I realized why bronchiolitis disappears at age 2. I always wonder why they always said it should be gone by age 2. Now you know. 4 most common viruses for this. Influenza. %80 of the cases. So if they ask you what's the most common, you have your answer. RSV. 15% of the cases, but this is severe, folks. So if the person's in the ER or in the hospital, I pick RSV because that's what they want. If you go to the hospitals right now, February, pick RSV. So you see RSV on so many doors. The fact is they're in the hospital. That means it was a severe case. Mild cases don't even come to the hospital. Mom will just call you and say, oh yeah, he's doing this. Oh, that's just bronchiolitis. He'll be okay. So the key is to recognize it, diagnose it. What do? Nothing, because they usually go away on their own. They're viral. Okay, they're viral. After RSV, there's adenovirus and influenza virus. That's the top 4 for both the illnesses. This is peak flu season, peak RSV season. You hear it all over the news. So there's a whole lot of croup and bronchiolitis in the hospitals right now. But if they're in the hospital, ER, pick RSV. That's all I'm telling you. But if they say what's the most common cause, then you have to say pure influenza. RSV can be treated with a drug. Honor, name a drug. Which one? Yeah, palivizumab. Viz. That in the middle is supposed to be a virus, RSV. And then motivizumab. And then, what's the other one? Ribavirin. You can use that as well. Okay? That's for severe cases. Most cases you don't have to treat. All right, bronchitis means increased mucus production, Zena. Somebody says, Doc, I've been coughing up more mucus the last 3 or 4 days. Okay, you got bronchitis then. So historical diagnosis, you don't have to run any tests or even listen to the chest. You got bronchitis. You got increased mucus production for 3 or 4 days. That's acute bronchitis. Chronic, that's less than a week, is acute. Chronic bronchitis is you've had increased mucus production for at least 3 consecutive months of 2 consecutive years. That's your chronic bronchitis, also known as the blue bloater. Acute bronchitis, you've been coughing up extra mucus for less than a week. Chronic bronchitis, you've been coughing up extra mucus like a smoker. You've been coughing up for years, so easy to make a diagnosis. For at least 3 consecutive months of at least 2 consecutive years, we call it chronic bronchitis, i.e. the blue bloater. The most common cause of bronchitis, Josh. What? No, all of them are going to cause inflammation. You can't say inflammation is the cause. What's the underlying cause? Who? Not asthma. Melissa, most common cause of acute bronchitis or chronic bronchitis. Which one? Infection due to what? What? Not influenza. You're close though. Cares. Adenovirus. Don't forget, viruses are way more common than bacteria. You already know your brain's got bacteria because that's what the book said. They don't even mention viruses in the books. I don't know why, but they didn't. I told you, you got to know the truth for yourself because there's a lot of stuff left out of books. Okay? The majority of infections are viral. And now I'm seeing a lot of questions. Why? Because of overuse of antibiotics. It's caused a lot of resistance. And they're telling doctors, could you please remember, viruses are more common. Unless a person really looks bad, don't treat with antibiotics. It doesn't make a difference anyway. There's so many studies that show antibiotics don't make a difference in any of these viral infections. That means unless they look real bad, don't treat with antibiotics. It's just symptomatic treatment only. So adenovirus, number 1. If they want a bacteria, that's less than 10% of the time. Then it's strep pneumonia, H. influenza, Neisseria catarrhalis. Anna. Yeah, you can call it that, laryngotracheitis. Yeah. No, croup is upper airway. Bronchiolitis, bronchioles, is lower airway. One has wheezing, one has stridor. So that's why you can't call it the same thing. Infectious agent is exactly the same. It's just that when the infectious agent is just coming in, it affects up here first, then it goes down, it affects, that's why you can get both. Yeah. All right, so chronic bronchitis, acute bronchitis. All right, pneumonia means you have consolidation. Consolidation means airway, mucus, and germs packed together. What are you going to hear when I listen? Ida. We have consolidation. Let me ask Mabel. What are you going to hear when somebody has consolidation, Mabel?
You're going to hear crackle.
You could hear crackles, but there's one that's more specific for consolidation. Leslie, you're first.
Increased parameters.
Increased parameters. Again, exercise your knowledge, folks. I mean, they'll say all these other things, but parameters tells me for sure it's consolidation. Okay. All right. So airway pneumonia, consolidation, increased parameters. Interstitial pneumonia usually doesn't have an airway problem, so they have crackles. They force your alveoli to collapse. So airway pneumonia is bacterial. Top 3 bacteria, same list I just gave you. Strep pneumonia, H. influenza, Neisseria catarrhalis. Ida, what's the first line drug for community-acquired pneumonia? CAP. First line antibiotic. Ceftriaxone is IVIM. You don't need to get that big. Community-acquired means it comes in your office. Just give a prescription for what drug, Melissa? Which one? Levaquin? No, that's too much. That's overkill. Let me ask Gloria. It's amoxicillin, something simple. Tastes like cherry gum. Easy to, yeah, amoxicillin is first line for all respiratory infections. Giving it to you now. Okay, all of them. They say start with amoxicillin because it covers them very well. And it's cheap and hardly any resistance. Okay, if they're not better in 7 days, repeat, but add clavulanic acid, augmentin. Okay, and they clear up. Majority of times they clear up. You don't need big gun antibiotics for community-acquired pneumonia. Yes. Yeah. Yeah, they've changed it. There's some macrolide resistance that they're running into now. Yeah, right now, amoxicillin, this was the last, what's they call a meta-analysis that they did. Amoxicillin covers it better. Now, if they're going to hospital, that means community-acquired pneumonia that's bad enough to end up in the hospital, and they want ceftriaxone, which covers all 3 of these bugs, plus you add azithromycin for the atypicals, just in case they pick one of those up. Okay? But this is community acquired, means it's in the doctor's office. Doesn't need to be hospitalized. Amoxicillin. But if you're sick enough in the ER and I got to hospitalize it, no, I got to cover some extra stuff because you're going into the hospital. You might pick up some other stuff while you're there. All right, ceftriaxone and azithromycin is the combination currently being used, and I'm seeing it in a lot of test questions. So again, I'm giving you an update so that you just know that, pick that. All right, so airway pneumonias. Interstitial pneumonias are non-bacterial. I'll go through them later. Tracheitis, most common cause, bacteria, Staph aureus. How do most people get it? When they're being intubated. Is the intern again trying to get that tube in there, and he brushes it right up against your cheek and just grabs Staph aureus before he gets into your trachea. Now you have Staph aureus in your trachea. So they'll ask, what's the most common way to get it? The answer is during intubation. Okay, tracheitis. How do we know we have it? The nurse will tell you, oh my, I'm suctioning a whole lot of pus out. That's how you know. All full of pus up here now. Tracheitis. Okay, so bacterial. All right, so Staph aureus, pick a good anti-staph antibiotic. Epiglottitis, most common bacteria, still H. influenza B. What do you see on the neck film? The thumb sign, which is a swollen epiglottis. We had one morning question where I showed you that. It looks just like a thumb. What if you saw a steeple sign? A B. Group. This is epiglottitis, different. So what do you see here? Fever. Which interleukin is that, Steve? IL-1. Maybe by what cells, Sabu? Huh? IL-1. Maybe by what cells? IL-1. Maybe by what cells, Maria? Macrophages. Don't forget. All right. So fever, stridor, muffled voice. That's the epiglottis keeps closing off the area, it's so big. And then leaning forward, drooling. Classic 4 findings. When you suspect somebody has epiglottitis, what's the next step in your management, Leslie?
Protect the airway.
Protect the airway, intubate them right away. And your question, Leslie, was?
Question was when we have a patient with a CAP already in the hospital,
Yes.
we use a mix of ceftriaxone and what was the other?
Azithromycin is the other one you put it with.
Azithromycin, right?
Yeah, correct. All right, so epiglottitis. Tracheitis, one unique cause is diphtheria. Remember, diphtheria has a toxin, and that toxin, if you remember, ADP ribosylase, we've talked about this already. ADP ribosylase EF2. And that's the most common question asked. What is this toxin doing again? Ribosylate EF2. Who else has that same toxin? Halima. Another bacteria has that same toxin as diphtheria. Melissa? And Zena. Pseudomonas. They're both ribosylate EF2. Okay? That one has a gray pseudomembrane, thick gray membrane. You'll see back there when they describe it. Easy point as long as you remember it. All right, what do you do with diphtheria? Secure the airway again, because that membrane is going to close off the airway eventually. The toxin, notorious for causing heart block. Remember one of the 5 infections that cause heart block. Name another one, Angie. Another infection that causes heart block. Not Coxsackie B. Cynthia. Infection that causes heart block. Nolan. And Amy. And Reed. Chagas. Legionella, Lyme, diphtheria, Chagas, and I'm missing one. Typhoid fever. Make sure you know the 5, folks, because only 5 infections out of thousands cause heart block. Yeah, I think it's pretty high yield. Huh? You know it's already in your notes, right? So it's Legionella, Lyme, diphtheria, Chagas, and typhoid fever. All right, now the different bacterial pneumonias and their clues. First one, strep pneumonia. First clue, rusty colored sputum. Rusty colored sputum, classic clue. Second, the only gram-positive with a capsule. If they say that, hey, I'm always happy, gives me a point. It's the only gram-positive with a capsule, folks. There are no others. Third clue, gram-positive diplococcus. That means it travels in pairs. The only one. So either they say diplococcus or they say travels in pairs. Hey, I get a point. They give you the culture results, folks. They don't hide it from you. That's why when we go through micro, I'm just going to give you key words. All they got to do is mention one of them. You should get a point. Strep pneumonia has 80 strains. Why would they ask you about that? To explain why Bobby keeps getting strep throat every week. Mom thinks you're not doing your job as a doctor. How come he comes coming back with strep pneumonia again and again? That's because it's a different strain. All right? Whenever you get antibodies, you get antibodies to the strain that's in your body right now. You don't have antibodies to the other 79. Okay, but mothers are the most impatient gatekeepers. If you don't explain things to them, there's more flux, movement of patients in pediatrics than any other field. Because mothers get irritated because you haven't taken care of it, they go to another doctor. By the time they get to the other doctor, Bobby got better on his own. Now she swears the other doctor's a lot better than you. Yeah, my other doctor, he just wouldn't give Bobby something strong enough. Whatever that doctor just gave Bobby, she swears that's what's cured him. No, the kid got better on his own. All right, but anyway, you don't want to lose your female patients. Female patients are the best paying customers in medicine. Just so you know. Nobody likes to lose a female patient. They pay their bills. I mean, they're conscientious, all that. So that's the kind of patient you want to keep forever. All right, anyway, that's rusty colored sputum. All right, next one, Klebsiella pneumonia. Curing jelly sputum. Halima, what do you think of when you hear curing jelly stool? Melissa, curing jelly stool. Interdeception. It's the same Klebsiella. Just Klebsiella down in your colon, that's all, or ileum. So curing jelly sputum. First clue. Klebsiella. Second clue, loves homeless people and alcoholics. Now, I didn't say it was the most common. Because I've seen that question. They'll say, what's the most common cause of pneumonia in alcoholic? They know you're going to pick Klebsiella. No, it's just strep pneumonia. If I told you, don't read a vignette when they say most common. Just click what you always know is the most common. Skip the story because you're going to be tempted to change your answer just because he's an alcoholic, but your answer's wrong. All right, Klebsiella pneumonia, alcoholics and homeless people. Third clue, likes to attack your fissures. Most bacteria like to be in a lobe. That's why it's called lobar pneumonia. This guy will attack the fissures. So that means he goes into the space between lobes. Very unusual. I've never seen that before until I read about this guy. Klebsiella. And then fourth clue, urase positive. A whole lot of those, you already seen it. BP punches, the mnemonic. And then last clue, has a capsule. One encapsulated gram negatives. Name another gram negative with a capsule. Mabel.
Strep pneumonia.
No, I said gram negative. Strep pneumonia is gram positive. Give me another gram negative with a capsule.
I don't know.
All right, Brenda Rivera.
Neisseria?
Neisseria is fine. Remember, some killers have pretty nice capsules. I'll give you the whole list. All right, so that's Klebsiella. Next one's Actinomyces israelii. It's in your mouth. It's oral flora. So sulfur granules. Here's a clue. You got sulfur granules, Rachel. What amino acid is it fermenting? Cysteine. So if they want to get out amino acid, you go down with them too. Okay? Sulfur granules. Second clue, abscesses of the face. So a facial abscess, always pick him. And that's why then you see the yellow flecks dripping out of his face. Classic. The nickname was lumpy jaw, which is an abscess. Lumpy jaw. Actinomyces. Classic description, gram-positive filamentous. That means it branches out in so many different directions. Gram-positive filamentous. And all you need is plain old penicillin to cover him. So easy to treat. Okay. Next one. Seen after the flu.
Excuse sir.
Wait a minute, maybe let me do the last two. All right. The flu, this is flu season. If you see somebody dying from the flu, it's usually not the flu that's killing them, it's Staph aureus. Staph aureus loves to come in after you're recovering from the flu. 10 to 20,000 elderly people die every year from the flu. But they'll ask you what actually kills them is Staph aureus. It's not the flu itself. What do you see with Staph aureus? He has every enzyme, eats holes into your lungs. So you see multiple abscesses, or they'll call them pneumatoceles, air bubbles. Pneumatoceal, air bubbles in the lungs, or abscesses in the lungs. Always think Staph aureus. And then malodorous smell or gas formation, pick anaerobes. The best coverage for anaerobes above the diaphragm, Leslie.
Clindamycin.
Clindamycin, below the diaphragm, Leslie.
Metro.
Metronidazole. So just so you guys know that. Now we'll go through all this again in micro. I'm just giving you a preview now as we go. Just so you hear the same antibiotics twice. Okay, but you gotta rehearse it and drill it, folks. There's no magic to this. I'm able. Now your question.
You said something about actinomycin is Larry, how to identify it. So I give two examples. I was lost on that.
What? I said what?
It's like you gave two examples about actinomycin is Larry, right?
Israeli, yeah. I said it causes facial abscesses. They call it lumpy jaw. Or there's a hole in your face and yellow drainage coming out of it. That's the sulfur, cysteine. It's all actinomyces. The last clue, actinomyces, I forgot to say this one. PID caused by an IUD. That's an old question still floating around. I just saw it a few months ago, so I know it's still around. Okay. This was an old question a few months, not even a few years, many years ago, until even though it's been debunked. Actinomyces israelii is oral flora, right? What's it doing down in the vagina? There's some couples who have an oral sex, and the doctors, for some reason, when it comes to sex, they always feel queasy about it. I told you, they just, oh my God, actinomyces causes PID. No, it doesn't. It's just his oral flora got caught by the IUD, and so that's how they found it down there. But anyway, it's treated as plain old penicillin would kill it, so it's not a big deal. All right, Mabel, you have another question? I see your hand is still up.
Yes, sir. What did you say about anaerobes?
What did I say about anaerobes? Right there.
Yeah.
Bad odor, smell, or gas. Anytime they say bad smell or gas, you want an anaerobe. Then I give you 2 antibiotics that treats it. Did you hear that part?
Yes.
What's the best anaerobic coverage above the diaphragm?
Clindamycin.
Correct. What about beneath the diaphragm?
Metronidazole.
There you go. Then you heard it. All right. Cynthia. What about anaerobe? Yeah, Clinda, and that's only if they want anaerobic coverage. Yes. All right. Let's see. You got some hands up here. First person. Oh, Jay. Oh boy. Who's Jay Gabriel? Gabriel Lopez Rivera?
Yeah, Gabriel.
Yeah,
I had a quick question actually about Klebsiella. You mentioned something about air trapping in the lungs or something like that. It was pneuma something something that you could
no,
see
that's
on
what
imaging.
Staph aureus. Pneumatoceal. Pneumatoceal. That means air bubble.
Air bubbles.
Or they'll say air fluid levels or abscess. They usually don't say abscess. They describe it, and you got to know, oh, they're talking about an abscess. That's Staph aureus.
That makes sense. Okay.
Yeah, no problem. All right, moving on. Interstitial pneumonias now. Those are all bacterial pneumonias. Now I'm going to give you a clue for the interstitial pneumonia. Are these people going to have trouble breathing in or out, Karina? Interstitial pneumonia is going to have trouble breathing in or out. In. Restrictive or obstructive? Restrictive. PO2 will be what? Low. Respiratory rate will be what? High. PCO2 will be what? Low. pH will be what? High. Tell me about the pulmonary capillary wedge pressure. High or low? Why is it going to be low? No, it's correct, but I want you to be able to explain it too. I don't want you to forget on the day of the exam, start thinking something else. All right, you did good. I just saw it in your eyes. You got the blood gas, you gave me with confidence. Yeah, I saw that you seen the physio. Use that physio. Hypoxia causes pulmonary vasoconstriction. That's wedge pressure. Wedge pressure is flow in the lungs. It's going to be decreased. So you had it right. That's all right. Connect to what you already understand. That's all you do. Okay, but good. Well done. Atypicals is the first family. You want to know what do you need to know about atypicals? They have no cell wall. That's what makes them atypical. Best treatment for atypicals. First line, Gloria. Yeah, macrolides, our first line. This is why when you put them in the hospital, they say, give them azithromycin to cover atypicals too, because you can pick up some of that. All right, so atypicals. And macrolides first, then tetracyclines, then quinolones. Chlamydia, the age was the best clue. 0 to 2 month old baby, chlamydia. He picked it up on the way out of mom. So they start out with conjunctivitis. Remember, that's where chlamydia goes. Attacks the eyes first, and then they get a pneumonia. So now when a child on them has conjunctivitis due to E. coli, or not E. coli, sorry, chlamydia, they say treat them with oral erythromycin because the pneumonia is coming. We usually use topical, but then that doesn't cover pneumonia. So they say use oral now. That way it covers both. If you use oral erythromycin the first month of life, it predisposes to another problem around 4 weeks of age on them. Yeah, that one. What was it? Yeah, pyloric stenosis. It's pros and cons. You got to do it when you have to do it. But it's because macrolides irritate your stomach. If they irritate your stomach has to contract harder, and that's how that muscle hypertrophies. Yeah, so it predisposes them to pyloric stenosis, but right now it's more important to get rid of infection that could kill that child. So chlamydia, 0 to 2 months of age. The other clue for chlamydia, it's a parasite, so eosinophilia. That's chlamydia. Mycoplasma, age range 10 to 30, so adolescent or young adults. Second clue, cause of walking pneumonia. Means they walked in the ER sick and walked right back out sick because nobody knew what interstitial pneumonia was back then. When we found out what it was, and they went back and looked at the x-ray, it was all over the x-ray, but nobody knew that was interstitial pneumonia. When you listen to somebody's lungs, what are you listening to? Airway. You're not listening to interstitium. So that's why they didn't hear anything. So respiratory distress, but when I listened, normal. So we thought, okay, it's not pneumonia, but it was. Anyway, that's how mycoplasma got that term, walking pneumonia. Walk in with it, walk out with it. All right. Another clue for mycoplasma, cold agglutinin, cryoglycolynemia. Remember, I am he. The M was mycoplasma. Mycoplasma. Next one, Legionella, after age 40. First clue, heating and air conditioning pipes. Outbreaks in high-rise buildings, hotels and motels. So anytime there's an outbreak of pneumonias and people in the same building, it's always Legionella. Because you got to go all the way up to their air conditioning system, swab it, and you see Legionellas everywhere. The one thing every apartment shares in the building is heating and air conditioning pipes. Goes through every apartment. So Legionella, that's your best clue. Second clue, love standing water. And that's what's in the pipes. Love standing water. Third clue, causes diarrhea before the pneumonia. Causes diarrhea before the pneumonia. Fourth clue, silver stains in the lungs. Legionella and pneumocystis, the only two silver stain in your lungs. You understand, Reed? All right. And then finally, heart block. 1 of 5 that cause heart block. Oh yeah, one new clue now. Well, it's not really new, but I started putting in my lecture. Is the charcoal yeast agar extract. It's the only thing that grows on this agar. Because I don't teach agars. But every time I've seen these 4 letters, I got a point for it. So that's why I started sharing it in my lecture now. All right, because all the other bugs, I'm not telling you agars, because agars are not specific at all. But this one is. So that's my Legionella story. Fungus. You've heard these before. Where you live tells you what fungus you ran into. Histoplasmosis, Midwest. That's where you're at now. Second clue, bat droppings. People who explore bat caves, apparently there's a lot of them in the Midwest. Spelunkers, yeah, they love going through the bat caves. They step on the bat droppings, and now when they take off their shoes, now in their hands, they end up ingesting it later. So histoplasmosis, bat droppings. Third clue is the only fungus that can live within macrophages. So anytime they say yeast form visible within macrophages, they already told you the answer. Histoplasmosis. Last clue is a warning. Even though his last name is capsulatum, he doesn't have a capsule. But they know a lot of students are going to fall for that because it ends in capsulatum. No capsule. Blastomycosis. Have a blast in the Northeast, so New York and surrounding states. Have a blast in New York. Next clue, pigeon droppings. Anybody here from New York? Man. Oh, Melissa from New York. Oh, man. You guys got some of the meanest pigeons I've ever seen in my life. And man, they totally gangster. Totally gangster, boy. I'm telling you, man. I'm used to Chicago pigeons. Totally different up north. So in Chicago, you walk up on a pigeon, fly away. You're the bigger person. They say, we fly away. So my wife and I were in New York for a conference, and we're walking towards pigeons. I didn't think nothing of it. But then as I approach the pigeons, I don't see them moving. And these pigeons start looking at you like, what's up? What's the deal? You know, got their chest out. Yeah, what's with you? You're a tourist, aren't you? Hey, you know the deal here? All of a sudden you're like, honey, let's walk around them, okay? I mean, them pigeons look at you like they're ready to fight you. Man, oh man. I'm like, whoa, this is a whole different breed of pigeons up here. All right, let's see. Muhammad Khan, question.
No, so just from New York.
Okay. Mabel?
Sir,
you're from New York too? Or is that why you're at here?
I'm not a gangster. Please, sir.
Where are you from, Mabel? Where do you live?
Georgia.
Oh, Georgia. Okay. So anyway, what's your question?
So please, apart from Ohio and Mississippi, which other state is in the Midwest?
Midwest, you got Illinois, Wisconsin, Ohio. What's the other ones? Any of the states around those three. I am completely geographically challenged. All right, I've learned more about the geography of America from fungus, from having to miss it many times, and then have to look on the what is it, map, and oh damn, I didn't know it was part of the Midwest. Okay, learn something all the time. One student bought me this little cartoon map of the United States a long time ago because I kept missing it. Say, hey, I can't help it. I just don't know the map of the United States. Anyway, so plasmamycosis northeast, pigeon droppings was the second clue. Third clue is a series of bees, broad-based hyphae. Remember, big bud. You would think the new bud is a tiny bud coming off the big one. It's the other way. You got a small bud and you got a huge bud that comes off of it. Big, broad-based bud, whatever. That's blastome. Big cavitary lesion in your lung. This thing eats a big hole in your lung. And then black nodules on the skin. Nobody's got their name on the rash, but they always describe these little black nodules that they have. That's blastomycosis. Coccidiomycosis, southwest. In the books, it says California. So I knew California. So I ran into a question they put in Arizona. I was like, damn, okay, that ain't California. I missed it. So I looked at the map. Oh, damn, it's right next to California. Oh, okay. Then they put it in Utah. I said, hell, I don't know where Utah is. Must be some other bug. Missed it again. Then they put it in New Mexico. I said, New Mexico, I think that's way too far over here on the right side. I had no idea where these states were, man. Where was I in high school? I must have missed those classes, man. Because I can't remember where the states were. I've learned more about where states are by the fungus, I'm telling you, man, than any other time. Anyway, Southwest, it likes dry heat. Dry heat. So Arizona, California, real dry heat. It hides right underneath the sand. So whenever they have a sandstorm, people pick it up. Then they show up in the ER, short of breath. Second clue, thin-walled cavity. So a real thin wall. And then when they divide, they describe them as multiple spherules. They look like little marbles. But anytime they mention that word spherules, I know they're talking about coccidio. So just a few buzzwords, folks, that you rack up points. Just make sure you know them well. All right. Treatment for systemic fungus. All right. All systemic fungus, we do it this same way. Okay. Amphotericin B and 5-FC for the first 2 weeks for all of them. Just so you know, we don't change for any of them. For the first 2 weeks, everybody gets treated with the best drugs. Amphotericin B and 5-FC. And then you send them home on one of the azoles for another 2 months. The difference is this. The azoles block the synthesis of ergosterol, which is the lipid these guys have. Just so you see it spelled, ergosterol. Amphotericin B binds to ergosterol and messes it up. And 5-FC takes the place of cytosine, so that's easy to remember. We'll talk about them again in micro. So the azoles block the synthesis of ergosterol. That's why you got to use amphotericin B first and then switch to the azoles. Because if you block the synthesis of ergosterol, who's amphotericin B supposed to bind to? You never use a combination. Okay? The difference is this: fluconazole flew up to your brain, the best CNS penetration. So for CNS fungus, they expect you to send them home on this one specifically. Itraconazole, nothing big about that one. Ketoconazole blocks P450 more than any other. They're all once a day, so they all block P450, but he does it more than anybody else. And then voriconazole, remember, the best one against aspergillosis. So those are the only 2 times they expect you to pick that particular azole. For cryptococcals up in your brain, they expect you to pick fluconazole and send them home on. For aspergillus, they expect you to pick voriconazole. For any other fungus, pick any one you want. Yes, sir. Josh. Is it safe to assume that any two fat separate drugs are going to impact each other's metabolism? Yes, that's true. No, the ones that block, the ones that activate, that's just memorization. Now, the majority fall in the middle. That's why it doesn't matter that you use two of them. Okay, but the ones that are real bad about blocking P450, that means they're going to elevate the levels of the other one. Then you can run into trouble. Huh? Is what based on affinity? Yeah, okay, yeah, the affinity for the enzyme. Yeah, for the P450, yes, correct. So that they don't expect you to know which one, I mean, how it does it, because I've never seen that question. But you need to know who can block it and who can rev it up. That we've been saying as we go. Okay. All right. So treatment for systemic fungi. Now you know how to treat all of them. All right. The rest of the fungus, the rest of the fungi we go through. Paracoccidio, South America. It's usually a businessman who's been in South America for a few months, comes back short of breath. Paracoccidio. And then ship's wheel appearance. It looks circular with spokes going through the middle like a ship's wheel, the steering. Aspergillus, we've done him 3 times already. Remember, moldy hair, moldy basement. Loves old TB cavities. There, you can actually see it rolling around. Looks like a fungal ball or aspergilloma. Likes to eat blood vessels. That's how you met him in vasculitis. Right? Sudden severe asthma in an adult. That's dad down in the basement cleaning up and didn't wear a mask, and now he's full of aspergillus. So aspergillus is a common one they're going to ask you about. And I already gave you voriconazole, works very well for him. Spore tricks, rose thorn. If you're a gardener or somebody who works in a flower shop, and then they get pricked on the finger by the thorn, you see a little red nodule. When it's just 1 or 2 nodules, we treat it with potassium iodide drops, Ki. And once it becomes systemic, once they got fevers and everything else, no, you got to treat it with amphotericin B and 5-FC. And then the pneumoconioses. Pneumoconioses, Miha, are lung diseases caused by what you do for a living. So there's a ton of them. But there's the 4 that they test all the time. Why do they ignore the other ones? Because all the other ones are too easy. All right. Bird breeder's lung. Gee, I wonder what he does for a living. Silo worker's lung. They don't ask about those. I'm talking about 40 years. I haven't seen a question about them yet. These are the 4. Why? Because you got to know what they do for a living. The other ones, they put it right there in the name. So that's as soon as you can figure that out. Okay. All right. So first, which one has the highest risk for lung cancer and the lowest risk for lung cancer? The lowest risk for lung cancer was anthracosis, coal miner's lung. When they factored out the smokers, there was no more risk left, which means it was smoking that was causing the risk. And the greatest risk is asbestosis. And they found if you smoke and you get exposed to asbestos, the risk is like 40%, 40 times. Relative risk of 40. That's huge. Asbestosis, number 1. Anthracosis, no risk factor, no risk for lung cancer. All right, starting with asbestosis, what does he do for a living? Number 1, shipyard worker. Shipyards have never been rebuilt in America. They're all over 100 years old. You know, the government always keeps trying to put it off, put it off, put it off. The problem is there's asbestos in all the pipes, all the shingles, all the columns. And that's why they made all the companies set up a $30 billion trust fund. That way those families can sue and get money for their loved one who died from asbestos or mesothelioma. All right. So shipyard worker was number 1. Pipe fitter. That's a plumber. Roofer, shingles. Brake mechanic. Old brakes have asbestos in it. Brakes, brake mechanic. And insulation technician, the guys who put in and take out insulation. Now they use fiberglass for insulation, but before it was made out of asbestos. The most common lung cancer seen with asbestos exposure. Nicholas Brusher, do you know this?
No, I just take a guess. Adenocarcinoma. I'm not sure.
All right, let's see what Divya says.
I'm also not sure.
All right, it is bronchogenic adenocarcinoma. The way to remember that, just so you know, next time, sir, is the fibers got to be inhaled into your lungs before they get to pleural cavity to cause mesothelioma. Students pick mesothelioma because why? Because the book talked about it. You don't realize your brain always makes the assumption that what the book talks about is the best answer for everything they ask. It's not. 70% of the time is bronchogenic adeno, 30% of the time is asbestosis. Mesothelioma. It's just that if you've been exposed to asbestos and you get a pleural cancer, is mesothelioma almost every time, 95% of the time. But they didn't say it was the most common. Okay, so be careful. So asbestosis. Another problem with asbestosis, when the fibers hit your lungs, they get coated with iron. So they call them ferruginous bodies. So anytime you see this description, they already gave you the answer. Ferruginous, that means coated with iron. And then in the pleural cavity, they talk about pleural thickening, pleural plaques, Samoma bodies, all meaning the same thing. Name another tumor associated with Samoma bodies. Aisha, Seba.
I'm blanking.
All right, Sheena, Kapoor.
Papillary thyroid cancer.
Yeah, remember papillary carcinoma of the thyroid, SA, serous adenocarcinoma of the ovary, M&M, mesothelioma, meningioma. Those are the four. All right, make sure you, again, review clues, folks. It's all over your exam. Rachel. It's adenocarcinoma. Yeah, bronchogenic adenocarcinoma. Yeah. All right, that's asbestosis. Silicosis. First of all, glass blower or sandblaster. Remember, silicon is using sand. Glass blower or sandblaster. So guys who are working on bridges, you got to blast the bridge with sand. All right, they pick it up. Silicosis, the silicon poisons your macrophages and predisposes you to tuberculosis. Next, silicosis likes to attack the upper lobes. So to talk about upper lobe fibrosis, the middle and lower lobes look fine. Silicosis is notorious for floating up there. Bisonosis, cotton. Somebody who works in a cotton factory or picks cotton on a farm. The fibers flying all over the place. That's what they're inhaling. Bisonosis. And then berylliosis comes from beryllium, a metal. You get it from radio and television welders, the ones who weld them together. That's when it vaporizes. Or now in the aerospace industry, I heard there's a lot of beryllium being used there. So now we got 3 good clues for beryllium. Any questions on these guys? A couple of miscellaneous. Nocardia. Nocardia is the only gram-positive that's partially acid fast. So it's the only one. That means it's called a point where I come from, if they say that. Gram-positive, partially acid fast, that's it. There are no others. Treatment for this one, trimethoprim, sulfamethoxazole. So the ones who are specific, I'll tell you. The ones who aren't, I'll wait till micro to start talking about it. So nocardia. Nocardia likes to attack diabetics. That's his favorite people. Lung disease and sinus disease. Sarcoidosis, description, non-caseating granuloma. It just means non-tuberculosis. I told you, but they love sarcoid whenever they use that description. Large hyaluronadenopathy. Remember potato sac. They look like big potato sacks. High ACE levels, because there's ACE in the lung cells, so makes sense. High calcium, because granulomas produce 1-hydroxylase enzyme to make vitamin D. Sarcoidosis, high calcium. Anyway, the rule is, if you see sarcoidosis in a chest x-ray of somebody and they're asymptomatic, the answer is do nothing. Which means the drugs we use don't work for that long. That means if you use it too soon, then you got nothing to do. When they finally get symptoms, now they're going to die quickly. Remember, what's his name? Bernie Mac died of this. A couple other celebrities have gotten this. Anyway, so sarcoidosis. If they're asymptomatic, do nothing. That's the answer. If they're symptomatic, treat them with steroids. And then I found out steroids have 5 anti-inflammatory actions. And Zena is going to give me one. 5 anti-inflammatory actions of steroids. It kills them. It doesn't just suppress them. Make sure you use the word kill, though. Suppress is not the answer that you're looking for. Kills T cells and eosinophils. That's I-KISS. Give me another one, Karis. Inhibits phospholipase A, so you can't make arachidonic acid to go down prostaglandins, oligotrienes. Maria. Inhibit macrophage migration into the area. They can't process any antigens. No inflammation. Saba. Stabilize endothelium. Fluid can't get out, and monocytes can't go into tissues, become macrophages. One more, Nolan. 1S. Second S, stabilizing endothelium. We already got. What's the second S? No. I is for inhibit macrophage migration. S is for something else. Amy. Stabilize mast cells from degranulating. All right, so sarcoidosis. Steroids is the only treatment that we have. Lung masses. Again, this is straight out of your neoplasia lecture, but we're going to go through it again. Most common mass in children, hamartoma. What is a hamartoma, Bailey? Benign what? Abnormal growth of normal tissue. Very good. See, that's what I want. I want to hear the key words. Whenever I ask you guys a question, give me the key words. That way I know you'll see the answer when you get to the test. You give me some other general word, and I'm not sure you're going to see the answer when you get there. I want you to be able to see the answer. You click, move, get in and get out real fast. What's common mass in adults? Granulomas, from all these things that we just talked about. Granulomas involves what 2 cells, Ida? T cells are macrophages. And the most common tumor, adenoma, means glandular, but the lung has always been glandular. Central cancers now. When you're talking about cancers, we got 2 that are central and 2 that are peripheral. So 2 that are central, that's how I know them. Squamous cell and small cell. Squamous cell, as we said earlier, produces PTH and is related peptide, not really your PTH. Your actual PTH is suppressed by this thing, since they do the same thing. So PTH related peptide suppresses your PTH. But what's going to happen to your calcium, Nate? Increase in your phosphorus. Decrease. Are you going to be more or less likely to polarize acid with high calcium? I thought calcium gets in the way of sodium. You don't want to lead with that. So it's less likely to polarize, unless you say atrium and thalamus, then you say more likely, but that's only for those 2 members. All right, so hypercalcemia with symptoms was the first step in your management. Anna. Hypercalcemia with symptoms. First step in management. Lewis, remember, dilute it down. Dilute it down right away. And then loop diuretics, so they pee it away. Yes, sir. No. The question is there a certain level where you have to add bisphosphonates? No. But we add them only for the real high numbers, to inhibit osteoclast activity. Because usually fluids alone takes it. Diuretics will take care of, make it pee it away. And then you find the tumor. Hyperparathyroidism is, you see one parathyroid is swollen, the other 3 are shrunken. Take that one out. They're back to normal. Typically above 12. Yeah, typically above 12. All right, small cell carcinoma. Remember, is where you get eaten Lambert from. This one is anaplastic, located usually at the carina, so the location usually gives away from me. And then it produces 4 hormones. Remember, Cushing's disease and then SIADH. If you got SIADH, what's the first line treatment for it? Josh? Not DDAVP. Shri.
I'm sorry, can you repeat the question? My mic's been going in and out.
Okay. So what's the first line treatment for SIADH, for the hyponatremia, seen SIADH?
Isn't it saline?
Nope. You're going to make the hyponatremia become worse if you give them saline. You don't do that. Margaret. How about Claire?
I don't remember, sorry.
Adonis?
The water deprivation.
Yeah, remember fluid restriction. ADH is holding on to water. Just restrict how much water they can drink. You can't hold on to water anymore. And they'll concentrate their own sodium back to normal. However, Davika, if you got hyponatremia less than 120 and you have symptoms, what do you do for that person?
Vasopressin?
Not vasopressin. Diamond.
I'm not sure.
All right, Latoria.
Hypertonic saline.
Hypertonic saline, 3% saline. And that's to get it back above 120. That way the seizures at least will stop. And then you fluid restrict and let it concentrate the rest of the way. What's the most common cause of SIDH, Mabel?
Sir, most common cause of SIDH?
Yep, that's the question.
Hyponatremia?
No, it causes hyponatremia, but that's not what I asked. What causes SIDH? Gloria, pain is number one. So you're going to see a lot of it in the hospital, folks. People are in pain. All the ICUs have it. All right? They're in pain. Remember I told you every time you wince, even for half a second, you engorge your brain with blood. And then the brain says, okay, you need more volume to raise the MAP because ICP just went up. Remember the equation? MAP minus ICP. You got to, if you raise one, you got to raise the other. Just in that half a second, ADH is released. And that before you know, you got SIDH. All right. All right. That's the two central cancers. Then the other two are peripheral. Bronchogenic adeno is in the terminal bronchus. That's out in the periphery. And then bronchoalveolar, just the word alveolar, got to be out in the periphery too. Can't be anywhere else. You understand, Solange? You understand, Meha? All right. Then we have carcinoid syndrome. Remember the triad? Flushing, wheezing, diarrhea. If you have carcinoid syndrome, where are most of them coming from? Sandra, you have carcinoid syndrome. Where are most of them coming from? Where? Yeah, remember pancreas first, ileum second. Although most carcinoids are in the appendix, they just don't go anywhere. So be careful what question they're asking. Too much serotonin. Serotonin is made out of what amino acid, Adnan? Not tyrosine. Close out. Oh, didn't say the right one first. So tryptophan. Tyrosine is for the catecholamines. So you measure 5-HIAA in the urine. And then large cell adenocarcinoma is real rare. Any questions on that? Yes, sir? Central just means right along the midline, right along the trachea. Yeah, mainstem bronchi. Yep. So they'll say perihyla. Perihyla is midline. I told you all they do is play around with words to see if you knew the original. Risk factors for lung cancer, since we mentioned lung cancer several times, primary smoking is number one. The risk increases with the amount and duration. The more you smoke, the longer you smoke, the higher your risk. Remember I said if you stop smoking, after 5 years, your lungs look normal, but the lung cancer risk is still the same. After 10 years, the risk is cut in half. And after 15 years, your risk is back down to 1 to 3%. That's why we help people stop smoking. What's the best way to help people stop smoking? Steve, what are you picking? Nabupropion. Andres. Remember, a nicotine patch comes with a support group. Pick that one first. Then bupropion, then varenicline. Radon is number two. Radon is radiation coming up from ground from bombs they dropped way back in the 40s. Still in the ground and still coming up. Secondhand smoke is the person standing next to you smoking. Some of that smoke is coming to you. Side stream smoke comes off the side of the tip of the cigarette. That smoke has never gone through the filter, and so therefore has a higher risk. Whereas mainstream smoke is the one that draws through the filter and then blows in your face. You say, thank you very much, sir, for being considerate. At least you lowered my risk of lung cancer. I appreciate that. Anyway, it's crazy, but that's what happened. Secondhand smoke was shown to increase the risk of lung cancer on airline, what do they call them? What's the general term they use for them? The flight attendants. That's the general. Yeah, that's just what I couldn't pick the term. Flight attendants. You know, they used to have, first 9 rows smoking. How about the 10th row? You're right next to the smoke. How does that stop? It was crazy, but that's what they used to have. And so the airline attendant who worked in that smoking section, they followed them for like 5 years. Their smoking risk for lung cancer risk was through the roof. It was like a relative risk of 8. That was huge. That's when they said, no more. That's how they stopped smoking on airlines, because out of concern for the airline workers, they were dying of lung cancer like you wouldn't believe. Okay. All right. Pneumoconiosis. All the pneumoconias we just talked about, and I gave you highest risk and lowest risk for lung cancer. Any questions? Risk factors for lung cancer.
Yes, sir. I have questions, sir.
Yes, Mabel.
Please, sir. You said that the most common cause of asbestosis when it comes to lung cancer is bronchogenic cancer. So what do you say about mesothelioma?
No, that's wait a minute. You got to put it in the right words. That's the most common lung cancer associated with asbestosis is bronchogenic adeno. Because the fiber's got to hit your lung first before they get to the pleural cavity. There's no way to go straight to the pleural cavity. That's how you know mesothelioma cannot be higher in prevalence than bronchogenic adeno. You understand that, Mabel?
Yes, sir.
All right. So Mabel, I just got one question for you. What's the most common lung cancer in somebody who works in a shipyard?
A shipyard is asbestosis.
That's not the answer.
Okay, in a shipyard, that isn't okay.
No problem. Nope, that's not the answer either. Let me ask Sabu. Bronchogenic adeno, still not the answer. Maria, it is metastasis. I told you guys about that question. Most common, you better ignore what comes after that. So you guys are going to read the vignette and end up picking the wrong answer by accident. Be careful. Most common is most common is most common. Metastasis is still the most common. Even if you're a shipyard worker or not a shipyard worker. They set it up by saying in a shipyard worker. That way you think about mesothelioma. But that ain't the answer. Most common. Okay, be careful. All right, so that's risk factors. Let's see, good place to stop. There we go, right on time. That way I do the physiology after lunch. Start back at 1:15. All right, EKG question while the rest of the people are strolling in. Yeah, 30 seconds to figure out what I'm saying. All right, you see tall, narrow P wave in lead V1 and V2, and you see tall, narrow QRSs in lead 2 and 3. 30 seconds to figure it out. Where's the P wave? I said tall, narrow P waves in lead V1 and V2. Tall, narrow QRSs in lead 2 and 3. Melissa knows this one. No, she don't. You gotta at least try. Karis is all over this one. Well, there is right atrial hypertrophy, but that diagnosis doesn't explain everything. All right. Well, let me give Sandeep a chance first. Growth coming out causes right-sided hypertrophy. Yes, but that doesn't explain everything. All right. Let's see what Maria came up with.
So I mean, there is still there's also there's a potential narrow QRS,
Yeah.
So that would also be at the ventricle.
Right.
So it has to be within the quarter of the valve.
And what's the diagnosis? I am thinking, I just need one diagnosis to account for all of this. Pulmonary stenosis? Not quite. Let me ask Cynthia, you get one chance. Let's go Holcomb. I gave you guys tall, narrow P waves in V2, V1 and V2. That means both atrial are hypertrophy. That's how you start out. Then I gave you tall, narrow QRS in lead 2 and 3. That means both ventricles are hypertrophy too. That's why you can't put just one thing on one side, one thing. It's got to be something that affects the whole heart. Only Holcomb could do this to you. All right, because the whole heart is hypertrophied. No, it's not just the ventricles, the atria hypertrophy too. Remember, if the ventricle hypertrophy, the atria have to hypertrophy to pump blood into them. Yeah, so the whole heart is hypertrophy. That's what it's concentric. All right, folks. Don't worry, we'll give you another one later on. Here we go. Ready? Physiology of the lungs. All right, so this is the same anatomy picture, just shows you again where everything is. Again, you just got to look at it, study it, make sure you understand everything. 3 physiologic parts of the lung. There's intrathoracic space, made up of the chest wall and pleural space, then the pulmonary vasculature and the pulmonary airway. So there's 3 pieces to the pulmonary puzzle. We're going to talk about each part, and then as we go to each part, we're going to bring them together so you see how each one of them interacts. Why? Because on the test, they give you a disease in one area and ask you how it's going to affect the others. I mean, how do you figure that out if you don't know how they interact? You won't. You'll be guessing. And we're going to stop guessing. We're going to figure things out. Okay? Any questions so far? Cool. Read. This is all you. Follow along for a minute. The most important properties of the lungs, folks. You got to have compliance, change in volume and change in pressure. What happens to your compliance of your entire body as you age? Goes down. What happens to compliance of your blood vessels as you age? Goes down. So is that going to affect systolic or diastolic blood pressure first? Systolic. That's why you see systolic hypertension in elderly people. Oh, Ms. Reed. Ooh, okay. Okay. All right, no problem. Amy, you follow along. Now we got to look at something called elasticity. Elasticity is for recoil. Remember rubber band? You stretch it, let go, comes right back to the starting position. What is the name of that protein that gives elastic tissue its elastic properties or allows it to recoil? Cynthia. Not made by proline. Anybody? Chris. No, elastin has something in it that gives it that elastic property. And Amy. Not collagen. Let's see. Anybody else know? Nolan. It's getting closer. It's made of lysines, but it had another name. And a B. Not alpha-1 And let me ask Cesar. It was called desmosine. Remember, it's made up of two lysines line up like that, you know. So that way, if you bring them together, they immediately go back to safe distance. If you stretch them, they run into another one, back to safe distance again. So that way, it doesn't matter which way you stretch a rubber band, it always comes back to the starting position. All right, again, don't forget it. Desmosine was the name I gave you. So this is pulmonary function studies. Folks, you and I order it every day as a doctor. You are definitely going to get a lot of questions about PFTs because you're the one ordering it. They want to make sure you know how to interpret it. So here's the tracing and all the different volumes and capacities. And then we're going to go through it in words. In words. Folks, you got to know this picture. You got to memorize this picture. Why? Because on the test, they give you several volumes and ask you to calculate another one. If you know the picture, they're all easy questions. If you don't know the picture, okay, you got a lot of work to do then. I'm not sure how you're going to guess it right. All right? So that's why you got to memorize this picture because we're the ones ordering PFTs on this guy, PFTs on that woman, PFTs. We're ordering them all the time. They want to make sure you know how to interpret it when you get there. All right? Any questions at all? I'm going to start from the beginning. Look at the picture. Amy, you flow with me on this one. The bottom here, it's called residual volume. Does everybody see? There's no way for you to come down here. Residual volume is the amount of air left, keyword left in your lungs after a full exhalation. That means passive and forced. You can't blow this out. Residual volume. You cannot willfully get rid of it out of your lungs. But you can pathologically get rid of it, and Amy knows who has trouble with the residual volume, restrictive or obstructive, because they have collapsed airways. Amy. Restrictive or obstructive? Collapsed airway. Who has collapsed alveoli? Restrictive. Is that what you've been saying? Oh, I just couldn't make, I thought you said obstructive. That's why I was watching your lips. I couldn't make it out. Okay, yeah. So all restrictives, the alveoli actually collapse. So that means if residual volume decreases, I know you can only be talking restrictive. Remember, obstructive has hyperinflation. There's no way residual volume decreases in obstructive. Everybody understand? So there's three main ways to separate restrictive from obstructive when you look at PFTs. That's number one. All you need is one of the three, folks. Even though they give you all these 10 numbers, there's three of them I look at, and I already know whether it's obstructive, which means I can already answer the question. Okay? Because they didn't ask me what disease it was. They just asked me some physiology about it. All right? So with PFTs, again, as you order as a physician, when the PFTs come back, you got to know how to tell quickly. Is this restrictive or obstructive? First one, residual volume. If residual volume increases, clearly you're obstructive. If it decreases, clearly you're restrictive. There's no overlap. All right? Now, residual volume is the amount of air left in your lungs after forced exhalation. It is also part of FRC, function reserve capacity. That's because it serves a function. And therefore, they can ask you, what is the function of residual volume? Residual volume is a sum total of all the little air in every alveolus that maintains it staying open. So it creates compliance in all the alveoli for you. That way, it turns out, folks, when you inhale, okay, let's say 100% of energy you need for inhalation. 75% of energy required for inhalation is burnt in the first 25% of your effort. That means if you let my alveoli collapse, I now have to exert that 75% of energy. But what if I have all your alveoli stay open? You just come and do the remaining 25%, which is easy. All right? Think about a baby who has RDS. Why do you think they die? There's no way you can make up this energy with every breath. Every single breath in your life, you can't exert that much energy. That's why they die. They're lucky if they even see 30 days of life. Because every breath, they have to supply that 75% of energy. You cannot live long. All right? Because you're in a severe low energy state. So in case they ask you, what is the function of reserve volume? All right, reserve volume is to provide compliance in every alveolus in your lung. It does not allow them to collapse. You just come and do the more effortless phase of breathing in. Anam. You can apply PEEP, yes. So he's saying that analogous portion on a ventilator, PEEP supplies this for you. All right, it just keeps the alveoli open for you. That becomes reserve volume. Okay, but in your body, That reserve volume just stays there. You cannot exhale it. Even if you try, you cannot do it. Okay? But if you have a disease, then it can collapse. Now you've lost reserve volume. All right. Then the next volume is called expiratory reserve volume. This is the amount of air left in your lungs you can force exhale. That means you have to, that means at the end of exhalation, there's still some more air you can blow out. That's expiratory reserve volume. But you have to force it out. Notice you got to use all these abdominal muscles. Now more air can come out. Expiratory reserve volume is also part of functional reserve capacity. That means, Amy, it also serves a function. What is that function? To fill up your dead space, Halima. Fill up your dead space. What's the normal tidal volume for an adult? Halima. What's the number I gave you earlier? Was that? No, not 5 liters. Let me ask Anders, what do you remember? Not 6 liters either. All right, Nave. 6 to 8 cc's per kilogram was the number you need to know. Okay, you calculated. So expiratory reserve volumes, the amount of air you can blow, force exhale at the end of normal exhalation. But it takes a lot of accessory muscles, and mostly abdominal muscles. Any questions on that? Now, what function does it serve? This is part of functional residual capacity. The function, Halima, of expiratory reserve volume is to fill up most of your dead space. You understand, Halima? You understand what I just said? The job of expiratory reserve volume is to fill up your dead space. That means, Halima, watch my hands. That means when you inhale, you're actually putting a column of air up here at the top, but that pushes the same amount down here at the bottom. The air you inhale is up here. The air you extract the oxygen from is down here. It's not the same puff of air. You understand, Halima? You visualize that? What? You don't understand. Do you understand what my hand just did? You have a column like this in your lungs. When you inhale, you put it on the top like this, and it pushes the same amount down here. So the air you breathe in is not the air you're getting oxygen from. You understand that? You're just putting a pocket at the top, and it pushes the same pocket down at the bottom. But your expiratory reserve volume. So your tidal volume is 6 to 8 cc's per kilogram. Let's say your tidal volume is 500. I don't see anybody in this room sucking in 500 cc's per breath. None of you are. The average person only sucks in 100 to 150 cc's. And they'll ask you, well, how the hell are they filling up their lungs? That's because you got dead space full already. Expiratory reserve volume did that for you. That way, all you do is put a pocket up here at the top, and it pushes the same amount down here at the bottom. That's why any column of air in your airway lasts a while. See that? Slowly going down to the bottom. So in other words, if I ask you, Halima, where's the freshest oxygen going to be found in your lung? Top or bottom? Top. Because when you inhale, it comes right up here at the top. The most stale oxygen is down here at the bottom. You understand that? Anybody not understand that? So that means if I look in your lungs, the most oxygen, Sabu, is going to be found at the top or at the bottom? It's going to be at the top because it just came in. The most carbon dioxide, found at the bottom. That just came in from the blood supply, arterioles. Anybody understand what I just said? I want you to be able to visualize it so you're not memorizing what I'm saying. Okay? You're inhaling, but it's coming and stacking right here at the top. That's because there's already a pocket right here that pushes the same amount at the bottom. So that means the freshest oxygen, top. Most carbon dioxide, bottom. A good way to remember this, why do you think TB likes to go to the top of your lungs? He ain't no fool, he Googled it. He ain't got no Google, say freshest oxygen, top of the lungs. I'm just telling you, that's how I remember it all these years. Because it suddenly makes sense to me. What? So TB goes to the top. Because he knows the freshest oxygen is up there. How come it's down to the bottom? But if you want to kill something in your lungs, where do you take them? Bottom of your lungs. Why do you think right and left lower lobe pneumonia are the most common? Your lungs try to move all the infections to the bottom so that they suffocate and die. Because there's hardly any oxygen down there. Everybody understand what I just said? That means the freshest oxygen, and it's top or bottom of lungs. Top. Carbon dioxide, Angie, top of your lungs. Bottom. So that means you're going to do switch. So the oxygen starts moving down to the bottom, while carbon dioxide starts moving up to the top like this. See that? You got carbon dioxide receptors up here at the top of your lungs. When they suddenly feel carbon dioxide at the top of your lungs, does everybody understand? That means the whole column is carbon dioxide now. Everybody understand what I just, remember, it's coming from the bottom, going up like this. So that means if they make it to the top, that means you got a whole column of carbon dioxide sitting in your lungs. You understand that, Sandra? You understand that, Mayha? So that's when your lungs say, you know what, you need to empty the whole thing out and refresh it. That's why when carbon dioxide touches the top of your lungs, it makes you sigh or yawn. A yawn is physiological, folks. It's to clean out your lungs, i.e. clean out your dead space and fill it up with fresh oxygen. You understand that, Karina? Just talking about yawn makes you yawn. It does. It's the memory of it. But that means, Karina, if I'm that person and I suddenly yawn to clean out my lung, does everybody understand? I just released a ton of carbon dioxide into the atmosphere. That's why anybody around me who takes the next breath, all of a sudden carbon dioxide touches the top of their lungs. That's why you yawn after anybody who yawns around you. Sounds like physio to me, folks. Sounds like physio to me. See what I mean? Okay. It's when you think it's something always, it sounds like it's always something complex. I say, no, why don't you go back to the beginning? And you see where they're getting this stuff from. Okay? Anybody that yawns, people around you will yawn right after you because you just exhale a ton of carbon dioxide for them to inhale. That means the next breath, carbon dioxide touches the receptors. They yawn. But because it's so beneficial, even if you hear somebody yawn on the radio, it makes you yawn. They're just like, no, just because I said yawn, you yawn. That's because even your brain knows the memory of a yawn makes you feel fresh. That's because it's fresh oxygen coming in. Okay? But anyway, I just want you guys to understand the physiology of a yawn. Yes, Anna first. The lower lobes of the lungs are the most prone to getting ischemia and the most prone to getting an infection. Lobar pneumonia, majority are down in the lower lobes. When you're doing shunting, the lower lobes are the first ones to shunt. That's correct, sir. Now you see it for yourself and you understand it versus I said it, you memorize it. All right. The bottom of the lungs has the most carbon dioxide and is most hypoxic. That's why pneumonia goes, your lung actually draws them down there. Or you can suffocate them. Remember, bacteria need oxygen like you. So if you take away this oxygen, they die faster. But that's also why you get most abscesses at the lower lobes. See that? Because every abscess is anaerobic by nature. Well, that's where you're going to be anaerobic. It's down at the bottom. Okay? All right. So now we've done RV and exterior reserve volume and FRC. Any questions for those three? Next one. Sir. Oh, who's speaking? Oh, Muhammad, go ahead.
So you said 3 to 5 cc per kg.
No, I said 6 to 8 cc's. Remember, it's already in your notes. You saw it earlier, 6 to 8 cc's per kilogram. But if you're doing restricted lung disease, 4 to 6 cc's per kilogram.
So if you lose weight, does that decrease your?
If you lose weight, no. That came up years ago. The actual tidal volume that they used to have was 10 to 15 cc's per kilogram. Till somebody asks the same question you're asking right now, Muhammad. When somebody gains weight, do they gain more lung? The answer is no. When you lose weight, do you lose lung? The answer is no. So they recalculate based on ideal body weight, which means that lung, that once you develop it, it doesn't shrink or swell. It's the same lung. 6 to 8 was what they came up with. That's less than half of what it used to be. All right, 6 to 8 is based on ideal body weight and ideal size of the lungs, Muhammad. So that's why
it's harder for. That's why it's harder to breathe when you're obese.
Yeah, that's why it's harder to breathe when you're obese because you got all this adipose tissue sitting on top of the lung now.
Okay, perfect. Thank you.
Yeah, same size lung, but it's trying to move all this weight off of it to take one breath. All right, next one. Tidal volume. Now you know how to calculate it, okay? Then the next one after that is called inspiratory reserve volume. That means at the end of a normal breath, you can force inhale. How do you do that? All these accessory muscles up here. This is why whenever I say somebody's using accessory muscles, that means they're either using it up here to inhale or down here in the abdomen to exhale. Inspiratory reserve volume, the amount of air you can force inhale at the end of a normal inhalation. Okay. And then when you cannot inhale any further, we say you've reached total lung capacity. You can't go any further. TLC. Cannot go any further. So total lung capacity includes all the air that's in your lungs, both passive and forcible inhalation is included. All the air that's in your lungs, even the residual volume, which you didn't have anything to do with, is included. That's why they call it TLC. Now, vital capacity is all the air you can inhale, both passively and forcibly. So that means it starts from residual volume, and then you can inhale all the way to TLC. That's vital capacity. How about all the air you can inhale starting from the starting point, which is FRC? Then we call it inspiratory capacity. So that's why you got to sit down and really look at this picture, and you can visualize the whole thing. If you can visualize it, like I said, all the questions are easy. That's what I'm telling you. You have to visualize this. That way you get ready for all these questions they're going to be asking. Okay? Now, 3 ways. I use 3 volumes to tell me restrictive or obstructive. Again, like 99% accurate. I'll take it. There was one rare time they'll catch me. I'm okay with that. All right? Number 1 was residual volume. If it's elevated, you got obstructive. Decrease, you got restrictive. I don't even care how elevated or how decreased. Everybody understand? They start playing with numbers. 58%, 49%. I don't care. If it's less than 100, it's decreased. If it's more than 100, it's increased. Okay? All right. Since RV is part of FRC, FRC is the other one. Same thing. If FRC rises, Halima, restrictive or obstructive? Obstructive. FRC drops, restrictive. Again, they'll give you a ton of information, folks. I'm giving you the 3 that makes your diagnosis for you. Get in there, answer the question, keep moving. Don't try to figure out all the other ones they put in there for you. That's put there to confuse you. But 3 numbers, 99% accurate. And all I need is one of them. I don't need all 3. Okay? Next one. So we got RV first, FRC second, and then the next one is vital. Hang on. No, total lung capacity. Total lung capacity. If it rises, obstructive, drops, restrictive. You understand, Cynthia? You understand, Melissa? All right. That means even though they give you 10 to 15 numbers, folks, just look for one of those 3. You should already know that what kind of disease you're talking about. And if it's just a physiological question, you already know how to answer it. You don't need to know what disease it is. Take your point and keep moving. Figure it out some other time. Any questions on that? All right. Now, let's look at one other thing. FEV1 over FVC ratio. FEV1 is how much air you blow out in 1 second. That's decrease in both diseases. That's why by itself, don't use it. In restrictive, you took in less. That's why you blow out less. In obstructive, you can't blow out enough. Well, you blow out less. So FEV1 is decreased in every lung disease. Cannot tell me a thing. Next one, forced vital capacity. It's all the air you can exhale if I give you all the time in the world. They just say you blow out into a tube. And then we set up a ratio. Because both of them are decreased in every disease, just so you know. That's why you don't look at the numbers by themselves. You set up a ratio if they haven't set it up. Usually they've already set it up for you. So normal person takes in about 5 liters, blows out 4 liters in just 1 second. That means the normal ratio is 0.8. So you got to know that's your starting point. It doesn't start at 100%. And let's go to Solange. In obstructive, are you having trouble breathing in or out? Breathing out. So you're going to breathe out more or less? Less. So your forced vital capacity, let's bring it down to 4 liters rather than 5 liters. You with me? Okay. But in 1 second of breathing out, you're going to breathe out more or less? In obstructive? Less. So rather than 4, it'd be a 3. So now 3 over 4 is 75%. See, that is dropped from 80%. That's why, as long as you know the starting point is 80%, any number below 80, you got obstructive lung disease. So please don't look at FEV1 or FVC by itself. You get yourself all confused. It's decreasing both lung disease. It cannot tell you what disease you're dealing with. The ratio tells you what disease you're dealing with. In restrictive, Sandra, you're going to have trouble breathing in or out. Huh? In. You're going to breathe in more or less? Less. So let's say you took in 4 liters, less than 5, right? But you can actually blow off all 4 liters. Why? Because your alveoli will collapse. So 4 over 4 is 1. So it doesn't matter. We don't get up to 100%. The rule is, as long as it's above 80%, they'll just use 81. Good enough for me. It doesn't have to be close to 100%. The key is, if it's above 81, above 80, you got restricted lung disease. Because what you're telling me is alveoli are actually collapsing. Most of the air you took in is coming right back out. So you can use RV, FRC. So the lung capacity you can also use, and now you can use FEV1 over FVC ratio, not the numbers by themselves. Any questions on that? Okay, again, 99% accurate. And that way you can answer their question without even knowing what disease they're talking about. Unless they ask you what disease, fine, then finish reading the vignette because I need to know the clue. All right, there's all the volumes. All of them are defined for you. That's in words, but you got to be able to visualize it on that graph. All right, compliance and airflow through the lung. Lauren, your turn. Compliance starts at 0 when you first start to inhale. Why? Because alveoli collapse. And then you inhale. Look at that, 0 compliance if the alveoli collapse. That's not good. As you start breathing in, alveoli start to open. Compliance then starts to increase. When you get to 50% of breathing in, you got the most compliance. So the highest compliance in your lungs, airway, alveolus, however they want to say it, is always the highest in the middle. In the middle of breathing in or the middle of breathing out, doesn't matter. It's always in the middle. You understand that, Lauren? Does everybody else see that? Okay? So in other words, look at this. It's 50-50 here. The two numbers add up to 100. What if I ask you, where's the compliance the same as here, at 0? It's the same as at 100%. Whatever question they ask me, if they put a number on it, your answer, your number's got to make it equal to 100. So if you say, where's the compliance the same as when you're here at 30%, Mitchell, then it's 70% of breathing in. 40%, then it's 60% breathing in, and so forth. Everybody follow? The two numbers have to equal 100%, just like 50-50 equals 100. Just like here, 0 and 100 equal 100. The two numbers have to equal 100. That's where compliance is equal and airflow is equal. Well, let's go over to Meha. Meha, you don't want your compliance to be at 0, do you? No, that's severe restricted lung disease. Alveoli completely collapse. That means you don't have to work real hard to open up that balloon, which means that 75% of inspiratory effort I talked about, you have to supply it. This is the reason why, listen carefully, every restrictive dies before every obstructive. That statement is never false. That is because the minute you get a restricted lung disease, your compliance is near 0. You're going to have to struggle for every breath there is. I mean, look at a guy like Bernie Mac. He was only probably in his 30s or 40s. How come the guy died soon after he got sarcoidosis? Severe restricted lung disease. You're going to die before any obstructive lung disease. But you see COPD years in their 70s and 80s, and they've been smoking for 40 years. That's because they're lucky. Obstructives get to live a lot longer than restrictives do. Okay, but just so you guys understand the big picture. All right, so that means compare this disease, I already know which one's worse. Restrictive will always be worse than any obstructive. Everybody understand that? That way on the test, you're not starting to guess because they'll just pick 2 new diseases and answer the same question. Okay? All right. But that's why we don't want alveoli collapse. But look at this, though, Karis. I don't want your alveoli completely inflated either. That's called severe obstructive lung disease. This is why, listen carefully, they tell you every obstructive lung disease, long-term, called COPD, at a certain point in time, they start to behave like a restricted lung disease because their compliance goes to 0. They're completely inflated. They say, breathe in, Mr. Neal. Guess what? Now you're having a hard time breathing in. That's not the physiology of obstructive. That's because you're years, decades into this disease. Every obstructive, at some point in time, starts to behave like a restrictive because their compliance goes to almost 0, just like restrictives. And that's why they start dying. So once we label somebody with COPD, why do you think they don't live long after that? Because they're fully inflated almost. That's why we don't want that. So how do we deflate them? That's why give them a beta-2 agonist to empty some of that carbon dioxide in there. Eh? That's why that helps. How about stop the inflammation? It's called steroids. Why do you think that decreases mortality? Treat the infections that are clogging up the airway. Why do you think antibiotics decrease mortality? See my point? Or how about a lung transplant? We'll just give them a brand new lung. There are 4 things that decrease mortality, folks. That's how I remember it. I always go back to the physio and back up for things. Because once they give me a list, I say, how did they come up with this list? Look at the physiology long enough, you start to, oh, I see where they got it from. Now you can see it too. You don't have to memorize it anymore. But that way, when they give you a clinical, what are the 4 ways to decrease mortality in COPD? In my mind, I'll go right back to it. I say, oh, yeah, that's right. How do you get the alveoli to collapse some? That means give it more compliance. Okay? So how do I know you have hit that point? That point is when you see barrel chesting. What are you full of? Carbon dioxide. And that lung is not collapsing. Okay, now you're COPD. You have barrel chest. And what do you see with that? Polycythemia. Why? Because now they're hypoxic. Obstructive lung disease doesn't have a problem with oxygen till the end. Because now they've lost compliance. See? All right, question. When surgeons are doing lobectomies, yes. How to save compliance, right? You try to take out the most inflated alveoli, because then that way you don't have a VQ mismatch anymore. The body doesn't have send blood to those alveoli. You just remove them. Yeah, that's how you save them, by covering out some of their lung. Yep. Spirometer. No, on the spirometer, just tell you about the different volumes. It doesn't measure compliance. Yeah. Inspiratory spirometer, this is just a little tube put by the bedside. The person just inhales and blows into. That way you can measure his pulmonary function right there at the bedside. Rather than doing a $500 test. Inspiration. Now let's put some numbers on things. Everybody follow me carefully here. Let's go to Maria first. When you inhale at the beginning, here's the chest wall. Let me zoom in a little bit here. Right hand, chest wall. Left hand, lung. You with me? When you inhale, chest wall goes out first. Who has more expansile forces? The who? Girl, you just said 3 things. Now, which one is the answer? No, then why am I pointing at the chest wall for you? Good Lord. So you guys think, no, he's trying to trick me. He's trying to trick me. Oh, I'm trying to make it easy. I'm pointing right at the answer for you. And she said, no, it must be the other one. He's trying to trick me. Okay. If the chest wall went out first, he has to have more expansile forces. It's impossible for the lung to be the one that is greater. He would have gone out first then. Everybody understand? I'm just trying to show you guys how to make this easy. The chest wall goes out first. He has more expansile forces. In the middle of breathing in, also the lung starts chasing them. See that? So from 0 to 49% chest wall, 50 to 99% lung. At the end of inspiration, the lung was going out. Expansile force of the lung equals recall of the chest wall. And that's why forces are equal and opposite, no more movement. Remember, at the end of anything, 2 forces are equal and opposite. They'll just ask you, what 2 forces are there? At the beginning of inspiration, chest wall expansile is greater. 0 to 49. 50 to 99, chest wall expansile is greater. Why? Remember Bernoulli effect? You create a vacuum. Whoever's close to that vacuum, you got to move into it. That's what makes the lung start chasing the chest wall. At the end of inspiration, the lung was still going out. Expansile force of the lung equals recall of the chest wall. So the chest wall goes out first and recalls first. So when 2 forces are equal and opposite, movement stops. You understand, Sabu? Let's do the opposite now. Sabu, here's the opposite. They meet up right here. And now the chest wall will start pushing your lung in. Okay, that's like somebody pushing on you from behind. Pushing in like that. That means the chest wall has more recall force. Everybody understand that? And now something from 50 to 99, see that? If somebody's pushing you from behind, after a while, you have more momentum. You actually will move away from him. See that? Same thing here. Chest wall recall was first, and then 50% of lung recall is greater. And then at the end of inspiration, the chest wall wants to go back out while the lung is still going in. And that's why they finish apart from each other. That way you have a vacuum for the next breath. Because if you don't have a vacuum, remember, you got to work hard for the next breath. So we don't want that vacuum to ever disappear. At the end of every breath, you recreate the vacuum again. Okay? So now, if you understood what I just said, so boom. At 13% of inspiration, which force is greater? At 13% of your inspiratory effort, which force is greater? What are the options? I don't know, what two things were we talking about? There was only two things. It's either chest wall or lung. Then you got to say compliance, expansile force or recoil force. Huh? At 13% of inspiration, which force is greater? Chest wall or lung first? Chest wall, expansile or recoil? Expansile because we're still going out. That's why I made it easy. 0 to 49, 50 to 99. Okay? On exam, they pick a number out of the blue. I find that the number just makes students all of a sudden, they're crazy, they're nuts. Because they put a number in, now you panic. Oh, the book didn't talk about 33%. Who cares? This is what they're testing right here. If you know there's only 4 quadrants to all of breathing. And now let's breathe out. Look at that. Exhalation. See, 0 to 49, recoil of chest wall. 50 to 99, recoil of the lung. At the end of exhalation, recoil of the lung equals expansion out of the chest wall. That's because they go in opposite directions. That's why they pull apart from each other and stay there. Now you're ready for your next breath. At 72% of inhalation, which force is greater? Count them. Lung or chest wall first. Lung, expansile or recoil? Huh? No guessing. There's the 4 quadrants. It's written for you. First quadrant is chest wall expansile. Second quadrant is lung expansile. All right, for breathing out, first quadrant, chest wall recoil. Second quadrant, lung recoil. That's it. There's lung. What? I gave you 72% of inspiration. You're not recoiling during inspiration. Yeah, so it's going to be lung expansile force. Any questions on that? Again, they'll pick any number they want. You got 4 quadrants, folks. They're all easy questions. Okay? Now let's put in some numbers. What? You know the example I just gave him? I gave him 72% of your inspiratory effort. Which force is greater? Yeah, greater. Lung or chest wall? Which one are you picking? I don't know what the middle is. There ain't no middle. I said lung or chest wall. What's this middle stuff? Is lung what? Expansile or recoil? That's my point. That's the same thing I just gave him. Yeah. It's a 2-step method, but it only takes like 3 seconds. You got to decide, is it lung or chest wall? Who's greater in that quadrant? And then are we going out, expansile force, coming in, recoil force? As long as you're methodical, folks, you get them all right. If you start guessing, or trying to remember what a book said, that's when students mess up. Because now you're not thinking it through anymore. You're just trying to guess what's the answer when they're really very easy questions. All right, now we're going to put some numbers on it. Baseline, Halima. That means before you breathe in, it's called FRC. The 2 volumes that make up FRC are. What's that? Now let me ask Melissa, the 2 volumes that make up FRC. Residual volume and? No. All right, Ashley. Residual volume and? Expiratory reservoir. You can look at your diagram. Now I gave you a diagram to look at. All right, the key is stop guessing. I told you the brain loves to guess what the answer is. But I want you to know, how do you get that answer? Just look at the diagram. They give you the diagram on the exam. Okay? So FRC is your baseline. If you look at tidal volume, starts at baseline, comes back to baseline. So FRC, RV plus ERV equals FRC. That means at baseline, your interthoracic pressure at that point, Halima, still you, is -3, -5. That's the vacuum that you want before you breathe in. If you have a vacuum, you don't have to work so hard to inflate the balloon. They're already inflated for you. Any questions on that? So, Halima, what's your normal CVP? Sitting outside the right atrium, sitting outside the thoracic cavity. Normal CVP is what? What's that? I can't hear you. No, -3 to -5 is intrathoracic pressure. What is your CVP, normal CVP? You learned that in cardiac, it's not in here. Melissa, what's that? 8 to 12, on them. No, not 5 to 8. Jess, what equation? I gave you guys a number for CVP. There was no equation. All right, Anders, what's the number CVP? 0 to 5, but the average is 3 to 5. Okay, why am I pointing that out? Your CVP is the exact opposite as your intrathoracic pressure. Physics, why you have to learn physics for med school? Here's one. Saba, when two forces are equal and opposite, which way is there going to be net flow? 0. I submit to you another incorrect statement in every physiology book. They say that blood flow into your chest, into your heart, is continuous. No, it's not. If you know physics, when they're equal and opposite, blood flow stops. Everybody understand what I just said? Oh, if you want to argue with physiology and cardiology, that's the one that gets them. I said, I'm telling you, the books are wrong. How so? Okay, let me show you. That means when you inhale, remember I told you, why do you inhale with each breath? To make the whole thoracic cavity negative. That's why -12. Okay, 3 to 5 goes in with no problem. So what if I make the intrathoracic pressure positive? Guess what? No blood goes into your heart anymore. How do I do that? What if I just put my hand around your neck and stop you from breathing in? How come all the veins in your head start being engorged? Because blood flow is not moving into your chest anymore. Why does the person die? Because blood flow didn't go into his chest anymore. That's why choking you. How about people at the bottom of a stampede and people walking over? They cannot inhale. Remember I told you about the 21 people that had fire in Chicago? All of them died because they were down at the bottom. People were walking over their backs trying to get out the door. And they all suffocated and died because their chest did not move the whole time. People, 2 of them, 200, 300 pounds on top of you, you're not going to be able to inhale. That's why they suffocated and died. How about if I make intrathoracic pressure positive by pneumothorax? How come all of a sudden you die? How about cardiac tamponade? How come all of a sudden you die? If blood flow in the heart was continuous, then this would not happen. See, another one the books got all wrong. They make it look like blood flow is always continuous no matter what you're doing. I say that's not true. Not if you understand physics. -3 to -5 equal +3 +5. There is no more moving. It stops. If you didn't make your thoracic cavity negative, blood flow would not go in. It is not continuous. It's just that the eyes cannot see it. But if you make the pressure more positive in the thoracic cavity, blood flow starts moving. Proves the point right away. Yes, Anna. Does this apply to Valsalva maneuver, meaning when you're grunting, when you're bearing down? Yeah, when you're bearing down, you're also increasing this pressure. That means blood can't go past it anymore. And that's why all of a sudden blood flow can't go into your heart, can't go into your lungs either. Yeah. When you take a tidal volume, look at where it is. See that? -10 to -12. See a 3 to 5 draws right in with no problem. When you take a deep breath, TLC, -20, -25. Now, these are the normal numbers for a normal person. That means if you know what normal is, Justin, on the test, they'll adjust it with a different number. So let's say they tell you at TLC, they have a -27. What does that tell you? They have what? But how did they get a more negative intrathoracic pressure? What? Well, we all inhale. How come his is -27, mine's only -25? You're on the right track, man. So when it's slightly off, we say either you took a deeper breath or a slightly shallower breath. So if I gave you TLC and I give you -18, you say, oh, he took a shallow breath because it's just slightly below normal. Or a -27, oh, just slightly above normal. He just took a deeper breath than you. That's the variance between people. What if I told you you took it a -60? Hell, that ain't normal now. You're talking about minus 60 is what you need to do what I do at minus 25. Does that mean, Mitchell? Am I having a harder or easier time breathing in? Harder. That means I'm struggling to breathe in. Restrictive obstructive lung disease, sir. Restrictive. You see that? Sneaky way. I'm telling you, restrictive from obstructive is just make the inspiratory effort give you this incredible negative pressure. You got to know, no normal person needs a minus 60. That means you're struggling. You're putting 2.5 times the effort into a normal breath. You're struggling to breathe in. That's a stiff lung. That's called restrictive lung disease. Okay? Restrictive lung disease is the one who's stiff. Any questions on that? You understand that, Josh? Go ahead. Okay. If you just rest at FRC, your heart is still beating. Yeah, your heart would have to work harder because you're staying at FRC. Whereas if you were going in and out with air, that means you're creating the pump that allows blood to come in easier. Because when you inhale, you suck in blood from your legs and then head and neck. See that? The heart didn't have to work that hard. It just receives it. Okay, when you exhale, you then push it forward to the left side. The heart didn't have to work so hard to pump it. Yeah, breathing in and out, folks, helps the heart do its job. The minute you stop breathing in and out, your heart has to do all the work now. Okay, and it can't keep it up for that long either. Yes. If you're taking a deep breath and pressure equalizes, what are you asking me? Yeah, pressure is equal to minus 25, and if you just hold your breath there, same thing. That means the heart would have to pump against that now, just to get blood to keep moving around while you're holding your breath. I think about it, like a child holding their breath. It's called a breath holding spell. What do? After a while, collapse, they pass out. Exactly what I just told you. If you don't have this vacuum all the time, you cannot keep it up. Blood flow in and out of your heart will just start dropping off until it's not moving anymore. That's why the child passes out. And then they come back to and start breathing again. You cannot hold your breath and hurt yourself. Children use breath holding spells to fool mommy and daddy. I want a new truck. And we tell them, anytime a child says that, you say, go ahead, son, go ahead. I want to see you pass out. Do that again. Because there's no harm done. Let them pass out 10 times every hour. Who cares? But they do that, hold their breath real hard, then they pass out because they want to scare the hell out of mom and dad and get their way. And so we just tell mom and dad, leave him alone. Let him pass out again if he wants to. All right? There's no harm done to him whatsoever. All right? Let him pass out. And don't ever give in to that threat or else you just created a monster. I'm serious. They'll start holding their breath every day to trying to get their way because mom thinks they're going to die. Mothers are always worried about that stuff. Fathers don't give a damn. Kid, get a job. Everybody pass out. Pass out. You better go get a job. $8 an hour. Something. Pass out at work. Okay. All right. So intrathoracic pressure should always be negative. Is my point. Everybody clear on that? If intrathoracic pressure is positive, you got problems. So here's intrathoracic pressure. This is how they graph it. Carries, if I answer your question. I know this is in thoracic because the pressure starts out negative. See that? Gets more negative with the breath, and then all of a sudden gets less negative, but it never crosses that line. It never gets positive. Your thoracic cavity should never have positive pressure in it. But let's say, you understand this so far, Caris? I got a new tracing for you, though, before I answer your question. So your patient did this, and then all of a sudden did that. I want you to interpret that for me. Don't give me a diagnosis. Interpret first of all. The pressure went from negative to positive in the middle of breathing in. Only one thing can collect that fast. Pneumothorax, then would be your diagnosis. Male or female? So male or female, first of all? Male. So male with what disease then? Klinefelters or Marfan. But you could have said female, and that would have been easier. All right. Estrogen or testosterone? Yeah, your patient stuff. Yeah. Estrogen or testosterone? Which one are you going to be picking? Thank you. Now, this is what I mean by I don't know how the test is going to end the question, and you don't either. First thing you do is interpret. Don't start putting a diagnosis on it yet. Interpret first. That way, even if you don't know the diagnosis, with that interpretation, go to the list of answers. You'll see there's only one answer that can fulfill that. Okay, all you got to just say, oh, pressure accumulated real fast, right in the middle of breathing in. Only air can accumulate that fast. Even blood can't accumulate this fast. Okay. All right. Let's see. Victoria, you have a question? Oh, wait a minute. Sorry.
Yeah.
Sorry, you were first. Hang on. She was right. She was first. Go ahead. Karis. The TLC didn't become a negative. Thoracic pressure at TLC became negative. So intrathoracic pressure was minus 60 when the normal person only sucks in a vacuum of minus 25. That means you needed 2.5 times the vacuum to do what somebody normally does at minus 25. That means you're struggling to inhale. That's how you know it's a restricted lung disease. Obstructive has no problem with inhalation. So why would they be struggling to breathe in? Unless you talk about the end when they're COPD, then fine, because they have the same physiology of restrictive. That's why they have to struggle to inhale. So that's why, again, only if you say years of it, that means COPD. If you just say obstructive lung disease, that's a trap. That's not the answer. No. Now, even exacerbation won't do that. Yeah. The key is if you got to struggle to breathe in, that's restrictive property or end stage obstructive. Okay. All right. Now, Victoria, your question.
Yeah, so this goes back a little bit, but when you said, like, if you were to choke someone and they pass out, it's more from the lack of oxygen or the blood to the lungs and not oxygen to the brain?
Yeah, it's both.
Okay.
It's more directly related to there's no blood going through the heart or the lungs. That's why it's not getting oxygen. That's why the person passes out.
Okay, right.
Yeah, it's the brain who actually feels it, and that's why it shuts down and you pass out. Yeah. And Latoya?
This is like the physio to like understand how the iron lungs works for polio.
That's exactly how the iron lungs work. The iron lungs would move the chest wall for you, and because they were having trouble breathing. So it would create the vacuum so the chest wall has to go up. And therefore, it does the same pumping action as you would have done if you could breathe on your own. Remember, in polio, they didn't know how to breathe on their own. They had such muscle weakness, they couldn't even breathe. So the iron lung just breathes for you. Okay. All right. Very good. Very good, Tori. Yes, Paul. No. Do you understand interpretation first? Pressure became positive right in the middle of breathing in. Yeah, because it just went from here to here. That's called a pneumothorax if they ask for diagnosis. Now they can ask you what's the underlying diagnosis. It could be women versus men. It could be estrogen versus testosterone. If they wanted to be a male with estrogen, that'd be Klinefelter's and then Marfan's. But theirs is because the collagen doesn't hold. It just pops one day. Yeah. Oh yeah. Yeah. The key is you got to figure out why the person has a pneumothorax all of a sudden. And that's what I said. I don't know how the test results are going to end your question. All they do is just go with new diagnoses. But the interpretation is the same. That's what I say. Start with interpretation. Don't start guessing where you've seen this before and think that it's the exact same thing as what you've seen before. That's where students make their errors. Anna. Yeah, and somebody with COPD, at this point, they have hyperinflated lungs, but the functional part of the lung, that means the part of the lung that's actually ventilating, it gets smaller and smaller. Why? Because the mucus keeps clogging it up more and more, and the bacteria keep digesting the alveoli more and more. Why do you think they finally died from bronchiectasis? Because the alveoli had got eaten by bacteria. And that's it. And they die because there's no more alveoli to use. But your statement is very correct. Very good. All right. So intrathoracic pressure should always remain negative. It should decrease with inspiration. Because positive, then it will resist any blood or air from entering the thorax. Hopefully I've convinced you of that. So I told you the books always say it's continuous. That's not true. That's not true. All right. If you do not breathe in, there will be no pressure gradient for blood to enter the thorax. That means no pressure gradient for air to enter your lungs either. Kussmaul sign, increase JV during inspiration. Pulse period exaggerate drop in blood pressure, usually more than 10 when you breathe in. And notice the two things I gave you before. Tamponade, number 1, pneumothorax, number 2. Halima, pericardial tamponade. What's the most common cause of that? Trauma. Again, gunshot wounds, stab wound, broken rib, that just punctures the heart. Where do you do a pericardiocentesis? Where do I put my needle? Are you saying something? I can't see if your lips are moving. There's a landmark I gave you. Josh wants to remind you. Up where? From the neck? Oh, okay, okay. I'm just playing with you. Yeah, xiphoid process. You understand? It's easy to feel on anybody, Halima. That's why you want to know that landmark. You stab the needle, large gauge, so blood can come through it, like 18 gauge needle. Right underneath the xiphoid, aim for your left shoulder. I told you it goes right into the pericardial sac. Which chambers are anterior in the heart? Melissa, right ones or left ones? The other way. The right chambers are anterior, left ones are in the back. Okay? That's why if you're going to puncture anything with that needle, it's right side, it's right ventricle. And how do I prove that my needle is in the pericardial sac versus in your ventricle? I taught you that one too. Halima, any idea? Jess, how do I do that? Draw what fluid? I know, but how do I know my needle is in the pericardium and not in the ventricle? I give you guys a way on them to know. Yeah, remember I said, as soon as they get, the pulse comes back, you take the syringe off, squirt a little bit on the gauze. If it clots right away, you're in the pericardium. Because that's fibrinous fluid, fibrin. There's a lot of fibrin in there. It clots immediately as soon as you touch something. Whereas if you're in the ventricle, your blood and your ventricles don't clot. And that's why it just sprays on there like water. That's how you know you're in the ventricle. You're in too far. Pull it back some. Okay, and retry the technique. That way you know you're draining pericardial fluid, not the ventricle. I told you, all of a sudden you drain 6 liters. You said, my God, look at all that fluid that was in there. No, you're busy killing your patient. Okay, you're draining all his blood. All right, so pneumothorax. If you got a tension pneumothorax, where do I put my needle? Believe me, we're going to put my needle. All right, Melissa, where do I put my needle? No, Ashley, where do I put my needle? Second intercostal space, mid-clavicular line. Allows the tension to escape. What I put in my chest tube, Karina? There you go, very good. Fourth or fifth intercostal space, mid-axillary line. Remember, angle upward. All right, so again, all stuff we've discussed already. Pericardial tamponade, most common cause, trauma or cancer, like Halima said. On a chest x-ray, you're gonna see a large cardiac shadow. That's because you got a fluid around the heart. The x-ray doesn't know the difference. It sees this big old blob sitting there, okay? On an echo though, echo goes through water, so it goes through your blood. So then you see this compressed heart in the middle, and all this is water, actually blood, okay? So large on x-ray, tiny on echocardiogram. And now your EKG must reflect that. How do I reflect that on my EKG, Justin? That all your chambers are being squeezed, man. So you squeeze the whole EKG. They'll say diffuse low voltage in every lead. There it is, tamponade. Notice all it's doing is reflecting what you're doing. This way you don't just memorize it because a book said that's what you're going to see. You actually visualize. Oh, you're squeezing, my friend. You're squeezing all the chambers. So diffuse low voltage is the way they're going to put it. Every lead has low voltage. All right, pericardiocentesis we just talked about on the xiphoid aim for left shoulder. If somebody had a stab wound, a gunshot wound, we usually take them to surgery after we get their pulses to come back and put in what we call a pericardial window. That means cut a hole in the pericardium That way, if any blood goes in, it drips down to the pelvis. That way it can't kill you. Otherwise, you're going to go back to surgery in a couple of hours when that blood collects again. So pericardial tamponade, after a stab wound or gunshot wound, you got to know they're going to be bleeding for a while. You don't want them to get another one and have to go back to surgery. So we go up to surgery, and while we're there, we put a window in that pericardium. That way blood is drained down into the pelvic cavity. Karis. Won't that just cause inflammation as in pericarditis? Will it cause inflammation of whatever it touches in the pelvic cavity? Sure will. When is it okay to do something that might be harmful? Remind me again. Remind me again. Remind me again. Remind me again. So remind me of the answer. Thank you very much. That means we don't care how much scarring you get. You would have died if I didn't do the procedure. If I remember this, in case I ask you this on the test now, don't start thinking of some new question. I mean, she can see that, yes, it's going to be harmful, but hey, if I don't do something right now, you're going to die right now. I have to do it. Cut a piece of pericardium right out. Well, that's because the blood goes down your pelvis. Yes, it can cause scarring on your intestines, your uterus, your bladder, your vagina if you're female, rectum. Hey, but we can always deal with that later on if it happens. Right now, I got to save your life. Saving your life is more important. And that's why we have to do it. Okay? All right. So pericardial tamponade. Pneumothorax, traumatic, again, is most common, but spontaneous pneumothorax, especially with estrogen or collagen diseases. I gave you these numbers, less than 25% occupation with no symptoms, do nothing. More than 25% occupation or symptoms at any level, put in a chest tube. There's anatomy of the lung again. Just remind you, please look this over from time to time. That's why I put it in several different places for you. Now the vasculature. So we've done the airway part. That's chest wall and pleural cavity. You understand? Now I'm going to bring in the vasculature so we see how he will be affected by what we just did. Okay? Here's the vasculature. Oh, you know what? This is why I put this picture right here. So you got capillaries, that's the vasculature, but the alveolar wall is out here. Okay? Here's the airway here. Here's the alveolar space out here. Okay? So that means when you create a vacuum in this space, the alveolar space, all right, then that means everything moves that way, opens up. So that as you open up your airway, that means as you close off the alveolar space, as long as moving into that space like that, it's pulling on the lung to open up. Okay? So imagine, therefore, you're pulling on one side. So here's a vasculature, that's a blood vessel. As you are opening up the lung, traction fibers are pulling on it like this. Is that vessel going to dilate or constrict, Maria? Dilate. What happens to resistance? Go up or down? Down. Pressure goes up or down? Down. Flow goes up or down? Up. That means resistance. Did it drop or go up? Resistance drop. So that means when you drop into thoracic pressure, you're also going to translate it to the vasculature. You're going to drop their pressure too. So whatever happens in the pleural space will make it happen in the vasculature. If you raise one pressure, you raise the other. Drop one pressure, drop the other one. They go in the same direction at all times. You should never try to separate them because you're not going to get a point. Okay? So now, as you dilate like this, Maria, blood flow increases. That's what you told me, right? That blood flow would then bring in oxygen. And we already said oxygen is the most potent pulmonary vasodilator there is. So if they ask you what's the most important pulmonary vasodilator, you say oxygen. But if they say what starts the vasodilator, it's traction fibers. It's not oxygen. So traction fibers do the first 10%. Oxygen then does the remaining 90%. So whatever happens to your pleural space, immediately translate it to vasculature. Let's look at that. We give it the letter Q. The letter Q, Gustavo, Q, flow. As you breathe in, the lung inflates, pulling on traction fibers attached to the vessels. So as the vessels dilate, flow increases. As flow increases, oxygen dilates the vessels even more significantly. And that's what increases your Q. The increased Q keeps the pulmonary valves actually open longer so that now S2 splitting occurs. That means if you want to accentuate any sound coming from the right side of your heart, what should I do? Jess. Have them breathe in, because there's always more blood flow on the right side of the heart when you breathe in. Everybody clear about that? Anybody not clear about that? Anam. In ARDS? NRDS. Okay, what's your question? Yeah, the traction fiber still works. Doesn't work that much, but it still works. The key is, even with the traction fibers working, it doesn't dilate the vessels enough to get enough blood flow to oxygenate the patient. That's why you have to apply pressure and get more oxygen in there. That's correct. Yeah, you have to oxygenate them like crazy if you don't give them surfactant. That's why we give them all surfactant now. All right, so flow. Flow is therefore greater to the bottom of your lungs for 3 reasons. One more time, Angie. Flow is greater to the bottom of your lungs for 3 reasons. Number 1 is gravity. Your heart is in the middle of your lungs. So when the heart pumps, gravity pulls it to the lower lobe. You have to pull up against gravity to the upper lobes. It's easy to go with the gravity. So the number 1 reason why flow is greater to the bottom of the lungs is because gravity pulls it straight down. Number 2, there's less resistance in the bottom of your lungs. Why? Because alveoli are usually mostly collapsed, so that means they're not compressing the arteries. That's why when you inhale, it takes a while for the air to come down here to alveoli, and so there's no pressure on those arteries. That's why plenty of blood flow. 3rd, there's more oxygen going to the bottom of your lungs as far as oxygen extraction. Remember I said when you inhale, you got a stack of a column of oxygen at the top, but you push an equivalent amount down here at the bottom. That's the one you're extracting the most. Any questions on that? These are the 3 reasons why there's greater flow to the bottom of your lungs. Any questions on these 3 factors? Anybody not understanding one of these factors? You understand it, Angie? Let's see if you do that. Your normal respiratory rate, Angie, is 12 to 16 breaths per minute. Each breath, each phase takes about half a second. So you breathe in for half a second, breathe out for half a second. So it takes about 1 second for each breath. You understand, Angie? That means there's 60 seconds for every minute, right? So that means for 12 to 16 seconds of each minute, where is most of the oxygen being extracted from? Top or bottom of your lungs? The bottom of your lungs. But the top of your lungs is always open. Ooh, watch out for this trick question. Show you in a second. Q increases on inspiration and decreases on expiration. Everybody clear about that? That makes sense to everybody? All right, S2 splitting, again, we said it's going to widen when you inhale, narrow when you exhale. That's because you have extra blood flow when you inhale. And now we can isolate everything on the right by inhalation, everything on the left by exhalation. Here's the part that's confusing people. Oxygenation is directly related to diffusion and perfusion. That means if you ask me a question about diffusion, I look for an answer with oxygenation or perfusion. You ask me a question with perfusion, I look for an answer with oxygenation or diffusion. I told you I like to get in and out in 2-3 seconds. That's because I know they're linear. The test writer can't give me these long stories. I need an answer with one of these words in it if I want to get a point. The others, I could kill us what they say. They're not the best answer now, are they? No, just look at these 3 words. Oxygenation is dependent on diffusion and perfusion. They're linear. So if you do something to one, all 3 will change in the same direction. That means if I ask you, how do you increase oxygenation? I say increase diffusion or increase perfusion. I don't have to look it up because that's the 2 main factors that govern his movement. Diffusion across the alveolar membrane and blood's got to pick it up. See? So if there's a question about diffusion, I know it's going to affect oxidation and perfusion. If there's a question about perfusion, I know it's going to affect oxidation and diffusion. The 3 words go in the same direction at all times. Yes. I said when you breathe in. So her question is, why does oxygen go to the bottom of the lungs, right? The oxygen that's going to the bottom of the lungs is not the oxygen you just took in. Remember I explained earlier, when you take in air, you're putting a stack of oxygen here at the top of the lungs. But old air goes in down here at the bottom. You're just putting the same amount into the air, alveoli down at the bottom. But it's not the same air you just took in. Yeah, remember I told you, when you take a fresh breath, you got a stack in the dead space, filling up like this. That same breath will last, for a while before is fully gone. Then you got to sigh or yawn again and fill it up. Anam? Anytime you have a ventilation problem, the top of the lungs will be affected more than the lower lobes. That is exactly correct. Vice versa. That means the bottom will be affected more than the top of the lungs. A PE that's located where? Right. Well, yeah. When the lower lobes will hurt you more than ones at the top of the lungs. Folks, they find out that 9 out of 10 PEs have no symptoms. Why? That means a lot of them happen at the top where you got plenty of ventilation. You're not even worried about it. And most oxygenation is being down at the bottom. It's not even affecting most of the oxygenation. See? Only 10% of PEs are symptomatic, folks. Yeah, and they do autopsy studies. They see people with clots in their lungs that never had any symptoms from it, which means people throw clots all the time. But at least now you're understanding when does it actually make a difference. The ones who are symptomatic, now you know. So one more time, folks, oxygenation is linear with diffusion and perfusion. They never go opposite each other. Whatever you do to one, you just affected all three. But watch this. This is a trick question that catches a lot of students. There's more oxygenation accomplished at the bottom of the lungs only with inspiration, which is what Anam is just saying. Is everybody understand that? But the top of the lungs is always oxygenating. Everybody see that? So that means the top of the lungs is the one that does most of your oxygenation. So here's the question they asked me. I think I missed it twice before I finally figured out what I was missing. They said, where is most of the oxygenation in the lung accomplished? And I'm telling you, I picked the bottom of the lungs. Why? Because every book I looked at said bottom of the lungs. This is where books will mislead you. The books assume that you understood they were talking about only when you're breathing in. But they don't explain that. You're supposed to figure that out. Well, most students don't figure that out. That's why they keep asking the same question on the boards and complex, because they know that most students don't figure it out. Okay? The bottom of your lungs is oxygenating the most only with each breath. That means if you ask me overall, the answer is the top. You have to say with each breath or with each effort. Then I say the bottom. See, that means you got to know the difference by the way the question is asked. The book was only talking about what happens with each breath. Because I remember looking, I'm holding the book up like this. I said, how come I didn't get it right? I said, the book said bottom of the lungs. And it took me a while after I read the explanation a few times. Oh, now I got it. And then I finally started getting it right. They know how students misunderstand what's written in the books. And they know how to set it up so you swear you got it right, but you didn't get it right. Yes. The top of your lungs is always open. That's why you have upper part of your chest is always inflated. It never collapses. Open to the air. That means if they're open, oxygen can come in, carbon dioxide can leave. The bottom of your lungs collapses after you exhale. So it's not always open. Yeah. Karina.
Since you have these factors, this change the physiology of like swimmers who are horizontal?
So swimmers who are horizontal versus being vertical? Yeah, it just spreads out the pressure a little more equal. It still oxygenates more from the top of the lung, but they're able to equalize the perfusion throughout the lungs while they're swimming like this. Yeah, and that's why they can swim great distances or stay underwater a lot longer. Okay, so in other words, folks, let me say it one more time. If you don't understand it, but say something now. Oxygenation is linear with diffusion and perfusion. That means if they ask you what affects oxygenation the most, folks, it better have diffusion or perfusion in that sentence. Otherwise, I don't care what it says, it's not the best answer. You can talk yourself into it, but you won't get a point. Okay, be careful. Your language has to match the language of the test writer. This is what he expected you should have learned. Okay, and watch out for this question. Most oxygenations accomplished what part of the lung, Gloria? The top, because the top is always oxygenating, because it's always open. But with each breath, most oxygenation is where, Josh? Yeah, now you say bottom. See, now they're two easy questions, because now you clearly know the difference. But when you don't know the difference, because you're going by what the book said, like I did, that's where I got them right, now I got them wrong. I'm looking at the book, looking at the questions, how did I get this wrong? The book is saying exactly what I picked. And it said I got it wrong. I had to read the explanation several times to finally understand, oh, now I got it. Then I understood. The book, the way they said it, they just didn't say it was only talking about when you're breathing. Ventilation. Ventilation inversely related to PCO2. Because when you ventilate more, Melissa, you have less PCO2 left over. If you ventilate less, you have more PCO2 left over. You understand that, Melissa? So ventilation and PCO2 are inversely related. Does everybody understand that? So when you ventilate more, less left. Ventilate less, more left. So you got to know that relationship. Whereas oxygenation, diffusion, and perfusion are linear. There's no inverse relationship whatsoever. Look at the definition of ventilation, Lillian. An open airway, an open alveolar space. That means the respiratory bronchial, alveolar duct, and the alveolus. The only three places I told you can exchange oxygen. But at the same time, that's the only place where carbon dioxide can come across to leave through the airway. True ventilation. There's ventilation that means your alveoli are opening. Then there's ventilation that says your airway is open long enough to let carbon dioxide get out. Notice they call it, they just say hyperventilation all the time. But which ventilation are you talking about? Okay. All right. The measurement of ventilation is by the PCO2. If PCO2 went down, then you hyperventilated. If PCO2 did not change, you're just hyperpnic or dyspnic, but you're not ventilating. You're not hyperventilating. There's a difference. That's what I said earlier. There's a difference between your breathing and your ventilating. And please make sure you know the difference because your attendant is definitely going to ask you. If you said a person is hyperventilating, then show me the PCO2 that went down. In obstructive, the PCO2 is always above normal, late in the disease. That's why they always say peripheral hypoventilation. Doesn't matter how fast they're breathing. They're breathing fast, but they're not hyperventilating. Be careful. It's so easy to pick that answer and not realize they're talking about obstructive lung disease. The PCO2 is above 40 all the time. No, you cannot call it hyperventilation. It's still called peripheral hypoventilation because they're not blowing off all their CO2. Now look at this trick here on them. There's more V to the bottom of the lungs, only on inspiration, but there's more V at the top overall. Same thing you said earlier, because the top is always open, so it's always ventilating. The bottom is open only when you inhale, so it's only ventilating when you inhale. Yes, sir. This is why COPDs are chronic retainers of CO2. They're breathing faster and faster, but they're not ventilating the CO2 off. Yep. All right, so now we create an equation. Pulmonary airway, all right, I mean FRC. This is at baseline. Airway pressure equals atmospheric pressure. Is that minus 3 to 5 equals positive 3 to 5, okay? When you inhale, look at this. Airway pressure falls down because you're creating a vacuum down here. And that's why atmospheric pressure, the air moves into your lung. At the end of a deep breath, look at that. They equalize again, but at a new set point. So you got a vacuum of minus 25, the air will fill up with a positive 25. And then when you exhale, it's just the opposite. Airway pressure then rises to overcome atmosphere, and that's why it comes out. So in other words, the airway pressure is the only pressure that gets positive with each breath. Very important to know, folks, because remember, vasculature and pleural space pressure stay negative with each breath. They never get positive. Getting positive will kill you. But your airway pressure is allowed to get positive because you give me a net vacuum minus 25, I give you a bubble of positive 25. You give me a minus 30, I give you a 30. That's how you get more air to come into your lungs. Take a deeper breath. So pulmonary airway pressure is the only pressure that gets positive with each breath. Everybody clear about that? The other two stay negative with each breath. So breathing cycle, normal, tidal volume. See, changing air. So as you start breathing in, see that pressure goes up and then pressure goes down when you exhale. Okay. Alveolar pressure follows a sine wave. It goes down when you breathe in, goes up when you breathe out. So it looks like an S lying on the side. Now, test writers know how to mix things up a little bit. What if I put A here, B here, C here, D here, E here at the end? Jess, do you understand what I just put up here? First half is when you breathe in because the pressure is getting negative. That's how you remind yourself of that. Second half, pressure is getting positive. That's when you're breathing out. Okay? Which letter represents FRC? Force reserve capacity? No, FRC is not the max of anything. You're using the wrong word. That's our starting point. FRC is a starting point. Thank you very much. See, when you say the right word, now you see the answer real easily. Okay? FRC is an A or E, because remember we started FRC, come right back to FRC. That's what I'm saying. Be able to talk the language, folks. That's what I'm saying. And use the right words when you're responding to me. Because I want to make sure you can find the answer real quickly. Because if you don't use the right words, that's why you're having a hard time figuring out which answer to pick. Say the right words, you'll see there's only one answer with that word in it. Now it's an easy question. Where is tidal volume at, Karina? Huh? In the middle of breathing in, that's your tidal volume? Thank you. It's at the end of breathing in. That's tidal volume or total lung capacity, depending on how big your breath was. Anna. How would it change your altitude? Everything will still be the same. You just won't be able to bring in enough oxygen because there's not enough oxygen in the air of high altitude. But the cycle doesn't change. Well, atmospheric pressure will change. So you're talking about, if you want to talk about, let's see, so interpleural pressure will change because the pressure out here in the environment will be pushing back on your lung. So that means that's why you can't take such a deep breath. And even if you do, you still don't bring enough oxygen. You're still short of breath. That's why you hyperventilate at high altitude, correct? All right, so that's breathing cycle. Then they have breathing cycle this way, okay? So and exhalation and inhalation is the same thing, but then they modify it by doing all kinds of other things, taking shallow breaths, deeper breaths, and so forth, okay? Pulmonary function studies. So I put in a bunch of these. I want to show you guys because they love these drawings on the test. You got to be able to look at it and understand it. Look at normal. Remember, it always starts, you got to understand what normal is. And they usually draw the normal for you. Okay, look at this one. Normal, you breathe in, notice getting negative. When you breathe out, it got positive to a peak and then drops. Okay, but look at asthma, an asthma attack. See that? You take a shallower breath because you got what? Bronchospasm. And then look at that. You can't seem to exhale as much as the normal person anymore. Okay, because again, your airway is now full of mucus and spasm. So they give you all kinds of different ones. Look at this one, emphysema. Now we're going to talk about it in a second, but emphysema is the only one who has restrictive and obstructive properties. So it's restrictive because you see that this is shallow compared to normal. But look at breathing out. Look how much the person has to struggle to climb up that hill and then drop. So that means he has problems with breathing in and problems with breathing out. That means he has restrictive and obstructive. Emphysema is the only disease that has both components in the same person. So the question then becomes, how do I answer the question when I get to the exam? It has both properties. First of all, does everybody see both properties? Everybody see it now? Say something if you don't see it. That means they took a shallower breath in, that's restrictive. But they struggle to get it out, that's obstructive. That's both components. So now, let's say they ask you about the blood gas. You got to put the two together. You say, well, the obstructive component says the PCO2 will be high, pH will be low. The restrictive component says PO2 will be low. Put that together, that says blood gas. That's the blood gas for emphysema only. What if they ask me, what are you going to see in the airway? Folks, the way I treat emphysema, it has both components, but when you're answering question about them, answer it as an obstructive lung disease. They have airway mucus, airway narrowing, thickening of the airway, increased breath index, the diaphragm bronchiectasis. Everybody follow? Okay, I just treat it as a obstructive lung disease when they ask about questions about it. But because it has a restrictive component, if they ask me about diffusion, I also have to say decreased. Other obstructive lung disease don't have decreased diffusion, but he does. How do we monitor or measure diffusion? It's called DLCO because it's measured with carbon dioxide, DLCO. Diffusion capacity of carbon dioxide. So all restrictive have decreased DLCO. Emphysema is the only obstructive with decreased DLCO. Otherwise, obstructive lung disease doesn't have a diffusion problem till the very end when they start to take on restrictive features. Here's another one. I saw it that fooled me at first. This is for fixed upper airway obstruction. Like if you got vocal cord paralysis. So the person, notice, is almost block-like breathing because when they try to breathe, their vocal cord is kind of messed up. So it doesn't open quite as much, nice and flat. See that? That's what they mean by fixed upper airway obstruction. And then breathing out, same thing, fixed upper airway obstruction. That's like a paralyzed vocal cord. Or you got a child with a foreign body stuck in his trachea. Same thing. See? All right, but anyway, this is just different samples. Oh, look at fibrosis. See that? A real shallow breath compared to, look at this. This person took 6 all the way down to 1. This guy took 3 to 1. See, that's a fibrotic lung. That means it's being squeezed down. And then he struggles to breathe out. But that's somebody who's got fibrosis. Very little span of breathing in because he's got fibrotic lungs. He can't breathe in for that long. All right, but anyway, just put a bunch of examples for you to look at. How does the brain monitor? Okay, pulmonary physiology. There it is, signals from the lungs and chest wall. Signals coming in from the lungs and chest wall. J receptors are found in the interstitial of your lungs. This is for anybody with interstitial lung disease. Ashley, who has interstitial lung disease, restrictive or obstructive? Restrictive. All the restrictives have their J receptors firing like crazy. This senses interstitial particles and makes you breathe in more. That's why restrictive, they're tachypnic, but they're spending more time breathing in because these guys make you breathe in more. Prolonged inspiratory phase, like I demonstrated for you. Versus slow adaptive receptors, Sandy, they're found in the ribs, especially the sternocostal junctions. They monitor how much your lungs inflate. They're stretching. It says, hey, exhale, would you? See, because you're pulling a rubber band. I say, hey, you're pulling too much. Exhale. They sense stretch and inflation. They cause exhalation. So who's getting the signal to exhale more, Anders? Restrictive or obstructive? Who's getting the signal to exhale? Exhale. The inhale is J receptors. To exhale more, that's obstructive. That's why they have prolonged expiratory phase, pursed lips, all that stuff they're always describing. Sandeep? The pulmonary function test we're looking at before, yes? That graph had everything on it. What do you mean, read the other way? Okay, let me see how far back I gotta go. I can't remember. Wait a minute. Which one? This one here?
No, forward.
Go here?
This one, yeah.
Okay.
Like if we look at the first, like normal, right?
Okay.
Where 1 is, right? Because you were tracing it from left to right. Isn't breathing process going to be right to left? And then that 1 would be your residual volume. And then the 6 on the left side would be your.
Oh, okay. You're right. Yeah, I think I made my arrow go this way, but it's actually this way. You're right. I didn't, because you start out from a lower number and then go to a higher number. So that makes sense. Yeah. So I think I did move my arrow the wrong way. Yeah. So you're right. Very good. All right. But any other questions? I just want to make sure I didn't fool anybody else. I made my arrow go this way, but I didn't look at numbers carefully. They're going this way. So that means you got to go this way and then this way. So notice the most effort is at the beginning of breathing out. See that? Yeah. So same thing, most effort is when you're starting to breathe in. Okay. So it's always there. And then you expend a lot of effort. Remember, you can blow out 80% of everything in just 1 second. That's what they're talking about right here. 1 second. You got most of it already blown out. Then the other 4 seconds is to blow the rest of it out. All right. Good point. All right. Monitoring J receptors, monitor anything or sense anything in the interstitium. That would be all the restricted lung diseases. They all have interstitial particles. All the pneumoconioses, interstitial particles. Whereas when you got hyperinflation from obstructive, then the slow adaptive receptors are the ones who are firing. And that's why now you spend more time breathing out. The same way restrictors spend a lot more time breathing in. Any questions on those two? I noticed they're talking about here the pons and the medulla. The medulla does basic breathing pattern, then the pons responds to your environment. Breathe more, breathe less, and that's how it modifies it. Like when you're scared, you breathe more. When you're sympathetic, you breathe more. But when you're tired, you breathe less. So that's the pons responding to the environment. And here comes the sinuses. Yes, we're all airheads. Don't deny it. All right, so sinuses. You have 4 sets of 2, total of 8. When I was born with me. Meaning what? Maxillaris ethmoids are there at birth. That's how I remember that. I was born with me. Maxillaris ethmoids are there at birth. They love to ask that question. Which sinuses are present at birth? Only 2. Sphenoidals come in after age 2. Frontals come in last after age 4. What's going on with these pockets in your head? Well, let's see. Montessori. You got cilia in your sinuses. Remember, the sinuses are continuous with your respiratory tract. If your head moves to one direction, the hair cells bend to the opposite direction. Everybody understand? That's what your brain actually monitors. So the opposite direction, as the bending tells me that's the side your head just moved. So if your hair cells bend to the left, the head just moved to the right. If the hair bends to the right, then your head just moved to the left. Sinusitis is what we care about. If you have inflammation of your sinuses, what problems are you going to run into? All right. That means the sinuses fill up with fluid. All of a sudden, hair cells go nuts every time you move your head. Because let's say I move my head to the right because I got allergies, as you already know. If my head moves to the right, the hair cells move to the left. If there's fluid in there, they're moving the fluid and beating it this way. Everybody follow? But that fluid will hit the wall of my sinuses on that side and come right back here. And my head didn't move. But my brain doesn't know the difference because he sees the hair cells move again. So sinusitis, when I start feeling like I'm moving around the environment, that's called dizziness. That's why sinusitis causes dizziness. When I feel like the room is spinning around me, same movement, that's called vertigo. That's why sinusitis also causes vertigo. And that's why before I started these allergy shots I get, my goodness, I would have so much vertigo I could barely move. Because the room was spinning. I'm trying to hold myself from falling. You feel like you're about to fall to the ground. The brain says, hey, the room is moving. And so it was just so weird. Every time I walked, I was like, oh, I got to hold on to the wall. I thought, okay, I need a cane or something. It's like, I don't even know what I'm doing. So you're surfing in there, right? Because your brain keeps saying, you're moving. And I'm saying, no, I'm not moving. The brain says, hey, the room is spinning. I said, no, it's not spinning. But I don't know that. I'm just feeling like the room is moving. So all of a sudden, before I'm losing all my balance. Okay? So sinusitis can cause dizziness when you think you're spinning, vertigo when you feel the room is spinning. Everybody understand the difference? When somebody says, I felt dizzy, you always got to ask them, did you feel like you were moving or the room was moving? Because everybody calls everything dizziness. But you got to know the difference as a doctor. Sinusitis, folks, the most common cause of sinusitis is a viral infection. No, sorry. Before that, allergies. Doesn't even need a virus. Allergies, number one. That's what causes mine. And you got millions and millions of people with allergies, so that's why it's number one. Then viruses are number 2, which means the majority of sinus infections, you don't have to treat it. Just symptomatic treatment. A little antihistamine to unplug your nose. They got these rinses now. You guys have seen it, the water rinse, the potty, the what do they call it? Neti pot, yeah, to rinse your nostrils. You blast the water into one side, comes out the other side. Just rinse the bugs out of there. That's been shown to make people feel better and decrease their symptoms. Makes sense. Everybody understand? Okay. Then when you have bacterial sinusitis, okay, how do we know you have bacterial sinusitis? 2 clues. Number 1, symptoms beyond 7 days. They say if somebody still has symptoms after 7 to 10 days, you probably need to treat them. That's usually bacterial at that point. And the bacteria, the same thing as all the respiratory tract. Strep pneumonia, H. influenza, Neisseria catarrhalis. And what's the drug of choice for it? Acid. Antibiotic for respiratory infections is what? Is amoxicillin. So no different here. If they're not better within 7 days, add clavulanic acid, repeat. Okay? But sinusitis, tree symptomatic, is just a virus most of the time. So the second clue that you have a bacterial sinusitis is called second sickening. It means the person just had a little runny nose, nasal congestion, sinusitis. You can feel the pressure in the sinuses. And everything was going well, and let's say 4 days later, 5 days later, ooh, the pain becomes real excruciating. A bacteria just took over. Because viruses make it easier for bacteria to invade. That's why they call it second sickening. Because you already knew how, the mild illness you had, and I was, ooh, and then it got worse. And that's an infection that just started up. Treat it with antibiotics. I know. The sinusitis, the reason for the headache is increasing the cranial pressure. That's correct, because there's fluid in there that should not be in there. Yeah. And then swelling. Sinusitis. Oh, yeah. The most common sinusitis is maxillary sinusitis. Why? It's the only one that drains upward against gravity and then into your nostrils. Everybody else is draining straight down with gravity. So that's why with maxillary sinus, it's hard to clean it all up. Because you got to wait till the cilia pull all that mucus up and then down into your nostrils. Okay? That's why you see some people hanging upside down to drain their sinuses. All right, any questions on sinusitis? So in sinusitis, we don't run any tests. We don't do x-rays, we don't do CT scans, don't fall for that. Symptomatic. So how do I know you got frontal? Pain right above your eye. Sphenoidal, pain right behind your eyes. Ethmoid, pain right here at the bridge of your nose. And maxillary, pain in your cheeks. And it hurts when you bite down on food. So history is what we go by. All right, so that's sinusitis. Then we got aortic and carotid bodies. If you guys remember, we did aortic and carotid sinus. That was for baroreceptor. That's for volume. This is the body. These are called chemoreceptors. They measure chemicals. So aortic body is found in the arch of aorta, right in the middle. Measures CO2, pH, and hydrogen ions. Notice, Sandeep, nobody measured PO2. That means blood going around the aorta to your body. Nobody measures the PO2. Do you see that, Rachel? That's why the periphery of your body, folks, is most affected by hypoxia. Nobody measured it. So it's real sensitive. So you got PO2 sensors in all arterioles. And when they measure that just PO2 is low, what do you want to happen, Halima? Do you want the arterioles to dilate or constrict? What? I said, what do you want the arterioles to do? The arterioles have PO2 sensors. So when the PO2 is low, they'll sense it. Because remember, aortic body never measured it. So that's why they're sensitive to it. All right, so when they measure the CO2 is low, what do you want the arterioles to do? Constrict or dilate? Why do you want them to dilate? Make sense of it for me. Let's see if Melissa can help you. What's that? No, she's saying that hypoxia should make the arterioles dilate. Why should they dilate? Okay, what are you saying? You took back over? What are you doing? To increase blood flow and give me some oxygen. Everybody understand? I want you guys to just use simple thinking to remember the information. Because if you're hypoxic, that means, oh, hey, we need some more oxygen here. Then dilate, bring more blood with oxygen down here. That's how to remember how it works. Look at the carotid body. Saba. Carotid body, look at the bifurcation of your internal carotids right above your carotid sinus. What does the carotid sinus respond to? I can't remember. Saba says stretch, right? Volume. Okay, look at this. Carotid body measures PO2, PCO2, pH, and hydrogen ions. Now, it makes sense that the carotid body should measure everything. Why? Because your brain's the most important organ. And you better measure everything going up there. So your brain is therefore more sensitive to hypercarbia. That means high CO2. Peripheral tissue, more sensitive to hypoxia. Your brain is more sensitive to hypercarbia. Any questions on that? Okay. So the brain is more sensitive to elevated PCO2, Bailey. More sensitive to PCO2, because remember the brain responds to CO2 before it responds to hypoxia. But if you got hypoxia and hypercarbia at the same time, then it's a synergistic effect. You follow? That's because if your PCO2 is elevated, are you having trouble with diffusion or ventilation? Yeah. You have a problem with ventilation. The brain says, hey, man, you're not ventilating. Then the PO2 goes down, and the brain will say you're having trouble with what? Yeah, diffusion or perfusion. In other words, hypercarbia tells the brain, hey, you're not breathing out. Hypoxia tells the brain, hey, you're not breathing in either. So what's the brain say? Oh, man, you just died. Wake up! That's why you wake up suddenly in OSA, because that's the two signals. Because when you're overweight, a lot of adipose around your neck, what happens when you hit REM? The fat tissue just collapses your airway. You cannot breathe in or out. And that's why all of a sudden the PO2 drops like this, PCO2 rises like this. The two signals give you this sudden jolt that says, what, man, you just died. And it's like, and goes right back to snoring. Okay? And that's why when they wake up in the morning, they don't feel refreshed. They never spend that much time in the REM. Every time they fall down the REM, airway closes off again, we're right back where we started. And now at least you know what we look for in a sleep study, because they'll ask you what's the sleep study going to show. They always say hypopnic, that means breathing stops. Hyperpnic, because you wake up, start breathing real fast. That's what we measure. And also they got PO2 and PCO2 monitors too. You can measure that as extra information. Okay? Now, forms of CO2 for your brain, Steve. 90% of CO2 in your brain is a form of bicarb, or 90% of CO2 in the blood. Let me say it that way. The brain doesn't take all this bicarb. 90% of the CO2 in your blood is a form of bicarb. Now, that's a trick question. Why? They'll ask you, how much, where do you find most of your CO2? CO2 is an acid. Doesn't make sense that most of it's in the face of a base, unless you understood what I just explained. Okay? 90% of your CO2 is a form of bicarb. I'll show you why in a second. 7% is attached to hemoglobin on a carboxy terminal and the amino terminal. Only 3% is dissolved in the blood. Only 3%, Ina. The 3% that's dissolved in the blood is the only one that can get into your brain. This is the one that affects your breathing. And this is one that the brain is more sensitive to. Carbon dioxide dissolved in your blood. So that means who has a higher dissolved CO2 content, either restrictive or obstructive? Obstructive, because they have a higher PCO2. Does that make sense to you, Karen? Make sense to you, Melissa? 0.03 times whatever higher number is higher than a lower number. Everybody understand? Restrictive have a low CO2 because they're hyperventilating. So because the brain of somebody with COPD sees more dissolved carbon dioxide every day, eventually, now this is years down the line, they'll just desensitize the CO2 receptor and said, doggone, I keep asking him to exhale and he just won't. He doesn't know that you can't. You're exhaling, but no carbon dioxide is leaving. So after years of having high CO2, your brain will become desensitized to CO2. That means the brain will force you, the obstructive lung disease patient, now we call you COPD, will force you to let your PO2 drop because that's the only other signal left. Everybody understand that? All of a sudden, as you enter end-stage COPD, their PO2 actually drops. They're doing that on purpose because that's the only other signal the brain responds to. Is either you respond to PCO2 or respond to low PO2. Well, the CO2 receptors got desensitized. It's not responding anymore. Only thing I can respond to from your brain is hypoxia. So I'm going to force you to let your PO2 drop. Number PO2 was what number, Sandra? Normal PO2, 60 to 100, it's around 80. So that's why they'll let the PO2 run between 55 and 60. Notice, just slightly low. But guess what? That's all it takes to keep you breathing. Otherwise, you would have stopped breathing because there's no more signal. You understand that, Halima? You understand what I just said? You understand, Melissa? Okay, I'm not convinced. I'm going to give you a question, see if you do. And let me say, you said you understood. You got to show me that you do. And here's your question. So here's somebody with COPD, and they're desensitized. They're keeping themselves PO2, 55 to 60, to keep the respiratory drive. And here you come as an ER doctor, because they showed up in the ER, and you slap a whole bunch of oxygen in their face. You will shut off their breathing. This is that message, I always say you can kill somebody with oxygen, especially COPD. Because if you give them a whole bunch of oxygen, you'll desensitize their hypoxic receptors. And that's it, shut up breathing. They'll die right there in the ER for you. Or go into a coma like the one I saw. Just went straight into a coma. That's because it got shut off. Because the ER physician did not know. You can't just give them a whole bunch of oxygen. So what they do on the test, they give you somebody with COPD, meaning they'll tell you he's like 60s or 70s, and he's had it for the last 40, 50 years. You gotta know that's pretty chronic. And he comes into that ER, and they put a couple of liters of oxygen in his face. And all of a sudden, he gets more delirious. That's because he's hypoxic. If you didn't know what I just explained to you, the answer about taking oxygen out of his face wouldn't make sense to you. Because you think he's delirious, he needs more oxygen. No, it's the opposite. You're turning off his breathing, and he's fighting you. He's trying to tell you, get the oxygen out of my face. You're shutting off the only signal I got. So whenever you see COPD, and as soon as they give him oxygen and they get more delirious, that's somebody who's been desensitized. Take the oxygen out of your face, or else you're going to kill him. On him. That's CO2 narcosis. That's exactly what they call it. I told you, that's always a word game. They just give a new title. All of a sudden, physicians have no idea what it is anymore. That's because they never learned it here, where it's basic. Okay? So get the oxygen out of your face, folks. So how do I know? Do you suspect they're desensitized? I got 3 clues. Number 1, they're barrel chested. What's all this in here? CO2. How come you hold on to it? Because you don't feel it. I mean, think about it. Barrel chest, that's all carbon dioxide. That means you got a CO2 75, 85, 90. And it doesn't even bother you. For you and I, if your PCO2 hits 60, you pass out. And they're walking around CO2 at 90. I've seen 100 and something. Didn't bother the guy at all. That's because he's been this way for decades. Okay? So that's the first clue. Second clue. You see a very high bicarb on his blood gas. It takes about 5 minutes to come back. If that bicarb is very high, that's buffering the high CO2 that he's had for years. Because you can't raise your bicarb to 40s acutely. That's impossible. Remember, the kidney takes 2 to 3 days to get anything done. Just so you don't talk yourself into, well, it's because he's compensating. He can't compensate the same day. He's had this for years. Okay? Or if you're lucky enough to see the CO2 in the real high numbers, meaning he's hyperpnic, so he's breathing 30, 40 times a minute, but his PCO2 is still 87. You say, oh, that means this guy's desensitized a long time ago. So 3 ways to detect that your COPD is desensitized, meaning don't give him a lot of oxygen or else you might just kill him with that oxygen. You would think every time oxygen helps people, except in COPD. You might actually kill them. Yes, sir. That's correct. So if you put in somebody with obstructive lung disease, well, COPD on a ventilator, you got to go with very low FiO2s. In the air here is 21%. You may start out with like 23, 24%, just low number. You see your blood gas come back and you see all the high bicarb, high PCO, you say, oh, forget it. Turn off the oxygen. He doesn't even need it. Okay. In fact, he comes in hypoxic. We send him home hypoxic. I had to learn that from another attendant who was trained under Dr. Rick. He's the one that picked it up. His partners didn't pick it up. We had a guy on a ventilator, and every weekend when we tried to wean him off the ventilator, we said, oh man, look, his PO2 dropped. We put like 2 liters on him. Psst, the guy was right back in a coma. And we put him up in the ICU on the ventilator again. We ventilated him for a whole week. Come the next weekend, we try to get this guy out of here. And PO2 low. Give him a little taste of oxygen. Put 2 liters in his face, psst, back in a coma, back up to the ICU. We did this 3 times. Till the 3rd week, here comes the partner. And he said, how come this guy's here? What's going on? And we explained what's going on. He said, oh man, don't you guys understand pulmonary physiology? He came in hypoxia, he has to leave here hypoxia. As a resident, you're always saying, if it's low, bring it up, if it's down, if it's high, bring it down. We weren't trying to reason out why he keeps doing it. None of us knew that we were the one causing this guy to go in and out of ICU for 3 weeks. Because we're busy trying to correct his PO2. You got to let him go home hypoxic. All right, all you do is document that you know what you're doing. And that way, in case the hospital gets audited, they say, oh yeah, well, the guy got COPD. Okay, that's fine. Hypoxia is okay. Okay? All right. Now, what about this bicarb made from CO2? Let me show you how that happens. It's called a chloride shift in your red blood cells on the periphery. All right. What do you got? First, you got CO2 and water. If you guys remember that. We've done it in the sweat glands. We've done the salivary glands. Same old stuff. Take CO2 and water coming in from the tissues. Carbonic anhydrase turns into carbonic acid, which then breaks up spontaneously the bicarbonate H+, right? And then to get this bicarb out of the red blood cell, look at that, you exchange it for chloride. This is a chloride shift. That means now the chloride is inside, the bicarb is out there in the blood. That's to help you buffer the acidosis. It serves a purpose. But that means your venous chloride is now higher or lower, Karen. Chloride is coming into the red blood cell. The venous blood is outside of this RBC. So the venous chloride is lower because it's all in the RBCs. When you get to the lungs, folks, what do? Reverse everything you see here. Okay, reverse the whole reaction, and you go back to CO2 and water and exhale CO2 and water. When you exhale, you got humidified carbon dioxide coming out of your mouth or your nose. That's because you just reverse everything you see here. So that's why arterial chloride is higher, because it just came from the lungs. They love to ask, explain that. Carbonic anhydrase, if they just want an enzyme, okay, it's called a chloride shift. They just want to give it a name. But this is how you bring bicarb out of a cell, but it went in as CO2. So it's for real. 90% of CO2 is swimming around the blood as bicarb. Respiratory centers, the medulla controls your basic respirations, and then the pons responds to the environment. As you see here in the pons, you got apneusic center and a pneumotactic center. Pneumotactic center is at the top of the pons, apneusic center is at the bottom of the pons. Pneumotactic center makes you breathe out, so it prevents pneumothorax. That's how I remember that. Apneusic center prevents apnea, so it makes you breathe in. Because apnea means lack of inspiratory effort with or without bradycardia for at least 20 seconds. So apneusic makes you breathe in more, pneumotactic makes you breathe out more. So you know which one is for restrictive, which one's for obstructive. Pons. Which cranial nerves I find in the pons, Ida? 9, 10, 11, 12, you're down in the medulla now. Remember, 3 groups of 4, but 3 and 4 outside the brain. So 3 and 4 in the midbrain, 5 through 8 in the pons, 9 through 12 in the medulla. All right. Medulla responsible for your basic functions. It has a respiratory rate of 8 to 10. Jess, respiratory rate of 8 to 10. Is that faster or slower than when you're wide awake? Slower, because we have 12 to 16 when we're wide awake. So if we're breathing much slower when when the medulla is the only one working, i.e. when you're asleep, okay, is your PO2 can be higher or lower? Lower. Everybody following this argument? The PO2 is lower. What's your pulmonary vessels do when you're sleeping? Constrict or dilate? Oxygen is the pulmonary vasodilator. So hypoxia is the opposite. They're going to constrict. So if you constrict your pulmonary vessels when you're asleep, what happens to pulmonary pressure? Increase pulmonary blood flow. Decrease pulmonary capillary wedge pressure while you're asleep. I thought wedge pressure is total flow. That's what I'm saying. It's talking out. Now don't just start stabbing it with guesses. So hypoxia when you're asleep says pulmonary resistance and pulmonary pressure both have to rise. And therefore pulmonary blood flow has to drop. So capillary wedge pressure has to drop. Everybody following that so far? Is that going to create a resistance or volume problem? The resistance is going to affect pulmonary or aortic valve. Pulmonic valve going to affect S1 or S2? S1? S1 is mitral tricuspid. As I said, talk it out. I know, but that's why I know when you guys are guessing, because now it doesn't even match anything I taught you. That means you let the brain just start to stab out with a guess again. No, take your time. That means if I ask it's going to affect S1, S2. Actually, what was S1 again? Okay, what is S2 again? We're on pulmonary. S2 is pulmonary. That's how you know. There's no talking 7 to S1. All right, so it's going to affect S2, which means it's going to get louder or softer. I didn't say when you inhale. I just said it's going to get louder or softer when you have high pulmonary resistance. You know, it's louder when you have high resistance. Okay. So that means, is the right ventricle going to hypertrophy or dilate? Hypertrophy get thicker or thinner? Thicker, contract harder or softer? Harder, which makes S1 louder or softer? Louder, which means CVP will rise or fall? Rise. That's how it's done, girl. Take your time. Okay? So imagine, therefore, listen to me carefully. Imagine if you make this even more pronounced because you're overweight, because you're obese, and you got fat around the neck cutting off your airway while you're sleeping. That means you're going to develop pulmonary hypertension one night and your right ventricle cannot pump against it. That's why they die in their sleep. So what if it was a baby whose face keeps going into the blanket like that? Call it SIDS if you like. Sounds like the same thing to me. Why do athletes who are overweight and obese, how come they die in their sleep? There's been football players who die in their sleep. There it is right there. OSA is what's going to kill you. You're going to die in your sleep one night. Why? Because pulmonary resistance becomes so high, your right ventricle says, I can't pump against this. And then that's it. They die in their sleep. That's why they say, folks, when somebody starts snoring and it's creating a problem, they're tired the next day, you got to do a sleep study. Because if it's significant, you got to treat them. Because it's not something small. One day they will die at a young age, 40s, early 50s. That's it. Just dying in sleep and nobody. I said, oh, Mr. Johnson died. But it could have been prevented. Could have been prevented. That's why we give them oxygen and put on their nose at night. Okay? All right. Brain dead. What's brain dead? No function above your medulla. Criteria for brain dead. Number one. Okay? I got to prove your cortex no longer responds to the environment. How do I do that? I check all your senses. Remember, all sensory information except olfactory must go to cortex. Okay? No, sorry. Even olfactory goes. It just only olfactory does not go to thalamus. I misspoke. All right. So all sensory information goes to the cortex. So we check all those senses, nothing. After you check sensors, then you check the what's it called? That basic. Hang on. No. The cranial nerves. There's a term for it. Oh, damn. What am I drawing back on the term? No, the cranial nerves. Collectively are called something. So we check the cortex. Oh, second thing, prove it with a flat EEG. We just pull up an EEG machine by the bedside, hook them all up, nothing. So two things must prove the cortex is gone. Oh, it just came to me and it disappeared. Brainstem, thank you. Then the next thing you do is check all the cranial nerves, brainstem. And of course, you have a different test for every cranial nerve, nothing, not responding at all. That means brainstem is gone too. Okay. Then you run an apnea test. Take them off the ventilator for about 5 minutes, 5 to 10 minutes, and nothing. No change in respiratory rate, no change in anything. That's how you know they're not sensing a thing. And then 2 doctors must agree, take them off the ventilator. They've gotten to a point where you don't have to fight with the family anymore, folks. Because in the old days, doctors would just say, hey, can we take your mommy off the ventilator? What do you mean take my mommy off the ventilator? No, you can't take my mommy off the ventilator. Families didn't like you ask them that question because the families thought they're then responsible for killing their own mother. Nobody wants that. They prefer if you just come and tell them, here's what we think we ought to do. You say, we're going to keep your mom comfortable. But right now, I've checked her. She meets the criteria for brain dead. Dr. Wilson here has checked her. He agrees she meets the criteria for brain dead. So we're going to keep her as comfortable as we can until she makes the transition. And we'll let you know when that happens. And the family said, thank you, doctor. That's it. Otherwise, if you ask for permission, you just created a court case. They'll say no. You don't have to take them to court to get mom off that ventilator. Because you can keep a person alive on ventilator for years, folks, but you're paying the bill now because they're not paying it. You're keeping a dead body alive. All right. So that's why they've created this criteria. So you don't have to get yourself into legal trouble and then the hospital stuck with this huge bill that nobody can pay. Okay. So brain dead. That's the criteria for brain dead. Next, comatose. What is comatose? A comatose says your cerebral cortex is still alive. That means when you test their senses, they respond. How they respond? You may see that their heart will race. But you'll see a response. It just won't be with their voice. Think about, Melissa, you have a question? Yeah. Yeah. Yeah, so she works at a hospital where there's a unit that keep brain dead people or comatose patients alive for years. The key is you got to know the difference between brain dead and comatose. Brain dead, if you present it properly to the family, you don't have to keep them alive for years. That's what it's going to do if you present it the wrong way. They think, Mom, you're still alive. Yeah, if they respond to sensory information, that means they're still alive. That's comatose. They're not brain dead. Yeah. Think about why we tell families, talk to them. They can hear you. You just can't respond. We tell them, hey, put the TV on your favorite soap opera. They can hear it. People are comatose and they come out of it years later. They can tell you what happened on their favorite soap opera, which means they heard it every day when it was playing. Play their favorite music. They can hear it. They just can't respond to you. But we know their heart rate can change, which means they're responding. That's how you know they're comatose. All right? Cynthia, your question. Patients who are brain dead can still take breaths on their own. Where's that breath coming from? That's why, yeah, so you should have fired off your question before I fired mine off. So her question is, where's that breathing coming from? Let me ask Asit. You asked the wrong person. Sabu, where's the breathing coming from? She said the patient's brain dead. They can breathe. Well, how are they breathing? Not from the ventilator. You can turn off ventilators, can see it breathe. Mitchell. Which part of the brainstem? You're right so far. Huh? No, not the pons. The medulla. The pons responds to the environment. They cannot respond. Medulla breathes 8 to 10 breaths per minute. So when somebody's brain dead, you can take them off ventilator, still breathing 8 to 10. But if you slap them, 8 to 10. Stick them with a needle, 8 to 10. That's how you know. They're not alive. That's just normal medullary breathing. You see, before when doctors did not understand that, that's why they end up keeping these people alive for years because they thought they were still alive. They're not alive. That's why they call it vegetative state. They're dead. They're just a vegetable at this point. But that's why they created the criteria. So you, the doctor, don't create another dead body to keep in a ventilator for years because the family is not going to pay that bill and you're going to be stuck with it. Yeah. The longest I've heard of a comatose patient stay alive on a ventilator, 17 years. And then woke up like nothing happened. That's how you know they were alive the whole time. Yeah. Well, when you're comatose, before Affordable Care Act, insurance policies ran out after $2 million. That's only a few months. That's it. Policy gone. Your family would have to declare bankruptcy on your behalf so that the state would have to pick up the bill. So that's what everybody did. Sold off everything they owned, and that you're bankrupt now. The state has to pay for you. The problem is, if you have the nerve to wake back up, the state says, we got a present waiting for you. It's called the bill for 17 years of hospitalization. Poor guy, he died right in front of the cashier, man. I'm sure he said, hell, I should just stay in a coma, man. Can you imagine a bill for 17 years of staying in a nursing home? They actually moved to a nursing home. 17 nursing home bills like anywhere between $40,000 to $50,000 a year. Times 17. I mean, oh, come on, millions of dollars plus all the procedures they had to do for him. It was crazy. But anyway, that's the rules. Yes, Anna. The biggest regulator of basic respirations is medulla. The biggest regulator as far as responding to the environment is your pons. It depends on how they phrase the question. Yeah, obtunded to comatose is somebody who just looks like they're completely out of it. That's obtunded. Once I see that only sensory information is registering, then they're comatose. Yeah. So he's saying opioids. Why is it when somebody's fully intoxicated with opioids, all you see is respiratory rate of 8 to 10? That's because you just put the patient into a coma. Yeah. All right. Gabriel, you have a question?
Yeah, I had a quick question about back when we were discussing COPD and their response to hypoxia. understand that we shouldn't give them too much oxygen because they'll end up in a coma, but I think I got confused as to what the pathophysiology of the desensitization was actually.
No, it's just the receptors that sense PCO2. They've been firing for years, and yet your CO2 is never falling below 40. One day they just said, I'm done firing, and they become desensitized. That's it. This is like any receptor. Just like you get downregulation when you have too much glucose or too much insulin. Why do you get insulin resistance? Same thing. If you keep stimulating receptor without giving it time to reset, it'll desensitize on you.
Okay, so they continue to accumulate COPD through the progression of their disease, and they get to a point where they just don't respond to
they just
to
don't respond
CO2.
anymore. Correct.
Okay,
Yeah.
that sounds
It's only
good.
when you've been following them over years, then you can tell exactly when they've gone to the other side.
That makes
so that's
sense. Thank
medulla.
you.
Yeah, no problem. PONS, response to the environment, locked-in syndrome. We talked about damage to PONS. Patient only blinks because the blink center is separate from the PONS. Blink once for yes, two for no, whatever. The PONS, however, is the most sensitive osmotic shifts. Remember, we talked about the central pontine demyelinolysis. And that's why Solange knows you shouldn't let sodium change any faster than how many milligrams per hour again? Which one? Not 5, Zena. Not 5. Paul. Meha is 0.5. 5 is a big difference. That's 10 times. Be careful. You got to put a decimal point in there. 0.5 per hour or 10 to 12 per day. And glucose should not change any faster than Adnan. 100 milligrams per hour. Amnesic extended pneumotactic, I already talked about. Amnesic at the bottom, pneumotactic at the top of the PONS. These are breathing patterns. Look at normal. You inhale for half a second, breathe out for half a second. Inhale for half a second, breathe out for half a second. That's normal breathing. Bradypnea, slow breathing. See that? Still half a second, but much slower. Fewer breaths per minute. Okay? Tachypnea, look at that. More breaths per minute. See that? And you already know that tachypnea and dyspnea is how almost every disease presents, so it doesn't really tell me anything. All right, sighing, see that? After you've taken some normal breaths, all of a sudden your PCO2 sensors at the top of your lungs sense the CO2. It means you got a column of carbon dioxide. You need to empty it out. So make sure you empty it out. Apnea, the person just kind of pauses. No inspiratory effort, but minimum 20 seconds with or without bradycardia. Think about premature babies. They have this all the time, right? What's the mechanism? Their brain is not fully wired yet. They were premature, so their brain is not fully wired. So they don't always get the signal to inhale. How can we get them to breathe more? We can put them into a sympathetic state. What drugs do we use, Sandeep? No, not serotonin. Melissa. Central apnea in the premature babies. I gave you guys these drugs. Linian. Not cortisol. Angie. Not epi. Leslie.
Caffeine.
It's called caffeine and theophylline. You guys forgot already. Make sure you keep reviewing this stuff. All you do is put them into a sympathetic tone. Don't we breathe faster in a sympathetic tone? All you do is buying time. And then one day they start going back to all the apnea disappears. That's how you know the brain is fully wired now. And you can stop the drug. Shane Stokes is when you pause. Shane Stokes means your medulla is missing something it needs, like oxygen, glucose, okay? And then Kussmaul breathing. Again, Kussmaul sign is not saying it's the same Dr. Kussmaul, but this is rapid but deep breathing. If you're breathing this deeply, you're trying to blow off CO2. Who would want to blow off a lot of CO2, Michael? Why are they blowing off so much CO2? To make up for, metabolic acidosis. You compensate. So anytime you see Kussmaul breathing, it means they have metabolic acidosis, okay? And if they have metabolic acidosis, then we have to figure out a way to organize that knowledge. So follow me again. Rapid deep breathing means you got metabolic acidosis. Then the first thing we do is calculate an anion gap. Anion gap equals the two positives, sodium plus potassium, minus two negative, chloride and bicarb. Normal 10 to 12. If you use potassium, that's 12 to 16. I don't use potassium because it's such a small amount. That's why it's best to just ignore it. That's why you take it up to 16 if you use it, because potassium is around 4. So if you just take sodium and subtract the 2 negatives, that's your anion gap. You got metabolic acidosis, your bicarb is low iodine, right? So if your anion gap is normal, then that means you must have raised the chloride to keep everything the same. That's why they also call it hyperchloremic metabolic acidosis. Then all you gotta do is think about, why would you lose bicarb out of your body, Ida? How does that happen? Huh? What drug? Okay, maybe it's acetylzolline is making you pee out your bicarb. What's the number one way, Anders? Diarrhea is number one. And if they want a drug, then your answer is correct. You follow? Yeah, diarrhea is number one, because diarrhea start in the duodenum, like I showed you before. So you lose all this bicarb that got dumped in the duodenum. And so that's the number one cause of normal anion gap, metabolic acidosis. If they want a drug, you pick acetylzolline. Okay. Victoria, you have a question?
Yeah, so I've noticed NVMe and UWorld a lot of times only put sodium, chloride, and bicarb. So
Right.
do we just say generally we should just use 10 to 12 as an anion gap? Because I've been hearing, I heard from other resources up to 16, but I never understood that's with.
It's up to
potassium
16 because you add the 4 for potassium. That's why it's the same thing. Yeah.
Okay.
So that's why I ignore potassium. So you get the same thing. But if your anion gap is increased, it means you have another acid in your system. Because if it's increased, that means your chloride did not change. That's because you have another anion, another negative charge floating around your blood. That's because every acid has an anion. So the real problem is you have another acid floating around in your system, and there's the mnemonic. Mule pack, mud piles, take your pick. See? Then you got to figure out which one they want. So how do I figure it out? Methanol is turned into what? Anybody remember what this turned into? Nolan? Formic acid, which causes visual problems. So if they come talking about blindness or visual disturbance, I know it's methanol poisoning. What's the treatment for that, Nolan? Omeprazole, block alcohol dehydrogenase, you don't have a problem anymore. Remember, same thing with ethylene glycol poison. All right, that's methanol. Uremia, severe renal failure. What's the most common cause of renal failure in children, Maria says? HUS in adults, Stephen says. In adults, make any sense? Hypertension and diabetes. Yeah. Lactic acid is the most common because it comes with exercise, just basic activity every day. It's lactic acid. Ethanol, they'll tell you the person went on a party Friday night. Easy to remember. Okay. Formaldehyde is a drug that's not even around anymore. Aspirin, obviously, I told you, it's almost always a little teenage girl trying to commit suicide by taking a whole bunch of aspirin. Okay. But we've gone through the 3 acid-based problems you get with aspirin. And then ketosis, somebody who's been starving, or ketoacidosis, DKA. What hormones are responsible for ketones in a person's body? Ida? Man, Cynthia? Glucagon, only glucagon can cause ketogenesis. And the rate-limiting enzyme for ketogenesis is what? Latoria.
I'm unsure.
Gabriel.
I'm also unsure.
All right, Syed.
HMG CoA synthase? Or...
That's correct. No, that's correct. HMG CoA synthase. And what's the number one ketone in your body right now, Olivia?
I am not sure.
Mabel.
Sir.
What's the number one ketone, Mabel?
Is a butyric is start from B is something butyric acid.
That's all right, Mabel. Close enough. I'll give you the point.
Thank you.
Beta hydroxybutyrate. Remember, B for brain. The only one that can cross the blood-brain barrier. All right, but anyway, there's your causes, and it's easy to separate them out. Okay. All right. A couple more slides. What about if I lesion apneusic center? Remember, you get, sorry, your lesion and you get apneusic breathing. It means I've lesioned somewhere between the pneumotactic at the top and apneusic down here at the bottom. There's a lesion right here in the middle. So if you had a stroke, they could do it, okay? But look at this. The person would breathe in for a full second and then pause and then breathe out for a full second. Question is, why is he, if he's pausing like this, how is he breathing out if you lesioned the pneumotactic center? That means the brain can't tell you to breathe out anymore. Why is this person still able to breathe out? Gustavo, any idea? Patient still able to breathe out. Question is why? How? Mayha. Anybody think they know it? Anders. Breathing out is passive. See what happens when you forget basic physiology? You swear it's something more complex than that. Breathing out is passive. You don't need a signal from the brain. That was on my boards many years ago. So that means I had to recognize that this was apneusic breathing because I had it drawn out. Then I had to know where the lesion was. So that means I can't say the brain made you breathe out because you've cut it. And I had to, oh yeah, it's passive. All of a sudden I see my answer. Okay? Apneusic breathing, pneumotactic center desensitized as in COPD. A lesion below the pneumotactic center, but above the apneusic center. Here's what it looks like when you look at the diagram. Okay, the location. Apnea, central apnea is a premature baby that I just described. No inspiratory effort with or without bradycardia in 20 or more seconds. We first start out with an apnea monitor. The apnea monitor has a rubber band with 2 magnets on it, and they stick to each other. Every time a baby breathes, those magnets slide on top of each other, creating electricity. The machine senses electricity, which means he took a breath. But if 20 seconds go by, no electricity, that means that child is not taking a breath. The alarm goes off, and mom knows, go over there and just rub his chest, and he starts breathing again. And then we put the kid on caffeine and theophylline, and now he breathes by himself. We're just buying time. Once he outgrows the apnea, we stop the drug. Obstructive apnea is mobility. Again, it's the adipose tissue around the neck. It just closes up the entire airway once they hit REM. How long before you hit the first REM? Saba. Is what? 90 minutes, yeah, 60 to 90 minutes. How many REMs do you usually have per night, Josh? Yeah, 3 to 5, just a little lower than that. 3 to 5. And remember, you wake up out of REM. That's why you always remember the last dream that you had. All right, so notice, treatment, weight loss is number 1, because obesity is number 1 cause. Then progesterone is number 2. All right, progesterone makes you breathe faster. I remember one time I was teaching a class, and I know my brain picks up things even when I don't want to pick it up. And I was scanning across the class like this. There's some young lady sitting in the middle of the back row. And my brain, as soon as it went by, said, oh, she's menstruating. I was like, why the hell do I want to know she's menstruating? Because I look at your face from here. I can see everybody. I can tell if a female in here starts hyperventilating, you're menstruating. What do I care? I don't care. It's the physio. Yeah, I thought you can't turn off the physio. Sometimes, though, it irritates me now. I pick up some of these things, but I can tell she was menstruating. There it is right there. Progesterone makes you hyperventilate. That means if I ask you what's the blood gas of a pregnant woman, Ida. Respiratory alkalosis for every pregnancy. Look it up, see if I'm wrong. See, it's not so much that the girl is menstruating, it's just helped me to understand, oh, damn, that's why every pregnant woman has this blood gas. I suddenly understood. Why birth control pills give you that same blood gas? Why progesterone implants, Norplant, Explanat? My brain just blew up with a bunch of connections. That's what I mean. That's why I like basic physio. Because all of a sudden, one day, it just explains 1,000 things to you, and you didn't have to read about it. That's what impresses attendings, that you can explain a whole bunch of stuff, and they never really understood it themselves. But you just explained it so beautifully, they actually understand it now. Adam, question. Yeah, you can give Provera to OSA patients. Adam, that's what we used to do. That's before your time. That's what we used to do. We used to give progesterone. And then they start breathing more. However, all of them said they don't want it. They all came off of it. Why was that? Because progesterone causes anger, agitation, weight gain, mood changes. Same thing a woman goes through every month. For the first time, men knew what women went through every month And they said, no, doc, I ain't taking this ever again. I've never met a man who actually stayed on it more than just a couple of doses. They couldn't stand it. The mood changes they were having. So, doc, no, I can't take that drug anymore. But it was actually approved for treatment of apnea, just so you know. All right. CPAP, you got to see the CPAP mask. The problem with that is you got to sleep on your back. It's got to be someone who's comfortable sleeping on his back. I'm not. I like sleeping on my belly, hugging my pillow. So that would never work. Okay. All right. This is why, I don't know if you guys do. Now, most houses are built with 2 master bedrooms. You guys know that? That's because one person is always starting to snore. Whichever one gains the weight first. Remember, husband and wives, as you get older, y'all both, one of you starts to gain a lot of weight. And all of a sudden, somebody starts snoring, the other one's complaining. That's why I was the first one kicked out, so it's okay. Yeah, my wife couldn't take it anymore. So I had to go to the next bedroom and start using that. But I mean, now I'm fine because now I treat my allergies. Mine was allergy related. I mean, I'd be all blocked up here, start snoring like crazy. And it would just keep her up and she didn't like it. Yeah, so, but that's the way it is. So now they're building houses with 2 master bedrooms because they know most husbands and wives, as they've been married for a while, one of them gains weight faster than the other one. And whoever gains weight the fastest will start snoring before the other one, and the other one's going to start complaining. So you might as well have your own bedroom ready to go when you get kicked out. And then surgeries last. We'll carve out your soft palate, so you got a bigger hole back there for oxygen to go through every night. But if they gain the weight back, doesn't matter what you do, they'll gain, the snoring goes right back. Yeah. With COVID, remember that's what they did. They started doing prone ventilation. They put people on ventilator, but put them in a prone position. That means on their belly. If you put me on my belly, what happens? Your airway drops down like that. It opens up. Everybody see that? So more air actually comes through. And all of a sudden, more of them survive. Yes. If they slept on their belly, the only problem is the CPAP machine says you got to sleep on your back. So if you like sleeping on your belly, it doesn't work for you. And that's why most guys didn't like it. Can you breathe better if you sleep on your belly? Yeah, if you sleep perfectly on your belly, yeah, it opens your airway a little more than if you sleep on your back. The problem is at night, they always end up rolling on their back and the same problem will happen. All right, so ladies and apneusics breathe. So this apneusic breathing that we just talked about, Cheyne-Stokes means that your medulla is missing something. So that can happen if what? Hypoglycemia. So late morning or late afternoon. This is late afternoon, last 15 minutes. Before you know, I'm going to hear Cheyne-Stokes in this room. Why? Here's the deal. Throughout the day, I'm watching from this side. If somebody's got too much CO2 in their airway, they yawn. But all you see is this. You don't hear sound. Late morning, 15 minutes before 12, 15 minutes before 4 o'clock. I'm going to hear it because somebody's hypoglycemic. And all of a sudden, now you hear, say, why'd you do that stutter before you yawn? That's not a regular yawn anymore. That's a Cheyne-Stokes yawn. That means your medulla is missing something. It's called glucose. All right. How about if you have ischemia? The 2 that they like to test on, thoracic outlet syndrome. Thoracic outlet syndrome says you got a rib way up here in your neck that shouldn't be there. How do we know, Melissa? Is when you turn your head to the side of that rib, it cuts off blood supply to your medulla, vertebral arteries back here, and wham, you hit the ground. Thoracic outlet syndrome, that's the best clue you're ever gonna get. Turn your head to one side, you're on the ground. And they don't know how they got there, somebody's picking them up. That's classic. Thoracic outlet syndrome. You do an x-ray, you see the ribs, send an orthopedic surgeon to saw it off, cured. Solange. You're passing out because it's cutting off the blood supply to your subclavian, vertebral artery, which provides blood supply to your medulla. Right. That means your basic respiration centers just got cut off. That's why the person drops down. I mean, but no brain damage, nothing done to them because they wake right back up. Yeah. I know. Why baseball players? Because remember, when they're throwing the ball, they wind up in one direction, look one direction, and then they flip around and go the other direction. And so that means if there's any rib anywhere here, or even sometimes they'll, from weightlifting, they'll build up their scalenes. their scalenes can compress their vertebrals, vertebrals, and do the same thing. They pass right out. So his question, why pitchers have a higher incidence of this. What about subclavian steel? This is a good one. Subclavian steel says you got atherosclerosis in your proximal subclavian artery, Ashley. So right here in the neck, you got atherosclerosis. So that if I raise my hand above my shoulder, I kink it completely off. If I do that, then the vertebral arteries to my brain will drain, because there's a vacuum in my arm now, will drain it into my arm. That means you're draining blood away from your medulla. You pass right out. Again, the history is the best clue, folks. They always pass out when they raise their arm above their head. Now, these are 70, 80, 90-year-old people. We're not going to do vascular surgery. They would die in surgery. What do? You get occupational, what do they call it? Occupational health therapists. You get the occupational therapist to go out to their home, survey their house, see where everything is. That means in the kitchen. Don't let grandma have to reach up to get the can of soup. Everything that grandma needs, put it down here on the counter. So she's always reaching down, never up. Everybody follow me? In the bathroom, put everything down on the sink. That way she doesn't have to reach up in the cabinet. I want her reaching down, never up. Because it's just an automatic. You come in the bathroom, reach up, they find it pass out right in front of the cabinet. They don't know why. In the kitchen, looking for Campbell's soup, they keep finding grandma pass out in front of the cabinet. They have no idea. And grandma doesn't know what happened. And they don't know what happened. I told you that history is the best clue, okay? So anyway, the occupational therapist goes in there, gets everything straight, does everything real well. She's so proud of herself or himself, and then they make the cardinal mistake. As they're walking out to the car, they wave to grandma. Oh, don't do that. And notice that there is an automatic response. Somebody waved to you, you want to wave to them, pass out right there on the porch. And now she done cracked her head. So, well, but anyway, we don't do surgery for this. We just teach them how to deal with it. Subclavian steel syndrome. All right, another way to achieve subclavian steel, what if I grab your subclavian for you? It's called a Vulcan claw on Star Trek. All I gotta do is grab your subclavian. And that's why people used to pass. I mean, Spock just did that, right? He would just come grab somebody's subclavian and they would pass out. Everybody always trying to figure out how the hell is the Vulcan claw? Make everybody pass out. There it is right there. All I gotta do is grab your subclavian, you will pass out. Okay, everybody understand that? What if I make your subclavian go into a spasm? Same thing would happen. How do you make it go into a spasm? It's called judo chop. Ring a bell? That's how the judo chop works. If you chop at the right spot, they pass out no matter who they are. No matter how big they are, they go down. Everybody understand that? Yes, Anders. Because it happens suddenly. Remember, it's different when it's progressive. Then the circle wheelers will take over. This is happening suddenly. Spasms happen like that. Before the circle wheelers can even get their blood over here, you pass out. Yeah. So the same thing with the billy club with the police. Beat you with a billy club. Why do you think they always go for your neck? Bam! Because if they hit you just right, spasm, you pass out no matter who you are. Yeah. The guys up in the UK are so good at it. Okay, they don't carry guns. Billy club, man. I'm telling you, man. So they got the old billy club throw off every summer. You know, like Summer Olympics, billy club Olympics. So they're all gathered in a circle and they're waiting for an alarm to go off. And all of a sudden, somebody just robbed the store. Said, you hear the alarm go, oh, I've got this chap, no problem. Billy club off the light post. She'd hit McDonald's sign right there. It should go right around that building here. It should hit the old bloke right in the back of the head, no problem. And all of a sudden, you hear, nowhere. You went, how the hell did that Billy club go around the corner, around the McDonald's sign? Then the guy in the back, boy, I'm telling you, they're that good. It's crazy, but they're that good, folks. They're better trained. That's why in those countries, they don't carry guns. They don't need to. They're that good at it. They can throw it and hit your carotids and your subclavian for you. And people pass right out, no matter how big they are. You know, here in America, they just throw a bullet after you. And that will make sure your carotid will be severed or your subclavian will be severed too. All right, so that's why you don't want to be running for cops in America. All right, folks, there it is, the way you should know it. Here at the bottom, here's just some clues, but these are things we just talked about. Let me go through them real quick for you. Bronchitis acute, increased mucus production, less than 7 days. Chronic bronchitis, mucus production increase for at least 3 consecutive months of 2 consecutive years. That's also known as blue bloater. Bronchiolitis, all the signs and symptoms of asthma, but it's infectious. They outgrow it by age 2. Asthma, reversible, reactive, small airway disease, right? The key is reversible. It's the only reversible obstructive lung disease there is. Intrinsic asthma is genetic. It's set off by cold air and common cold. Extrinsic means environmental. Pet dander, roach droppings. What's another one? Pet dropping. Yeah, pollen can set them off. Yeah, it's always things outside of you. That's why I call it extrinsic asthma. Okay, the history makes the diagnosis easily. Cystic fibrosis, we talked about, looking at chromosome 7, CFTR gene. All right, Delta 508, that just means that spot 508, the wrong amino acids there. So missense mutation. Remember I told you there's 2 new drugs out there now that actually, one brings the receptor to the membrane, the other one opens up the receptor. Is amazing. And they're reversing the disease. It's just fantastic from what I'm hearing. All right, that's cystic fibrosis. Again, first week of life. It's called Meconium ileus. They can't even pass the first stool. Then it affects the GI, they get diarrhea. And then after that, affects their lungs, they get respiratory disease, and they die of bronchiectasis like every other obstructive lung disease. Bronchiectasis is the end stage for every obstructive lung disease, and emphysema is the only restrictive that behaves like an obstructive lung disease. The difference is paranephrinar, alpha-nitroglycerin deficiency. Centroacinar, smoke comes through the middle, so smoking causes it. Distal acinar, aging. Distal blood supply. And then bullous, bubbles, pneumatoceles, Staph aureus, and Pseudomonas. All right, just a few key clues for you, that's all. All right, folks, you've been empowered big time. All right, let me set up reproductive before I let you guys go. No way, I'm just gonna set it up. That way I just go right into the lecture on Monday. On Monday, hell, sorry, Tuesday. All right, see ya. Let me find it here. All right, reproductive, where are you? Repro. Where'd I go? Okay. Oh, there it is. What page? 749? All right, 749, folks. A repro. Or the other name for this lecture? Let's talk about sex, baby. Let's talk. That's right. That's what we're going to talk about for a whole day, man. A whole day. All the questions you always want to ask your mama and then ask her. I'm about to answer every one of them. Okay. Now, this is a very fun lecture. Why? Because the guys get to learn a lot about female sexuality and women get to learn a lot about male sexuality. Everybody swears they know a lot about sex. They don't. All right. There was an article written back in the 80s, and the title of the article said, "Men and women don't talk about sex enough." Now, at first face value, every time, what do you mean they don't talk about sex? Men talk about sex all the time. Women talk about sex all the time too. What he really meant when you read the article says that men don't talk about sex to the woman and women don't talk about sex to the man. Men talk about sex, but to their buddies. Women talk about sex, but their girlfriends. They're not talking to each other. What he was really making a point about was that sexual dissatisfaction is the second most common cause of divorce in America. So this is not a small topic, folks. It's a big topic because it's the second reason why most couples will divorce. First reason is what? Finances. That's the number one reason why she leaves. Sexual dissatisfaction, number one reason why he leaves. Number one reason why men cheat on their wives, sexual dissatisfaction. But if you ask them, have you talked to your wife about this dissatisfaction? No, never talked about it at all. And yet you've stepped out of your marriage and you never talked to your wife about it. For some reason, both sides feel uncomfortable talking about it. So the reason why a man doesn't want to talk about sex is because he doesn't want you to think he's trying to get some, but he is. He just doesn't want you to know that. And women don't want to talk about sex with a guy. Why? Because she doesn't want him to think he might get some, but he might. But she doesn't want him to know that. So both sides just play a game, folks. So my advice, if you think you're getting serious with a guy or a girl, at some point in time, you guys gotta sit down and talk about sex, whether you like to or not. Otherwise, it's gonna lead to a breakup or lead to something worse than that. All right? Because women are much more emotionally tied to sex than men. And if you haven't had a conversation, all of a sudden he leaves you. Number two, he thinks it's okay to have 7 other girlfriends. You think monogamy is part of this relationship. And you guys haven't had to talk about this? I think you better start talking, okay? Because otherwise somebody gets hurt. And then she's whining, crying, I don't know why you did this, I don't know why you did. You guys never talked. And then he's crying because she left, I don't know why she left it. You guys never talked. So somebody misunderstood the relationship and now somebody's badly hurt by it. I've seen both sides here at the past program, obviously. Okay, but either some guy got his heart broke or some girl got a heart broke, but that happens. All right. So the key is if you think you're gonna get serious with somebody, at some point in time, have a conversation. Now, a lot of girls are afraid to have conversation about sex with a guy. Why? She thinks, well, if she has a conversation, that might chase him away. If it does, then you know that's all he wanted. You got your answer now, didn't you? Stop being afraid to talk. Because if all he wants is sex, then of course then he will run. But at least now you know that's all he wanted. Versus you get emotionally involved. And then you find out he wasn't really interested in any long-term relationship. And now you got yourself emotionally involved in the whole relationship. Now you're hurt. And that's because you never brought up the topic early. Bring up the topic, folks, because at some point in time, you guys better talk about it. All right. So anyway, we had to do, I think it was 2 weeks of rotation in with sex therapists right here in Champaign. That was part of the curriculum when I was at U of I, you know, because it had just started hitting the literature at that time that doctors really did not understand sexual issues at all. I told you, doctors feel so queasy about sexuality. I don't know why, but they do. Okay, but that's why they want you to feel comfortable with sexuality, folks, because you're going to be talking to people about their sex lives. And as long as you look comfortable, they'll tell you everything that's going on, you know, because they don't see any judgment in your eyes. If you look like you're uncomfortable, it makes them uncomfortable. They don't want to talk anymore. Okay, so in my training, here's how my the pediatric chairman, how he defused that problem right away. It was all male residents. And he said, whatever hangups you got about sexuality, leave it outside the door. I don't even want to hear about it. And he said, you're going to be seeing teenage females or young women about abdominal pains. I better see a vaginal exam and I better see a rectal exam. I said, I'm not accepting any excuses for why it's not on that chart. If not on that chart, you're not here after this. That's it. And he said, oh, but wait a minute. I will accept 2 excuses. Everybody thought, what? 2 excuses? Yeah, okay. Number 1, she has vaginal or anal atresia, and I'm going to check. That means she doesn't have a vagina or an anus. Or number 2, you lost all your fingers since the last time I saw you. Yeah, so you can see it made the point. In the 4 years I was ready, now I never heard any time he had to scream at somebody for not doing a rectal or vaginal exam. So he got the message across to all the guys. Whatever hang up you got, leave it out. Because you're a doctor now, get it done. If you come out of a room and you didn't get the exam done, you cannot tell your attending, well, she wouldn't let me. That's your problem. Yes, it is. Okay. No, I'm talking about you, the doctor. Yeah. That's okay. That's up to you. The patient can always say no. Then you have to say the patient said no. And the chairman will walk in there and verify that she says no. If that's not true, you're fired. You're fired. That's it. He didn't accept any excuses. He didn't want to hear about it. Okay. Now, if the patient wants to be like Ms. Melissa says no, okay, fine. They don't do it. You don't force yourself on anybody. But the majority of times, 99% of patients don't say no if you approach them the right way. That's the point of this lecture. I want you guys to understand it. Muhammad Khan, you have a question?
Sir, I actually wanted to tell you that there's a treatment option for COPD and emphysema.
There's a treatment option for what now?
There's a new treatment option for emphysema and COPD.
And what is that?
They use these valves called the Zephyr valve.
Uh-huh.
And they put them in, they do program atelectasis of a portion of the lung.
They do programmed what?
Atelectasis.
They purposely go and collapse some of the lung?
Yeah, a portion of the affected lung. My brother, he's a pulmonology critical care doctor. He does.
Oh, I haven't heard about this. I didn't know they were calling Zephyr, whatever you just call them. But I heard about something like that. But what you're doing is, let's say you got a part of the lung that has a lot of bronchiectasis. That's alveolar collapse. Okay. Is there a way to just collapse that part of the lung so blood doesn't have to go there anymore? What you're trying to do is reestablish the normal VQ ratio. Otherwise, VQ mismatch is killing the person because you're still sending blood to an area with no oxygen coming across. That's a VQ mismatch. Yeah, but I never knew they would call them Zephyr anyway. I just read it in one article. That's all. Yeah, thank you though.
Sure, I just wrote it in the thing so you can look it up.
Okay, yeah, in case somebody wants to look that up, that's good. All right, Adam, you have a question then, Mabel? That's what they're doing, yeah, because once the alveoli get digested, that's dead space now. That means there's blood going across that space. That's a VQ mismatch. And that makes your hypoxia even worse. And so it makes it real hard for the person to breathe. So if you can shut that area down, the blood will only go to the living areas. VQ match will go back to normal. Yeah. All right, Mabel, you had a question?
Yes, sir.
What's your question?
So, yes, sir, please. I just want to ask the female version of what they call it again. What's this medication again? Is it Viagra? Does it have any side effects?
Yeah.
Does it have any side effects?
Does it have any side effects?
Yeah, for females, yeah.
Same side effects it is for males.
Okay, thank you. And also, I also want to know, is there any side effects for bariatric surgery?
Bariatric surgery?
Okay, yeah.
Yeah, of course there's side effects with that. I gave you guys some. I said early on, some of them just have nausea and vomiting. They can't go back to eating what they normally eat. So nausea and vomiting was number one, and then perforation was number two. That's acutely. Long-term, malnutrition, vitamin D deficiency, iron deficiency, calcium deficiency were the big ones. Dumping syndrome, I explained to you guys. All right. Small intestinal bacterial overgrowth, SIBO syndrome is that empty pouch that, from the Roux-en-Y procedures. So all these were talked about in GI, Mabel. All right. So yeah, no problem. So let me just set it up here. Let me go to this. Menstrual irregularities, folks, is the number one reason why an adult woman goes to see a doctor. Imagine if you're a male doctor and you don't know anything about the menstrual cycle, and that's the number one reason why she keeps calling your office. Well, that happens all the time, folks. And what do male doctors do? Try to talk over her head like she doesn't understand that you don't know what you're talking about. How do we know that they know that the doctor doesn't know what he's talking about? Because every time a female physician sets up practice in a town, all these women run to her, which tells you they've been dissatisfied with the male doctor for years. They just want to be respectful. But as soon as a woman comes, she's full in less than a month. She has more patients than she can take care of. They found out nationwide. Every time a female sets up practice in the town, why do you think most of them come up with a name that includes women's health? Because they know a lot of women come running. All right, because that way, at least in their mind, she goes through Mr. Cycle every month. She at least understands what I'm going through every month. She can answer my questions. So for the fellas, please listen when I go through Mr. Cycle in the morning, because you're going to get a lot of phone calls and they're going to ask you, well, why is this happening? And you can't say, well, let me look that up. I'll get back to you. They're not going to hang on. That means in their mind, you don't even know about it. So they'll just go to somebody else. You just lost a customer though. I told you, women are the best customers in medicine. They're best payers, everything. You don't want to lose them. But if you can answer their menstrual questions, oh my God, they love you to death. All right, they love that. Because every time they call you, you give them a simple answer. It makes sense to them. It's all good. Yes. Against?
No, they have the highest rate of bias by patients against them in the field.
So female urologists, the highest rate of bias by other women against them. By male patients against them. Right, okay, yeah. So males prefer to go to male, women prefer to go to women. That's just normal. Remember, empathy. Somebody who knows what you're talking about always makes you feel better, okay? Look at this though. The number one reason why a teenage female misses work or school is dysmenorrhea, heavy menstrual bleeding. There it is. That's where we're going to take it. You're going to learn about Dr. Nagel in the morning. All right, folks, you've been empowered. Enjoy your evening. All right. How you doing, Ms. Jolita? You doing okay?
Oh, I'm so lost in translation.
Take your time and keep going through the notes. That way, any questions you have, just feel free to ask.
I will try.
How about you, Veronica? That's a big horse you got standing next to you. What's the dog's name? That's a big dog, man. Veronica, you there? Yeah, she took off already. All right, see you guys in the morning. Oh, there.